Means even in your prosthodontic treatment, the baseline for a healthy prosthodontic replacement is you have to have a healthy periodontium of the adjacent teeth. The fact that the basic principle of FPD, the Antes law, is not given in any prosthodontic terms, it is given in periodontal terms. It says the periodontal area of the supporting structure should be whatever it is. So that means the baseline of dentistry is the healthy periodontium. So whole dentistry treatment revolves around if you have a healthy periodontium. You cannot do any treatment in any department if the periodontium is unhealthy. So that means if periodontium has to be healthy, the branch periodontology has to be surviving, and dentistry just cannot survive without periodontology.
Start. Good morning everyone, this is Dr. Vishakha Grover. I am a periodontist by profession. Periodontist is a dentist who specializes in the care of gums around your teeth. In our country, gum diseases occupy the major proportion of oral health problems. Almost 90 to 95% in every 100 people are suffering from gum diseases. The worst part of these problems is that these are very silent or do not causing any signs at the early stage. Only in advanced stages, the patient may suffer from some pain, bleeding, or some unsightly appearance of the teeth. Recent research has highlighted that consistent inflammation in oral cavity may lead to other body problems also, for example, cardiovascular diseases or diabetes, etc. So this new dimension has been added to gum diseases, that they may act as general body health risks as well. So maintaining good oral hygiene with twice daily regular brushing is the only way to avoid these problems. But as a periodontist, I would like to stress upon you the importance of regular visits to the dentist for checkup. Because whatever best practices we are maintaining, these visits will give a chance to the dentist to check on to how well you are maintaining your hygiene, and if there are any lapses, they can be made up. Even any new diseases, caries or gum disease, any new issues coming into the oral cavity may be detected at an earliest point of time and can be managed thereafter. So, maintaining good oral hygiene coupled up with the regular dental visits, in my view, is probably the best and the most sure-shot way of preventing gum diseases and maintaining good oral health. I don't know when did you last visited your dentist, but today I will really ask on that book for your next appointment. Thank you.
Hi. As we all know, the periodontal disease is one of the integral part in dentistry, and the survey shows that 95% of the population are affected with periodontal disease. Here, we as a periodontist are taking an effort to get into the masses of the population to create an awareness among the general public and to create an impact as well as on the treatment line and to create an impact on the urban as well as the rural population in the coming years. So, we are creating an attempt as the President-elect of Indian Society of Periodontology to have a proper screening, charting and a treatment line for the patients and to have a benefit for them as such. Thank you.
Friends, periodontal disease leads to loss of teeth, and this loss of teeth has to be rectified by way of placing artificial teeth. And who else better than a periodontist would be able to restore the teeth, and this by way of dental implants. Dental implants has been aggressively being practiced these days into dental clinics, and periodontist is one of the best specialists in terms of practicing implant dentistry because he knows the details nuances and also the structures which are involved into placement of dental implants. So whenever you are experiencing dental loss or tooth loss, better go to a dental surgeon and go in for dental implant therapy. Dear friends, on behalf of the Indian Society of Periodontology, I wish to inform you that according to the data of WHO, we have 80% of our population which is affected with some or the other sort of periodontal diseases. Periodontal diseases are gum diseases and which increase in severity and lead to periodontitis, which ultimately leads to tooth loss. So, if we consider the huge population, if we consider our country as the second most populous country of the world, then definitely it's a huge healthcare burden over us. And if we consider the clinical data, it reflects that very less number of patients are being treated for periodontal conditions into our clinical practices. And this is basically because of the fact that we devote less time into diagnosing these conditions. Since these conditions are asymptomatic conditions, there is a great possibility of them being missed upon in the initial examination. So, I would request all of you to devote adequate time into diagnosing these conditions at the initial screening visit, so that we would be able to provide a healthy periodontium and a healthy masticatory apparatuses to our patients. Thank you.
Aesthetic and smile designing is incomplete without the proper care of the pink. The judicious balance of white and pink is a prerequisite for aesthetic periodontal outcome. The various aesthetic periodontal surgeries, various aesthetic periodontal treatments like periodontal plastic surgery and even the newer advances in periodontal microsurgery are very handy in comprehensive aesthetic periodontal care for the patients.
India happens to be the diabetic capital of the world. India also has the highest prevalence of periodontal disease. Of late, the literature is flooded with the correlation of periodontal health and the systemic health. There have been enough evidence everywhere around the world, with conferences, with workshops, with consensus meetings happening together, wherein it has been almost conclusively said that a poor oral health, a poor periodontal health can actually worsen the systemic health as well. So within the Indian perspective, Indian Society of Periodontology takes the lead, takes the charge, and makes sure that all of our
One of the points regarding gum disease is that it is entirely preventable. So if you visit a dentist regularly and get all the regular checkups and treatment done, you can have a teeth that will last for a lifetime. You need not wear any false teeth or dentures, and you can chew happily ever after and have a well balanced diet. The key to it is that you must have good oral hygiene practices, clean your teeth regularly, and visit a dentist and do all the treatment that is recommended by a dentist.
Now, we have our branch is periodontology, and basically it deals with the structure which is called as periodontium, which in common terms, which means the structures which support the teeth. Now, a structure which supports the teeth means that if tooth has to remain in oral cavity, the structure have to be in a healthy state. Now, we always, as you know, concentrate on treatments like orthodontics, that is treatment of malocclusion, root canal treatments. We have FPDs, RPDs, replacement of all these, missing teeth, which gets concentrated too much. But if we go to the background of this and we realize that, can we have an orthodontic treatment without a healthy periodontium? After all, movement of teeth is just based on bone and periodontal ligament, which is a part of periodontium. Have you asked any endodontist, would they do a root canal treatment in a mobile tooth? They will not, because after they see an X-ray and they see the extent of caries, the next thing which they see is the amount of support which is present. Take a tooth to them, which is mobile, and the thing they will ask is whether the prognosis is good or not, whether we should do a root canal or not. So that means if you have to have a successful root canal treatment, the baseline is a healthy periodontium. You give RPDs, you give FPDs. Can you give a FPD on a tooth where the adjacent teeth are mobile? No. Can you give a RPD when you have the adjacent teeth mobile? No. So that means even in your prosthodontic treatment, the baseline for a healthy prosthodontic replacement is you have to have a healthy periodontium of the adjacent teeth. The fact that the basic principle of FPD, the Antes law, is not given in any prosthodontic terms, it is given in periodontal terms. It says the periodontal area of the supporting structure should be whatever it is. So that means the baseline of dentistry is the healthy periodontium. So whole dentistry treatment revolves around if you have a healthy periodontium. You cannot do any treatment in any department if the periodontium is unhealthy. So that means if periodontium has to be healthy, the branch periodontology has to be surviving, and dentistry just cannot survive without periodontology.
Start. Good morning everyone, this is Dr. Vishakha Grover. I am a periodontist by profession. Periodontist is a dentist who specializes in the care of gums around your teeth. In our country, gum diseases occupy the major proportion of oral health problems. Almost 90 to 95% in every 100 people are suffering from gum diseases. The worst part of these problems is that these are very silent or do not causing any signs at the early stage. Only in advanced stages, the patient may suffer from some pain, bleeding, or some unsightly appearance of the teeth. Recent research has highlighted that consistent inflammation in oral cavity may lead to other body problems also, for example, cardiovascular diseases or diabetes, etc. So this new dimension has been added to gum diseases, that they may act as general body health risks as well. So maintaining good oral hygiene with twice daily regular brushing is the only way to avoid these problems. But as a periodontist, I would like to stress upon the importance of regular visits to the dentist for checkup. Because whatever best practices we are maintaining, these visits will give a chance to the dentist to check on to how well you are maintaining your hygiene, and if there are any lapses, they can be made up. Even any new diseases, caries or gum disease, any new issues coming into the oral cavity may be detected at an earliest point of time and can be managed thereafter. So, maintaining good oral hygiene coupled up with the regular dental visits, in my view, is probably the best and the most short way of preventing gum diseases and maintaining good oral health. I don't know when did you last visited your dentist, but today I will really ask on that book for your next appointment. Thank you.
Hi, can you guys hear me?
Yeah, of course. Good morning.
Hi, good morning, Doc.
Good morning, Dr. Roghunath.
Hi, how are you guys doing?
Great.
We shall go in 5 minutes, right? Or we're
Yeah.
ready to go?
Yes.
Yeah. We are good to go in around 4 minutes.
4 minutes. Okay, do you want to do my share screen or not yet?
We are the chairpersons. I think the backend team.
The technical team is going to handle it.
Yeah.
You can share your screen, sir.
We can have the introduction first, madam, then we can go ahead with share.
Okay.
How many people we have online at this time?
We'll just get the data from the tech end and let you know. But yesterday we had at no point in time less than 900 logged in into our main auditorium.
Yeah, okay.
We were pretty much the same number, but the tech team will just let us know how many are logged in.
What time is it now in India?
It's almost 9. We are 3 minutes short of it.
Oh, okay.
You're in Lebanon right now?
Yes, it's 6:30 a.m.
Oh, good morning, sir.
I usually wake up at 5 every day, so not bad.
Really?
How are the COVID conditions over there?
Not bad, you know. I guess almost all the population get COVID. That's why we get to the herd immunity. So,
But you want it to be anyone else than you only.
how is it now in India? Things kind of calm down or still?
Bit better, not very good, but better than what it was last week or last week.
Hospitals are still overwhelmed?
Yeah.
It's getting better gradually.
Oh,
We're
okay.
seeing more empty beds.
Yeah, that's
I don't know
crazy.
if it's only the government figure or it's actually happening. That's
Yeah.
it.
So no more hybrid meeting yet, huh?
No.
Not till next year.
Are you all vaccinated over there?
Yes, I already did the Pfizer vaccine back in my second dose was in March, April. They started with the dentist and the physicians. So you feel a bit less of pressure when you do it, but people are not too responsible here. So
Everywhere.
yeah, it's
All types of people are there.
social issue, you know. Yeah, yesterday I was at the dinner at the restaurant. Nobody had a mask. No one. And
You were brave enough to venture out.
I'm vaccinated and I'm still wearing my mask. I mean, this is crazy. You know.
But the courage to go to a restaurant.
You were brave enough to venture out.
Yeah, I see. The thing is, I asked my patient one day, come in, so how is it going with the COVID? And almost 70%, I already got it. I was like, okay, thanks.
So we are ready to go in a minute's time, sir.
All right, sir. Should I share the screen or not yet?
Not yet. After the introduction, I think.
Okay.
Yeah.
Sorry.
Yes, Jilu, you can go on.
A very warm good morning to one and all. Today we are starting an yet new beautiful session chaired by Dr. Nifya Pandit and Dr. Ashish Nichani. Dr. Nifya Pandit was a 1993 graduate from SCB Medical College, Cuttack, and Dr. Nifya completed her MDS in periodontics from Government Dental College, Ahmedabad in 1998. She has received the Best Graduate Award for excellent performance in the 4 years of graduate program by the ICDRO in the year 1993. She is also the recipient of Colgate Palmolive Award for highest marks in the subject of periodontology. Dr. Nufia is presently working as the professor and head of the Department of Periodontology, DAV Dental College and Hospital, Emna Nagar. She has 20 international and 34 national publications and has been a keynote speaker at more than 50 firsts at national and international state levels. Dr. Nymphia has conducted 6 workshops on surgery in periodontics at Yamuna Chandigarh and Nepal and Gurugram in West Bengal. She has authored a book titled Concise Periodontics and written a chapter in the implant course book conducted by IGNO as well as a chapter in the book on bone regeneration. Dr. Nymphia Pandit is the current president of Indian Society of Periodontology and in the editorial board of Journal of Indian Society of Periodontology and many other national journals. She has been at different posts in the IDA Yamunanagar branch, including president in the year 2012. Our next person, Dr. Ashish Nichani. Dr. Ashish S. Nichani graduated from STM Dental College and Hospital in 1996 and went on to complete his master's in periodontics from the same institution in 1999. He is an active practitioner and maintains a practice that is limited to the field of periodontics and implanted dentistry with emphasis on regenerative periodontics. He was the editor of the prestigious Journal of Indian Society of Periodontology from the year 2010 to 2016. He was the treasurer of the Indian Society of Periodontology also from the year 2016 to 2019 and an executive committee member of Indian Society of Prosthodontics Restorative Dentistry and Periodontology. He is also a member of the Asia Pacific Society of Periodontology and a life member of Indian Dental Association and has been conferred the prestigious fellowship of the Parade Fortune Academy, USA. He is a reviewer and an editorial board member for various national and international journals. He is an undergraduate and postgraduate examiner in various universities in India, and his active interest in continuing dental education has seen him lecture on several courses and conduct various workshops at both state and national levels. He is currently working as the professor of periodontics at Oxford Dental College and Hospital, Bangalore, in India. I wholeheartedly welcome Dr. Nymphia Pandit and Dr. Ashish Nichani to chair this session. Now,
Thank you, Dr.
over to
G.
chairpersons. Thank you.
Madam, you're mute.
Mute, madam. Please unmute yourself.
I have this proud privilege of introducing Dr. Alain Ramanos, and he is a very well-known figure, and I have seen him in many conferences that we have conducted over here and conventions, and he seems to be a very familiar figure with all of us, and of course he's very well-known and he's a renowned implantologist and a well-known periodontist, but you seem to be a part of us only since you have been a visitor to this country for so many years. And he is an assistant professor at the postdoctoral program of periodontology at the Lebanese University and is a visiting assistant professor at the University of Alabama, Birmingham. Dr. Ramanos received his DMD from the Free University of Brussels, Belgium, his certificate in AEGD, Advanced Education in General Dentistry, certificate in the periodontics and master's in science from University of Alabama at Birmingham, USA. Dr. Ramanos is a diplomat of the American Academy of Periodontology. He is a fellow of the International College of Dentistry. He is the director of the periodontics course at the Lounge Dental Educational Center, a continuing educational center in Lebanon, and is an active member of the American Academy of Periodontics, the Lebanese Dental Association, and the Lebanese Periodontal Society, where he occupied a position of general secretary. Dr. Ramanos loves teaching and lecturing that we can see and has conducted more than 167 seminars and courses on the soft tissue, periodontics, and implant surgery nationally and internationally. He is the founder and director of Lounge Dental Clinic, private practice limited to periodontics, aesthetic, and implant surgery in 3 locations, Antilles and downtown Beirut and Tiwayar, Lebanon. I welcome you, sir, to this course, and I welcome all the delegates for this wonderful session that we are going to have now. Thank you.
You guys can see my screen, right?
Yes.
Yes, sir.
Okay. Thank you, dear friends, for this nice introduction. It's a great pleasure to be back to India virtually this time. I always love to start with this slide. It's one of my favorite quote because we all have a love and passion for this dentistry job. You know, this is my happy place. This is where I like to be most of my time, and I'm always accused by my wife that I love my job more than I love her. So, which is, by the way, she's sleeping now. Sometimes it's true. Uh, you know, I am here with my team. I'm a part of a practice where we work as a group, and most of the cases that I will share today are done by this grateful team. I'm really fortunate to be with I call them the dream team. And you know, like the movie, I have these doctors, they call me, you know, like Charlie's angel. So this is like Dr. Romano's angel. You know, probably I've been to India 5-6 times, almost every other year. Since 2012, I've been to Goa, been to Mumbai, Nagapur, New Delhi. So, and every time I go, I spend a few more days actually visiting the lovely country. I love the people. I have so many friends. One of my classmates, actually at the University of Alabama, that we spent 3 years, Ashwin, he is now in California. You know, probably this is the last time I was in 2017. So it's time to go back, I guess. If COVID didn't hit, I would probably be back in last year or this year. You know, I'm almost Indian when I wear the clothes and, you know, feel part of the culture. I love the food, not too spicy though, but I still love your guys' food. So I'm really happy to be here this morning. It's 6:30 a.m. my time. So I hope you guys already had your coffee. Today, I will share with you the topic of gummy smile, and writing an article on the combo technique. It's not been published yet, but hopefully it will be published soon. Let me take you back to 1999. This is when I was doing my perio training. And you know, when you're a resident, you know, you're so excited to do surgeries. And I got Maria, this patient, came in with a chief complaint that she wanna treat her gummy smile. And you know, when I saw Maria, and I was like, you know, all excited, I was like, yes, we can fix this. And she said, well, how are you gonna fix it? And I said, well, we're gonna do an aesthetic crown lengthening. You know, I was just in the program of perio, and I was doing my perio training, and I was like, you know, this is the best thing that we can do, and you'll be fine. No pain, immediate results, and you'll be highly satisfied. So I took Maria through the surgery with the, you know, flap elevation, osteoplasty, ostectomy, you know, the things that we do when you're a student. We teach you everything well, take you back to the real positioning of the gum. And then this is the case after a few months, before and after. You can see a little bit, there's more exposure of the tooth length and height. And then, you know, when you bring back Maria and you look at the picture, what do you guys think virtually? Do you think this is a good result? If I was in the room, people would say, yes, it's a good result. But this is not her smile. This is the picture I took when she wasn't smiling, really, a spontaneous smile. This is her smile. And then when you look at the case before and after, and then Maria, she was like, well, you know, we did the surgery, I paid money, but I'm still gummy smile. And I was like, yes, you know, this is not teeth related issue, this is more the jaw, you know, and I start, you know, dancing in front of this patient, but I can see her, you know, not too happy about this. So, I overpromised this case. I overpromised so that I can fix it. And actually, all what I did took her from 9 to 7, which is just an improvement of 23%. But Maria wanted 100%. She didn't want 23%. And the communication was an issue because, I was too excited to take her through surgery, but the end result was a complete failure. Another one, and this is recent. I got this patient probably 4 years ago now. She came and she was seeking treatment for her gummy smile. And I told her, listen, your case cannot be treated with a crown implant. And she went to another doctor and he did for her this. And look at the disaster. She came, I told her, you're not a case for crown lengthening, you're a case for other things. She still went to someone else, and look what he did. And this is, we're talking 2019. We're not talking 1999. So today we have guidelines, and look at the disaster that this patient went through. So the number one mistake in dentistry, my friends, is always come back to diagnosis. You do the right diagnosis, you get to the right treatment. You would go to the wrong diagnosis, you go to the wrong treatment. So remember this, whatever we do in our job, in our profession, it has to come down at the end of the day to the right diagnosis, because this is what will lead you to the adequate and correct treatment plan. These are 3 patients. All of them, the 3 of them are gummy smile, but they're not the same gummy smile, and probably not the same etiological factors. And when you look a little bit, you dig deeper in these smiles, and you can see that there's a difference in these 3 different gummy smiles. And when you look at even more in details, you see that some patients, they have asymmetrical smile, not just symmetrical. So we cannot take, look at the gum alone, but we have to take a look at the whole smile, including the lips, including the gum, of course, and the teeth positioning. And you have to take this whole smile and incorporate it in the facial aesthetics. And you start to look at these things when you start working on the facial aesthetic. I started doing Botox and filler back in 2009, 2010. And then you start to see that, there's a customized smile for each patient. So the question is, let's start by the basic. What is the definition of gummy smile? And how you classify these gummy smile? Well, if I'm in the room now of 1,000 people in India, I would say out of the 1,000 people watching us today, they're probably 100 to 150 of them, they have gummy smile. And gummy smile is when you see at least 3 millimeters of the gingival display and the full entire crown. Most people look for a medium smile line, the Julia Roberts smile line, where you can see just about 1 millimeter of the gum and the papillas. And the low smile line, which is me, I have a low smile line, where you don't see any of the gum. So here, this is the best cases to do immediate implant, to do anything that you want in these patients. So the question number 2 is, are all gummy smile the same? Well, I would say there's 3 different classification. You have the mild, you have the moderate, where you can show 5, 6, 7 millimeter of gingival display. And then you have the severe, where you show more than 8, 9, 10, 15, 20. So these are really severe cases. And therefore, the treatment should be different. Not just the treatment, but the etiology, the reason why these patients have gummy smile. We always rely on videos. Today's treatment for gummy smile, you cannot just look at the picture, because when you take the picture, you don't know if the patient is smiling politely or is smiling in a spontaneous way, or he's just, being shy. So the dynamics of the smile are completely different. So we have to really record these by taking videos and trying not to tell the patient the same joke, different jokes. Because every time I tell them the joke and I look at my assistant, it's like, I've heard this for 1,000 times now. So, you know, we have to really make them smile in a way where we can take a video so we can analyze these smiles later on. And in the literature, there's this one classification that talks about a classification of smiles. Well, you have the anterior gummy smile. You have where you just show gummy smile in the front. You have the posterior gummy smile where you see just in the back, mixed where you have anterior and posterior, and then you have the asymmetrical smile. I would say anterior gummy smile, not too common, but there's still a lot of bunch of numbers. Posterior gummy smile, depending on the muscles, some patients, they have hyperactive muscles that pull the lip on the side more so you can see the gummy smile. Most people, I would say, they are mixed between anterior and posterior. And, you know, asymmetrical gummy smile are really challenging. This is really super challenging cases. But there's a lot of people that they have this asymmetrical smile and they don't know where to go. Because, you know, if you break your arm or you break your leg, where do you go? You go to orthopedic surgeon. But you have asymmetrical smile, where are you gonna go? To a plastic surgeon or to a dermatologist or to a dentist? This is our job. This is our field. This is where we're supposed to shine. We're supposed to shine in this field because this is what we do every day. And you know, some patient, when they have asymmetrical smile, you have to record the right side, the left side. So here's this patient, she has a 10 millimeter gummy smile on the right side, and here she has a 6 or 7 on the left side. So how are we gonna manage this? Can we get her back to a normal, regular, symmetrical, harmonious smile? So the question number 2 now is, how important is this? Is this gonna influence the facial aesthetics? And I got this common question, at which age we can do these procedures? Well, if you look at this survey at the American Academy of Cosmetic Dentistry, smile is ranked number 1 now. You know, 10, 15 years ago, it used to be the eyes. The most important feature of the smile, people will look at the eyes, and this is considered to be really the number 1 important criteria for aesthetics. So now I think smile is becoming number 1. When you ask people if they're willing to invest, yes, all of them, they are willing to invest 60%, if they have the money, of course. And other people, they judge people. So just by looking at the first physical contact is you consider them if they are attractive or not based on their smile. So smile is becoming today a big integral part of our daily society. And when you look at the ads, billboards, people talking about shampoo, but you see somebody smiling. So the focus on the smile is becoming bigger and bigger. This is another study that was published at the University of Washington back in 2014. And they look at Photoshop pictures. So they gave trained and untrained people, and they asked them, just by looking at Photoshop pictures, and they asked them 5 questions. Who do you think out of these people is trustworthy? Who do you think is intelligent? Who do you think is more friendly, attractive, self-confident? So you get 60 people to judge pictures based on pictures and ranking the gummy and non-gummy smile. And what they found, of course, they found that non-gummy smile patients are more friendly, they are more attractive, they are trustworthy, intelligent. Can you believe this? Intelligent. So based on a photo, people are judging other, and guess what? Gummy smile was an issue, even though a lot of people, they say, no, it's not bothering me, I'm okay with that. Wrong. If you go to the literature and you look at the studies and the impact that it has on the patient's personality, it's there. And today we have a new technology. We're going into digital in all different aspects, implant, veneers, and we apply this technology. We apply it in our treatment. So today you can show the patient digitally how they will look like before they get to start the treatment. So just by you know, we used to use it for veneer simulation by doing the digital smile design, which is fine. And from this, we moved to patients who have gummy smile. So if I do all the measurements beforehand and I know how much the patients are showing and I know how much I can gain by each of the procedure, I can simulate and let the patient know beforehand how they will look like. So there will be no surprises like the case that I showed you this morning when we started. So question number 3 is, what is the etiology of a gummy smile case? Well, it could be a bone problem, which is, you know, the orthognathic cases. It could be a gum problem, or it could be a short lip or hyperactive muscle. Let me tell you, the middle case, this one, she used to go to a dermatologist and he used to give her Botox for her gummy smile, which is wrong because this is not the case for Botox. And let me show you this one. This patient, she was referred to me by a dentist to do crown lengthening. So I did treat her, but of course not crown lengthening, sent her back to the dentist. And I was like, wow, the crown lengthening procedure was super nice. But again, problem is the diagnosis. We have to identify the diagnosis. Why this patient have the gummy smile? What's the reason? And then go and treat the etiological reason. Let me show you this recent study, basically 2018, when they looked at among the patients that they had gummy smile, what was the reason why the patient have gummy smile? And they looked at 56 patients, and what they found that there's two major reasons. One, the hyperactive upper lip, 45%, almost 50%. The active passive eruption, which is excess tissue of the, you know, you have excess gum that usually require aesthetic crown lengthening, it's 20%. And the patient who has combination of aesthetic crown lengthening and hyperactive lip are 34%. So we as a periodontist, when we were trained to treat these patients by doing aesthetic crown lengthening. So 20% of the people who had gummy smile require our expertise. But what we're gonna do with the 80? You know, we have 80% that they need our expertise, and we cannot just fix it by doing a gum lifting. So when you look at the numbers, and then from seeing patient day after day, years after years, you come to realize that, you know, these patients, they need help, and who else can help them if it's not us? So this will kind of open up our eyes that there's a different treatment modalities to manage these patients' concern. Because 80% of them, they have a two-reason issue, one related to the gum and one related to the lip. So if you have a case, a bone case, a jaw case, of course, these cases, we advise them early on to go ahead and do orthognathic surgery in combination with an ortho treatment. But my experience, and I don't know how is it about you guys, 90% of my patients, they refuse to go to orthognathic surgery. If you have inadequate crown exposure, or if you have excess tissue, too much tissue, teeth look short, well, of course, these cases are indicated for to do crown lengthening. And if you have a hyperactive lip, or you have a thin lip, or you have excessive lip removement, most of the time it's a combination of short lip and hyperactive lip. Well, these are cases that needs to be treated by using Botox, filler. Some patients, they do muscle control therapy. There's so many different modality of treatment nowadays. A lot of things are on the market, but we have to identify the reason. And the reason here is the lip, not the gum. But my experience, I can tell you most of the time, I would say, you know, 7, 8, 9 times out of 10, it's a combination treatment. It's a little bit of gum, a little bit of lip, a little bit of active muscle, a little bit of bone, And we need, therefore, to find a way where we can combine all these treatments to treat these patients. So the question now, number 4, is how we treatment plan the gummy smile case. And by looking at first identifying the etiology, the second question becomes looking at the tooth exposure, how much tooth length we have. And when we go back to basic anatomy, dental anatomy, the question becomes, what is the normal crown dimension? We're talking averages, of course. How much the length of a central incisor should be? 8, 9, 10. So, you know, we go back to anatomy, and we know from the literature, going from Stewart's started study and others, we know that the central incisor on average is about 10 millimeter. And there's always this golden proportion rule between the length and the width. And then when you look male, female, it's almost the same. And when you look at the numbers, whether the width is 8 or 8.5 or 9, number 10, you see it in the 3 categories. So that's why we always teach our student that on average is 10, but it could be 12 and it could be 9. So we're talking averages. So when we look at the tooth height, the question number 2 becomes, well, other anatomical landmark. Where is the CJ? How can I identify the CJ? How much attached gingiva do we have? How much do we need? Do we need 2? Do we need 3? And then what's the crown to root ratio? Can we do crown lengthening and not compromise the tooth structure? So many questions that we have to answer before we jump and take the blade and start cutting these patients. So we have to really do our study beforehand and, you know, gathering all this data from the patient's mouth. Of course, there's a lot of tools to help you out, but these are tools, but we have to know the basics. So we have to really look at the CJ, we have to look at how much attached gingiva these patients have, take x-rays, look at the root anatomies. So once we gather all this, I will take you to the combo treatment. And what is the combo treatment? And, you know, based on the numbers that I showed you and the facts that I showed you, you know, most patients, they need not just the crown lengthening procedure. They need the crown lengthening procedure along with some addition to this, which is in this combo treatment, is the lip and the hyperactive muscle. So this is Jennifer. And Jennifer, she's not happy with her smile. She did ortho, and she wasn't an orthodontic case at the time. Finished the ortho treatment, and major concern, she was still gummy. The ortho did improve, and all the orthodontic studies improved the gummy smile by doing some intrusion and so on, but this is limited, maybe 2-3 millimeter of enhancement of resolution of the gummy smile. But what if Jennifer has more than 2? And when you look at starting to analyze, and I'll show you how we analyze the study. So we take videos, we take photos, and then we measure. While she's smiling, we have my assistant taking the ruler and see how much showing she's showing. So here she's showing 5, on the right she's showing 7, and then we look at her lip, we look at her teeth, and then we start looking at the dimension of the teeth, how much length we have, how much height, and then we try to identify the CJ. We have many techniques to identify it, and then we gather all these numbers, and then we start our treatment plan. So we tell Jennifer, you know, Jennifer, you have between 6 and 7. What are your wishes? How much do you want of resolution? And I can tell you, most people, they say, well, I want 0, or I want 1. So if she wants 0, which means I need to get this number 6 to 0. Now, how I'm gonna get it to 0? Remember, question number 2 was what? What is the tooth dimension? So we look at the teeth dimension. The crown width height is 8.5. And how much I can get her if she's a width of 8.5. On average, I can give her 2 to 2.5 by doing just a static crown antennae. So if this patient wants to stop on just doing a static crown antennae, we can tell her upfront that I can give you a resolution of, 40%, 35, 40% of the whole gummy smile. Are you happy with 40%? And I can tell you, most patients, they will say, no, I need more. I want more. So if they want more, we know from the studies, and I don't have time to share with you the whole studies on fillers, but if you do some research on fillers around the lip, if you give a bit of a volume, a bit of a contour, we can drop this lip on average 1 to 1.5. So if she is 6 and I remove 2.5 from the gum, and then I remove 1 to 1.5 by doing the filler, and today's filler, they can last at least a year. So how much do we have now? We have 3.5 to 4.5, I would say, filler, but she wants 0. So how I'm gonna finish up with the 0? Well, we're gonna add some Botox. Botox, we know from the studies of Botox that each unit of Botox that you give, it will drop the lip by 1 millimeter. So each unit, 1 millimeter. So if you do the math now, we have 2.5, 2.5, 1, and this, if you addition all this, this is how you will get to 0. So now you do the study, you sit with the patient, you talk to her about this, and then when she says yes, you go for the procedure. And the combo treatment is when you do the 3 of them at the same time. So you do the crown antennae, take her back to the normal positioning of the gum. We switch her back up, and then while she's numb, I did all my numbers study beforehand. I have on my tray exactly how much Botox I'm gonna use. I know exactly how much filler I'm gonna use before even I start. And I take Jennifer through the procedure by
shine bright like a diamond. Shine bright like a diamond. My light, beautiful thing. I chose to be happy.
So while we're doing the procedure, after we finish, so we give her a bit of Botox, filler in the lips, just to give her more volume. And we realize something, that when you do Botox, a lot of patients, they lose the red lip. So we rarely do Botox alone. It always has to be combined with fillers. So we do all the measurement. We know how we're gonna proceed. So we give her more defined anatomy for the philtrum. We do the contour. We do the uplift of the upper lip. All this patient not experiencing any pain because she's numb. She did the crown antennae, and we're just combining the 3 of them. Once we finish with the filler, we go to the Botox. We can do 1 side, you can do 2 sides injection, depending on the technique, depending on the case. And all this in 5 minutes, less than 5 minutes, you're done with the Botox and the filler. And you spend, and this is Jennifer's smile afterward. This is the healing. This is 6 months, supernatural smile, not overdoing the filler. And when you look at the teeth before and after, we just gave her back to the regular anatomy. And when you look at her smile, again, we were able to give her back a smile where she feels comfortable. Not too fancy with the lips, just the minimum, because I like natural lips, not over like the duck lips. And with the filler, you can always add, you can always come back and do progressively the treatment. And when you look at this, the impact that this has on Jennifer's face, now she's feel more comfortable. Of course, the beginning, they are a little bit, they feel like, you know, they're forcing, they have a fake smile. But once she gets used to it, this will start to integrate her facial aesthetics. And how do we realize this? We always have to take videos. We always have to compare the before and after, not just by taking photos, but you want to see the dynamic of the smile for these patients. So another one, Tina, she's a happy face, always smiling, and she's not too happy with her gummy smile. Again, thin lips, and most people that they have thin lips, what they do, they start to increase the lipstick to give it the illusion of having a bigger lips. So when it comes to diagnosis, well, you can tell that this is a lip and gum issue. And then, of course, now we still use the blades. We use a little bit of laser just to finish up, to do the finishing of the cuts. Then we do the same as I showed you before, osteosurgery, before, after. And then while she's numb, we suture up. We always put the sutures on the lingual side, so no sutures on the outside. And while she's numb, we do the filler. And so here we do all the measurements, and again, a bit of a Botox based on the study that we did, like Jennifer. So probably 1 unit on each case. We start with the philtrum. So we do the philtrum, and this will give you the diamond shape of the lip. So the combo treatment is basically doing the three things: doing the aesthetic round lengthening, doing the Botox, and doing the filler. And 3 in 1, all in one time, all in one appointment, zero pain because it's the same anesthesia. And we have to know the anatomy, and we have to really discuss all this with the patient, because you have to have the same expectation as the patient. And really, you cannot just look at teeth or gum. Today's job, our job, is to look at the whole smile. And the perioral area, this is our field. And you look at this is bloody, but amazing, patient doesn't feel anything, zero. I've done lips after other doctors, plastic surgeon and dermatologists. These people, they cry when they do the filler at the plastic surgeon. Why they cry? Because, plastic surgeons, they don't get the patient numb. Most of them, they have no time. They just want to do it quick. Boom. So look at this. So this is Tina, just the day zero at the time of the surgery. You can see already the lip volume. And this is after some healing time. And this is her smile after a few months. And then when you look at the Tina smile, she's now almost zero gummy smile. Teeth-wise, there's not much of a change in terms of, we just brought it back to the position where it's supposed to be, very anatomically respected aesthetic round lengthening. And then when you look at her smile, she's more balanced in her smile. And when you look at, the symmetry and the proportion between the teeth, the gum, and the lips, you can start to feel that this is more proportional, more friendly, and fitting Tina's face. And then when you look at the lips, again, my experience with the lips patient, they always want more. And I always tend to bring them back. Let's do it progressively. So you can always add. But I like natural lips. And here, this is, to me, this is, nobody can tell that you already had fillers. In Lebanon, the culture is now to have the upper lipper bigger than the lower lipper, where the anatomy is reversed. We have to see the lower lipper. So in some countries like here, they like the upper lipper. So they like probably the duck type lip. What's new? So what's new, my friend, is the asymmetrical smile. And this is really super challenging, super challenging. So this is Rania. Rania, she came after a car accident and she had some issue with the jaw, reconstruction of the jaw, many years ago. And she ended up with this asymmetrical smile. She saw so many practitioners, plastic surgeons, dermatologists, dentists, periodontist, oral surgeon. And nobody was able to help her with the asymmetrical smile at the time. This is 2012, 2013 case. So when you start to look at the case and you start to do your study, and Rania's wishes is to really eliminate her gummy smile, her asymmetrical gummy smile. And again, you do go to the same concept, the same technique that I've been showing you. You do all the measurements, you take the pictures, you take the videos, you note the numbers, and then you start to do your study. And then the treatment plan of Rania in this case is to do a combination of crown lengthening. Then one side we give a filler more than the other side. And then on one side, we don't do any Botox, and the other side we give Botox. Why? Because you want to drop the lip on one side to make it more symmetrical. This is super challenging, to be honest with you. But if we don't do it, who's going to do it? So we take Rania through the procedure, and this is the crown lengthening. And then while she's numb, again, we do the same thing, filler on one side. And then most people, they was like, hey, doc, since you're doing the Botox, can you do a little bit here? Can you do a little bit here? Can you do a little bit here? So it's, it's never end. So this is the Botox, just on one side, just here, not there. And then here she's doing the eyes, crow's fit. And this is after 1 month. We looked at 1 month, so we gave her a bit of a filler, and Botox. And when you look at the 1 month, she was still asymmetrical. And I said, well, let's do another touch-up. We're better on this side, almost zero crown lengthening with the crown lengthening procedure. Filler is okay, but we can do a little bit more. And let's do another touch-up. So I gave her Botox, again on one side, which will drop the lip, but there's no more red lip. So this is one of the downside of the Botox therapy. When you give Botox, the lip become hypoactive, but you lose some of the volume. So we waited another week, and then we added more filler. And then you look at it, and then she's happy, not happy, can we add more? And again, most people, they want more. So we add more, and then we add more. And then we get to the point where she becomes symmetrical. And then, when you write down in your chart how much Botox you gave her, how much filler you gave her, and then you can, with the touch-ups, this patient took me maybe 5 or 6 touch-up appointments to get her from here to here, to me, the asymmetrical smiles are really the most challenging smiles. You want to do it right. You want to please the patient. She has to be satisfied. And you want to do it in the most natural way possible, because we're not looking to be fake. We don't want a fake smile. We want really natural smile. And again, the smile has to incorporate the whole facial aesthetics. So my friend, the asymmetrical smile is really challenging, but it can be treated. And then once you know your doses, you know how much to give the patient, when they come back for a repetitive treatment, then you know how much you should give, and you know where you did in the first place the treatment, so you just have to repeat it. And this will take less than 5 minutes. The repetitive treatment, quick, no pain, and then you make money. And this is Rania. Again, she's proud of her smile, she's happy, and this is natural, not really fake. And you can see that there's no more asymmetrical smile. So, do we get to, and this patient now, I can tell you, she comes She calls me, you know, cleaning patient, I have to call them up and tell them, you know, it's time for your cleaning, you guys have to come, and they never come. But the Botox and filler patient, trust me, they will call you. So let's finish up with this case. This is a patient of mine, Jad. Now he's in Australia. He's a basketball player, professional basketball player. And Jad, he was, when we were discussing the case, he was telling me that most of the pictures that he have, most of them, he have them when he's putting his hand in front of his smile, because he wasn't too happy showing her smile. And when you look at Jad's smile, really, this is severe. I mean, when you show more than 10 millimeter, this is becoming a severe gummy smile. And Jad had an issue that he wasn't happy with the smile. And, you know, he really is so excited to do something about it. And again, we have to not just take photos, we have to look at the dynamics of the smile by taking videos and then really showing not just the polite smile, but I want to see the spontaneous smile. I want to see how much they pull and the way they pull. And, you know, just to see when they are kind of loose, they have to let it go so you can see exactly what you can achieve. So we had some dental issue that we had to fix, and then we go to the same study. The only difference here, this is not just the combo treatment. We added another thing that we're still doing a study on it. And you know, there's other techniques in the market working on the same thing. But what we did is, of course, we do the crown lengthening as a first procedure. And then we do the osteotomy, osteoplasty, taking back to anatomy. And we added alloderm. I use alloderm for soft tissue grafting techniques for recession. I published a couple articles on that. But I was thinking, you know, because it's a muscle pool, what if you block this muscle pool by adding something, a volume under the lip? I saw some cases on the online, they're using you know, customized block ppm, and they screwing it under the gum. So there's nothing in the literature yet, still under you know, investigation, I would say. But I thought by, you know, placing the alloderm to see how much this will improve. So at the same time, while we did the crown lengthening, we added the alloderm just to support the upper lip and keeping the slip from going up. We gave him a Botox just to have a relaxed gum in the beginning of the treatment. So this is after we waited, and then you can see that there's some improvement, but Jad wants more. So we gave him, I would say, you know, 50% improvement, but he's asking for more. And can we do more? So we decided to do another step. This is another protocol that we're trying, is doing the combination of Botox and static crown lengthening. So, you know, by doing this combination of treatment, and if we want, we can talk about the lip repositioning. The main issue with the lip repositioning is the relapse. So we thought by going to Botox, maybe you can lose this muscle from pulling back up. And maybe by doing this, we can relax all those muscles. So we gave him this combination of lip repositioning and Botox. And then we waited. And you can see that we have a bit of an improvement, more than 50%, 70% now, but he's still gummy. So we waited, we finished up with the dental part. And this is our team did the 4 veneers, bleaching, you know, get all the teeth done. And then when you look at his smile after now almost 2 years, from doing the combination of treatments, he's still gummy, of course, but not as gummy as we started. Here he was about 12, 13 millimeter. Now we have about 5. So what we're doing for Jad now, he's just coming every 6 months to get a small touch up of his Botox lip. So he's, you know, we did as much as we can with the irreversible treatment, which is the gum lifting and the lip repositioning. But when you have a hyperactive muscle, you still have to do the Botox. So my friend, this will conclude me to the conclusion of this chapter. And this is actually a 2-day course that we do, a full 2-day course. So I tried to summarize the most important thing in 1 hour. So treating the gummy smile starts from etiology. You have to know why these patients they have gummy smile. What's the etiological factors? And then the second question becomes looking at the teeth dimensions, how much tooth exposure these patients are showing. Some of the treatment modalities to do crown lengthening, of course. Orthodontic surgery is still on the menu, of course. And we always, for the bone cases, we always advise these patients to do orthodontic surgery in combination with ortho. Lip repositioning, super debatable topic. I can share my experience with you, but relapse is one of the major issues of this technique. Botox, of course, it's a repetitive treatment, definitely. Patient has to come back. But you know what? They love it. Patient love it. Filler, combination of all, it's probably what most patients need. And this is my experience with seeing patients that none of them have one issue. A lot of them has a lot of issues in terms of gummy smile. So combination is the name of the game in most of these cases. But again, we're not alone in this field, and the evidence-based research and the best approach and the best technique that we have is when we work all together in the purpose of serving our patients. So we have to really put all our effort, do the brainstorming. We do a lot of communications within the team to see really what is the best treatment plan. And, you can do it alone, but the learning curve will be so long if you want to do it alone. But if you do it within team, friends, ask for advice, then this learning curve becomes shorter. And this is what will make you a better surgeon. We published an article on crown lengthening, and we have a couple papers coming up, on these techniques. Beauty is still very powerful, and the smile, it's the sword. And most people today are mainly focusing on the smile. They want to feel good about themselves, and we can do it for them. But we have to incorporate the smile in the facial aesthetics. So facial aesthetic, it's becoming really part of what we do. They used to call us periodontists. We used to do mucogingival defect. Then they start calling it periodontal plastic surgery. Now we're talking oral plastic surgery because, the perioral area, this is our field. We are supposed to be helping these patients out. If you like this topic and you would like to know more, I'm started a practice in Dubai a few months ago. And in this practice, we have a training center, the practice called Villa Fortuny, and we're running a 2-day course on gummy smile where we have workshops, lectures, and live surgery. And this is by next month, June 26, 27. So if you guys are interested, you can text me. We have this social media platform on Instagram. So these are for dentists, the Lounge Dental Academy, where we post cases. This is more for the clinic cases, and my account is personal. It's been a pleasure, my friends, to be with you this morning. I'm looking forward, really, to come back to India once the COVID situation will end, and I'm sure it will end. So I'm looking forward for the question session, if you guys have any. Thank you.
Thank you, Dr. Rovanas, for giving us a comprehensive insight into the gummy smile treatment, along with all the different aspects associated with it. You talked about the use of botulinum toxin, soft tissue fillers, and also the scope of lip repositioning and orthodontic surgery. Your lecture has been well received, and this can be backed with the questions which are popping up in the chat box. So if we have time for it, I'd like you to address a few.
Sure.
So one of the questions asked is, Are there any reported case of infections after placement of fillers?
Well, depending on what you're using, but if you're using the top branded fillers where they have research and evidence, honestly, I've been doing this for the last, I would say, 10 years now. Zero case of infection, zero.
What would be the, okay, sorry, please go on.
One concern that people should keep in mind is that if the patient had previous filler injection of a non-resorbable product, and and before the years of 2004, before the HA came on the market, we used to use a non-resorbable resin, acrylic, and these materials, yes, they tend to get infected, but we don't, we do not inject HA next to a product that's been there for many years. So the previous fillers, yes, it can be infected if they are non-resorbable, but the ones that we're using today, no, zero risk.
What would be the percentage of relapse after using fillers and Botox?
Well, like as I showed in the combo treatment, when you're doing the combo treatment, the one that doesn't relapse is the part related to the aesthetic crown lengthening, because this is an irreversible treatment, because you do the measurement, you do the crown lengthening, so this is done. What will relapse is the part related to the Botox and filler, which is a 5-minute treatment. Most patients, they do it when they come to do the dental cleaning. So this touch-up session of 5 minutes, they would do it, and some patients they do it every 6 months, some patients do it once a year, but it's a one-time yearly to do these touch-up sessions. So it's not relapse. This is just based on the numbers that we looked at.
Okay, so I'm going to combine the next two questions. These are, how do we decide the quantity of Botox to be given and what landmarks do we take into consideration?
This is a 3 hours answer. I should come to the course. Well, there is, of course, there is anatomical landmarks. We cannot just inject like this. We went, actually, when we were putting this course together back in 2013-14, we had to go back to the anatomy department, and we had to do anatomy study on pulling the skin, and then looking where the attachment of the muscles, and then see where the nerve is, where the artery is, and try to be safe. We all know this. We are dentists. The head and neck anatomy, we were learning this for many years. All what we need to do, guys, is just a refreshing course of anatomy. So for people who wants to do this, it's easy. I promise you, this is probably the most predictable treatment with a low risk of complication. And this is what we both like. We all like to have zero complications, but we have to go back to anatomy, and we have to understand how things work. And it all starts with the anatomy. It all starts with biology. But I cannot answer this question by just telling you inject here or here. This is not scientifically speaking appropriate.
This is a follow-up question by one of the participants. Do we expect any kind of side effects after we use Botox?
Well, if you do it the way I'm telling you, no, zero side effect. I get a patient coming to seek a second opinion from complications where they injected more on one side than the other side, so they have asymmetrical issue. I see this very often, to be honest with you. I see a lot of patients, they've been injected a lot with filler and they want to remove the filler. So these type of complication may happen if the treatment plan and the discussion with the patient is not done properly. That's why, I spend an appointment 2, sometimes 3. And I can tell you honestly, some patients, I refuse to treat them because, some of them, they have super high expectation. and I feel the trouble. I feel the trouble is coming my way, and I don't want to be part of this trial. I have so many headaches. I want less headache. So communication is very important, especially when it comes to Botox and filler with patients, because some of them, they have a high expectation which we cannot fulfill. I mean, if somebody has a full anatomical problem, you're not going to be fixing it with just doing Botox and filler. Some patients, they need the facial lift, so you have to know the limitations, and we have to know what we can achieve and what we cannot achieve.
This one is from me, Dr. Romanos. The role of digital guides in gummy smile treatment. What do you think of it?
Well, I didn't incorporate a case in the study, but
Yes.
it's in the 2-day course that we will do. We will talk about this more in details, and this is good for general dentists who are looking to do these type of cases. It makes their life easier, simpler. Honestly, Dr. Nishani, when I do it, it's much faster for me to do it without it. But for GPs, yes, it can be a good help. And the concept comes, we in Dubai at the clinic at the Villa Fortuny where we work, we are DSD certified clinic. So we do a lot of Invisalign veneers cases where you send them to the Madrid center, they send you back the guide, and then you use the guide for veneers. So we start doing these DSD digital gummy smile guide. Again, I mean, if you don't want to do the measurement, somebody can do it for you. But this work just on the gingival part, just doing the static crown lengthening. The Botox and filler, you still have to do it yourself. So DSD, they don't have this technique yet, the combo technique, where they can tell you exactly what to do and where to do. So the guide, it's nice, but you cannot do it alone. You have to know the basic, you have to know the anatomy, because if you put the guide and you start cutting and the patient end up with the minimum attached gingiva, you will be fixing the gummy smile, but you're causing another problem of potential recession in the future and discomfort to the patient. So that's why I didn't put it here, because I don't want to give the wrong message. We have to really understand the basics, the anatomy, the biology, the classification, because when you have a patient, you need to identify the etiology before we jump into the treatment.
Dr. Romanos, it has indeed been a pleasure. Thank you so much for your comprehensive and insightful presentation on the gummy smile. On behalf of the Indian Society of Periodontology, we wish you all the best for your future endeavors and look forward to seeing you in India very soon.
I'm looking forward. I wish you guys the best with this meeting. It's been a pleasure. Looking forward to be back to India, and really, the virtual is awesome, but the physical contact, the interaction with the crowd is really something different. And
thank you
plus,
so much.
I miss the Indian food too.
Definitely.
And the Indian bread.
Correct.
Every time when I come back, I bring with me in the bag the Indian bread, and I put them in my bag, and my wife's like, "You're crazy, why are you bringing this?" What did they say something at the airport? So I love the bread, really. So I miss that.
We look forward to having you back soon.
Again, very soon, and you will be able to have that bread again. Thank you so much for a wonderful presentation and beautiful presentation of your cases, and making smile one of the most powerful weapons. Thank you so much. Thank you.
Thank you. Pleasure.
Thank you so much, sir, for delivering to us such a remarkably outstanding presentation on gummy smiles, the combo treatment. It was an outstanding and thought-provoking presentation which had shed light on this spectacular topic. We truly appreciate the fascinating talk you gave. Thank you. We also would like to thank Dr. Nimfia Pandit and Dr. Ashish Nichani for being chairpersons to this session and extending their warm wishes to ISP. We are so grateful to them. Thank you.
Thank you. Thank you.
ഞാൻ തുറക്കുന്നില്ല വീഡിയോ, എന്നെ കാണുമ്പോൾ എനിക്കെന്നെ മടുപ്പ്.
Now, we are moving on to our next session, chaired by Dr. Nitin Dani and Dr. H.S. Grover. Dr. Nitin Dani is the past president of Indian Society of Periodontology, and Dr. Dani has completed his MDS in periodontics from Government Dental College, Mumbai in 1985. Dr. Nitin Dani is a well-known private practitioner at Nasik, specialized in oral rehabilitation since 1986. He was in academics at Dental College at Nasik from 1991 to 2015, and he was invited as a keynote speaker at various numerous national and international conferences. Dr. Nadani has been more than 50 publications, including more than 5 books under his credit. Our next person is Dr. Harpreet Singh Grover. Dr. Harpreet Singh Grover graduated from King George Medical College, Lucknow in 1985. Dr. Grover has been awarded Gold Medal for outstanding academic achievements. He did his post-graduation in periodontics from the prestigious King George Medical College, Lucknow in 1988. Dr. Harpreet Singh Grover is a well-known presenter of more than 85 scientific papers, and he has chaired a considerable number of scientific sessions at various conferences. Having worked as a principal in Desh Bhagat Dental College and Hospital, Punjab, his immediate past position was of the Dean, Professor, Head, and PhD Gate in the Department of Periodontology in SGT University, Gurugram. Having served 4 terms as an executive member and 2 terms as a vice president, he has recently been elected as the secretary of the Indian Society of Periodontology. More than 135 publications and contributions in 7 books were under his credit. And Dr. Grover also has been a secretary of the Bioethics Unit of the UNESCO Chair in the Bioethics and also the founder convener of the ISP Study Group Delhi NCR. Dr. Grover is currently maintaining his own private practice in the field of periodontology and implantology. And it is my great privilege to welcome Dr. Nitin Dani and Dr. H.S. Grover to chair this session. We wholeheartedly welcome you both, sir, to chair this session. Now, over to chairpersons. Thank you.
Thank you, Dr. Jilu, for those kind words of introduction. At the outset, I'd like to place on record my sincere gratitude to the Indian Society of Periodontology Head Office and the Convention Organizing Committee of the 19th ISPPG Convention for considering me worthy enough to be a chairperson for this session. And it is my pleasure to introduce you Dr. Amit Mohindra, who is going to be our speaker for today. Dr. Amit is a postgraduate in dental implantology from the University of Central Lancashire in 2013, where he also did an advanced dental implant training from Brazil. He received training in CBCT and started intraoral scanning and CBCT since the year 2015, and has undergone extensive training in implant studio, surgical guide design, and printing in 2017. He also does Form Lab 2 printing and training and has undergone Navident training, and he uses the Navident since the year 2019. In digital dentistry, he's using ExoCAD and in-house milling since last year and has done an advanced course in aesthetics, including Botox and derma fillers. He is also a certified dental intravenous conscious sedation dentist from Yorkshire and also has a certificate for use of IV sedation from the Newcastle Dental Hospital. He is a principal dentist in his private practice, providing private dentistry with digital dentistry, guided surgery with real-time videography, in-house ceramic restorations, and intravenous sedation. He is also the principal associate at a private dental clinic in Coventry, where they do modern dental services, smile makeovers, and facial aesthetics. His main interests include dental implantology and digital dentistry. He is, dear friends, a key opinion speaker for Navident,
the real-time videography for guided surgery. In his own words, Dr. Amit is a conscientious, friendly dentist with a caring and positive approach, fully committed to continuing professional development and postgraduate learning. With this brief introduction, dear friends, I hand the screen to Dr. Mohindra, who is going to enlighten us with his presentation. Thank you very much.
Hello, Nitin, and hello, everybody at the Society of Periodontology. Firstly, I'd like to say thank you for the invite and the opportunity to talk to you about dynamic navigation. I will be sharing my screen with you in a moment, and hopefully I can share with you what I've learned over the last couple of years, and it is of interest to you. So I'm going to share the presentation here. Right. Nitin, thank you for the lovely introduction. Mainly, I'm a general dentist. I work in Oxford, and I've been doing implants for a number of years. And as Nitin kindly pointed out, I've developed an interest in digital dentistry about 5-6 years ago, and definitely within the implant area, got involved with the guided surgery about 5 years ago. I started off with a static guides initially, and after a couple of years of using those, I was introduced to dynamic navigation, which I felt would overcome some of the problems I was having with the static guides. So that's what we're going to be talking about today. So the topic is dynamic freehand navigation for guided dental implantation. Dynamic navigation, what is it? Well, basically it's guided surgery, but it's using real-time videography to guide where you are in the patient's mouth, as opposed to a static guide that is made prior to treatment. So you're relating the CT data you have to the real anatomy of the patient, and you're guided by correlating the two together. You are able to visualize where you are in the patient's bone as you are doing the treatment. And it's not a new concept. It has been around for, about 40 years. In the last 15 years, it's been widely used for care in cranial surgery. It was introduced to dentistry probably about 15 years ago. And because of at that point, access to CBCTs wasn't available, and due to the cost, it didn't really develop any further until more recently in 2015, where dynamic systems reappeared in the dental market. And there are now, a few systems out there, one by Noble Biocare, and the one we're going to be talking today, Navident. The reason I got into guided surgery was because I wanted to look at ways and how I can minimize the invasiveness of the surgery when we're doing implant treatment. So guided surgery enables us to reduce harm because we can do more flapless procedures or mini flap procedures. It also, would lead to less errors, and more importantly, more precision in where you're placing the implants. And by planning and placing the implants in the best possible place would lead to better aesthetics and to restorations that are easier to maintain going forwards. But the other advantages we found was that once you had planned the procedure, the actual surgery time would be quicker on the day, and we were able to carry out more complex procedures without bone grafts, etc., being able to utilize the bone availability far better with guided surgery. The advantages of dynamic navigation over static guides. There were several advantages that we realized over time. One of them being that because there's no guide in the mouth present, you didn't have any problems with the coolant, the silane getting onto the preparation site. That was something that was always a bit of a concern when I was putting the guide in and feeling as that the irrigation wasn't getting onto the actual surgical site as it was covered with the guide. Another advantage was that when you're working in the posterior area of the mouth, you didn't have a physical guide in the way, which would then create a problem with access. It's an open system, so it was compatible with all implant systems, and you avoid the cost of having to get stents produced and also the time taken to produce these stents, because with the navigation system you could prepare the sites there and then. When you got the CT data, you could do it straight away and start the treatment straight away as well. Another advantage of the dynamic system was that you could actually change your design or your plan at the time of surgery. So with a static stent, once you designed it, you would obviously be limited to using that design or not using the guide at all on the day of surgery. With the dynamic system, because it's real-time videography, you could plan the treatment and edit it as you go along. And also, when you're viewing the real-time videography, you could actually change the direction of your placement if you felt it wasn't correct at the time for any reason. So there's a lot more flexibility in using the dynamic system over a static guide. So the system I want to talk to you about today, the dynamic navigation system, is Navident, and that's the one we've been using in our clinic for a couple of years. It's a Canadian-based system, and it was introduced to the UK market about 4 or 5 years ago. And I believe in the UK now, there's probably a dozen clinics approximately using the Navident. The Navident differs over other dynamic freehand navigation systems in the sense that it uses a trace and place concept. So this is where you're actually tracing landmarks in the patient's mouth and correlating it to the CT data, as opposed to using a fiducial or something, a CT marker, which would require an extra CT scan at the time of surgery. And I'll come on to that in a bit more detail later on. We'll come on to it now, actually. Trace and place. So what we're doing is, when we're preparing the case, we are correlating the patient's real anatomy to the camera, which will then show us on the video where we are. We're correlating the handpiece and the patient's anatomy with a jaw tracker, so it all correlates together, so you can visualize on the computer where you're drilling in the patient's bone. And there's a workflow we follow when we're doing these procedures. Initially, we start off with collecting the data, which we do with a CT scan. And these days, we also take an STL file as well, take an intraoral scan and correlate the STL file onto the CT scan, which has been a big change actually, because with a lot of CBCT data, you get a lot of scattering when you have metal artifacts. And this was a problem with some of the early cases, because with the scatter, it was hard to correlate the anatomy to the CT scan sometimes. But now we can use the STL files. That has overcome that problem. significantly. However, still in cases where there is a lot of scattering and you can't relate the SDR file to the CT scan, it is still a slight issue, and we're still looking at some ways of overcoming that. Once you've got the CT data and the SDR file, we then plan the case. This has been, I think with guided surgery, the biggest learning curve actually. It's taken that time to actually look at your case in detail and plan it before the surgery has been probably the biggest and probably the best outcome of doing guided surgery, because I feel personally, when you're planning your case to this level, when you come to doing the surgery, you already know exactly what you're doing and things tend to go far more smoothly. And as you can see here, we always plan prosthetically first, and the implants are placed in relation to where the prosthetics are going to be made. On the planning software as well, you also have the opportunity to mark the ID canal and other landmarks that may be of concern or interest. And once you plan the case, on the day of surgery, we then need to do the tracing. So we have to put a marker on the patient so we can relate the patient to the actual camera, the navigation system. And there are a couple of different markers you have. You have the head tracker on the second picture here. And this can be used when you're dealing in the maxilla as it's fixed to the upper skull. And when we're dealing with the mandible, we use the jaw tracker, which obviously allows the tracker to move with the mandible so your correlation doesn't change with the navigation system. The jaw tracker has the disadvantage that you then obviously have to have a couple of teeth to apply the jaw tracker to, as you can see on the video below. But obviously this is the only way because the mandible does move, and therefore we need to have something fixed to the mandible and not anywhere else. Once you've got the tracker on, we then trace the hard tissue landmarks in the patient mouth that we've identified in the CT scan. So we can actually correlate the two systems together. And with the tracker in place and the correlation carried out, that should allow the handpiece then to enable to visualize where we are in the patient's jaw. And then once we've correlated all the systems together, we can then place the implant. And during placement, we can then see exactly where we are. So this is a view we have on the computer while we're drilling into the patient's bone. So we can see in different sections where we are, the placement, and also we have a little guide on the lower left of the screen, which shows us our angulation, etc. And there is a bit of a learning curve to reading this data while you're treating the patient. And I'll say that probably the biggest learning curve is actually looking at the computer screen while you're treating the patient, as opposed to just looking in their mouth, which was a strange concept initially, but you do get used to it very quickly. The trace in place is basically unique to the Navident system. Other systems often require, as I said, CT markers, etc. And there are a lot of advantages over having a trace in place system. So it allows for less x-rays being needed, and also it allows basically for corrections to be made on the day if anything changes. But the disadvantages of the trace in place, as I mentioned, is that when you've got metal scatter, it can be sometimes more challenging to trace, and also you do need to have hard tissue structures in place to trace to correlate to the CT scan. But this can be a problem when you've got edentulous cases, for example. And there have been methods developed to overcome that, and we are still learning on different ways and how we can make this process for edentulous arches easier. A current method we're using at the moment is where we place bone screws on the day into the patient's jawbone, take a CBCT scan data, and then we trace the bone screws to the CT data to correlate the two together. But there are still there are other methods being developed for edentulous cases all the time, and this is something that's being developed on regularly. Now there are, it's been around for a little while now, and more papers are being released on dynamic navigation. And the accuracy in the studies have been shown to be comparable. And we were looking at, mean deviation of in the studies of 0.6. I'd say actually with experience that deviation is probably so. One thing that has been identified from the papers is that real-time navigation, it is a valuable alternative to the static guides, and it does offer advantages that the static guide over the static guide as well. It is a less expensive ongoing treatment if you're not paying the lab for the guides to be made. However, there is the initial outlay to buy the software and the system. Another advantage that's been quoted by others with the navigation system is that you still have the tactile feeling during the surgical procedure. But I believe more importantly, being able to change your angulation, having that freedom on the day of. The other thing to note with the tactile sensation is that, well, going back to surgical guides, some of the issues we had with the surgical guides was on the day of treatment. If it was going to be an immediate implant placement, you would remove the teeth and find that the guide doesn't fit exactly, and therefore you end up spending time trying to adjust the guide to get it to fit properly, or putting the guide to the side and not using it at all. And this is a big advantage we found with the navigation system, is that you didn't have that problem, or if there was a problem with the tracing or you wasn't sure about the correlation with the CT data, you could just basically reset the calibration and start it again on the day. So that's something that we found quite useful using real-time videography. The clinical applications, mainly we use the navigation system for partial edentulous cases. We have used for a couple of full edentulous cases, but as I said, we are still developing methods on how to make that workflow easier. The biggest advantage of using real-time videography in our practice is that it's really made the implant procedures far less invasive. It allows us to carry out most procedures with flapless surgery. We do a lot of immediate implants using this system, both anteriorly and with posterior molars. And as we'll come to see, it's very useful for when you haven't got a lot of bone in the area to accurately place your implants. This is a zygomatic case. This is not one of mine, but it just shows how you can plan your placements accurately using a navigation system. With the navigation system, you can also use it to do piezo surgery as well. And more recently, they've also introduced the concept for endodontics. So if you have a sclerosed canal, you can now navigate your drill to be very precise and also minimize the amount of tooth destruction when you're getting down a canal. A big advantage of this navigation system over a static guide for endodontics is that for a molar tooth, you would normally need three or four guides, but for the navigation system, as there is no static guide, you can, you have that freedom to move around into different canals and plan for different insertion pathways on the system easily. I don't do endodontics, so this is not something I'm that familiar with, just something I know is now being carried out. Being able to read the data on the computer and correlating it to your hand movements was a little learning curve, which took a few cases to get used to it. So it is you'll always start off with the more simple cases first and gradually build up the complexity of the case with time. Navident we chose because at the time they were one of the market leaders and they had a good support for teaching onto dynamic navigation. I've covered why we prefer the dynamic navigation over the static guides. So what I want to do is actually move on. And we covered why the trace and place is more beneficial over using a CT marker. I want to go into a couple of cases here just to show you the advantages that you get with using a navigation system. So this is a case here. It was a 78 years old gentleman here. He had his missing upper left canine, premolars and molars. And as we can see here on the OPG, we have an impacted canine in place, which was limiting the amount of bone available. And this gentleman also had ongoing issues on the upper left sinus, and he was planned elsewhere to have a sinus lift and the impacted tooth removed and a significant bone graft. When we saw him, we discussed with him actually keeping the procedure less invasive and using the bone available to place the implants carefully. And using the navigation system, we was able to place implants in the jawbone and later restore a bridge, which has now been in place for over a year. And this, I believe, was a far better approach for this gentleman who was 78 years old, already had issues with his sinus, as we can see. The sinus was inflamed on the left-hand side. In my opinion, a candidate for a sinus lift or an impacted canine, or at least it was better to avoid it if you could. This is another case here. This is a 38-year-old male who had missing upper left canine and premolars. We can see there's other issues here as well, such as over-erupted molars. But we were dealing mainly with the tooth loss, and this gentleman wanted fixed teeth, and he was concerned about the appearance of the upper left lateral tooth as well. And as we can see from the CT data here, again, there wasn't a huge amount of bone available, and being able to plan this case and place the implants carefully allowed us to avoid any complex grafting and get a satisfactory results for the patient. So this was the bridge that was placed on the implants. We can see obviously the tissue architecture could be better, but he had a low lip line and he preferred to go down this path rather than have major block grafts placed. And this is another case here. This was a 69-year-old female. She had missing teeth in the lower right and a lower right premolar tooth that was failing. And she was looking at having this tooth replaced and didn't want a lower denture. And with the navigation system, we were able to plan the implants. Access at the back for this patient was not great, but by planning and having the guided surgery, we're able to place the implants exactly where planned and get a restoration placed because the implant in the photos the bridge for you. There's more cases on our social media page. And if you have any questions about Navident or dynamic navigation, you can always drop me an email and I'll be happy to answer any questions you may have.
Dr. Mahindra, this is Dr. Grover.
Hiya. Yes.
Sir, Dr. Mahindra, first of all, I welcome you on behalf of Indian Society of Periodontology. Your lecture so far has been really fantastic and it has been a wonderful, 3D journey into the mouth. Sir, if you allow, I have a couple of questions if you would allow to, if you would like. Yeah. So, Dr. Mahindra, this technique, this image navigation has lots of advantages, as you have rightly explained. But I am talking, of course, of the Indian milieu, the Indian ecosystem. Despite the many advantages of this, navigation system, many of the clinicians are still practicing, a freehand implantology here. We do understand that the navigation system now has become less expensive because CBCT, of course, is also not a very expensive tool now. And the softwares are also not really very expensive. I want to know what is the reason that it is not becoming a standard of care in India, because most of the clinicians are still doing, I said, as a free-handed approach, and they would use this system only in very complex cases like zygomatic implants. Why can't it be done as a standard of care thing?
I think I'll say it's the same reason why it's not yet become the standard of care in the UK as well. And there's two reasons for it. One is
There seems to be a problem at this end.
Element, training element to it as well. With these things, there's barriers to adopting new technologies. Hello, Dr. Grover, can you hear me? Hello, can you hear me?
Yes, sir. Yes, sir.
Sorry, I lost you there for a moment. So as I was saying, Dr. Grover, with CBCT as well, I believe there was a slow uptake to CBCT because a lot of experienced dentists feel, well, we've managed without it for so many years. Why do we need to adopt new technology? And sometimes it's not only until you adopt it that you realize that actually the advantages it brings to your daily life and the care that you can provide to your patients. I'm sure many of us dentists have done implant surgery without CBCT for many years.
Yes.
But those who have started to use it, who have access to it, would now use it for every single case. And I believe, putting the planning you can do beforehand with CBCT data really, makes a big difference to your surgical day, your procedure, and your outcome, and the care you deliver. And the same is with the navigation system. We can do implants without it. Most dentists do, but once you start adopting the new technology, it's hard to go back. You realize that actually the care you can deliver, the precision and the accuracy that you can deliver, the predictability you can deliver becomes far greater.
Very true, sir. Very true. We would really like more clinicians to be using this approach because it is definitely a far better approach than the conventional, freehand implantology, which I am also practicing, I would say. One more question, sir, if you would allow. Uh, I have read in the literature that there are, two approaches of this guided navigation system. One is a fully guided surgery and one is a semi-guided surgery, which is there. So I just want to know that are there specific indications where we do a fully guided surgery and there are different indications where we can do a semi-guided surgery? Because just a corollary to that, I also read that in fully guided surgery, the room for any maneuverability is very less. I mean, there is very less flexibility if you are doing a fully guided surgery. But is it the reason why we should prefer a semi-guided surgery? I just want you to enlighten us.
Well, I think we call it guided surgery, and by that, we've got to understand it's a guide. It can never replace our own tactile sensation, our own what we're looking at, visually, and our own experience. I would not recommend any dentist to get into guided surgery until they've learned how to do implants without guided surgery, because we need to understand as implantologists, how it should feel to us. So if the guided surgery doesn't feel right or it's not going where we want it to go, we have the confidence to continue that procedure without using the navigation or a static guide. So we must learn to do non-guided surgery first. And then once you've got guided surgery, it's
We have lost
precision
we got
treatment guys. This is
so we seem to have lost
that approach. You're not fixed to one specific point. Hi, can you hear me?
Yeah.
Yes.
Yes, we can
Hello?
hear you and we can
Any
see.
better?
Yeah.
Am I back? Yes. So I'm not sure where you lost me there. At what point? But the point I was making was that we need to be able to do implants without a guide before we can use guided surgery. So we understand when the navigation or the static guides aren't working correctly, and that we also need to be able to have a semi-guided approach. So the dynamic navigation allows us to achieve that. So if we want to alter our angle or our plan on the day, we have the flexibility and freedom to do that.
Thank you, sir.
I have a couple of questions from my side, sir.
Yes, Dr. Dani, please.
Good morning, Dr. Amit.
Good morning.
An excellent presentation. And
Thank
I
you.
must really commend you for being up so early in the morning to address
Thank
your
you.
good friends and followers at India.
Thank you very much. Yeah, I'm
I'd
not
like
a
to,
morning person.
yeah, yeah. I'd like to ask you or just discuss with you a couple of things, like
Yeah.
regarding your navigation surgery. I draw a small analogy with the Google Maps we use to drive our cars around nowadays.
Yes.
So when the Google Maps actually started, we would spend more time looking at the map than at the road.
That's right.
So
Yes.
that's what you mentioned in your presentation also, that that learning curve was looking into the computer and working in the patient's mouth.
Yes.
So do you think there is a system or there will be a scope for a system in the navigation system which will tell you verbally whether you need to drill, how far you need to drill, which angle you need to go ahead? Can this be integrated in any of these visual systems that are there? So you can look in the patient's mouth and listen to what the guide is telling you.
That's a very interesting concept, and I'll feed it back to Navident and ask them if they can do that. I know some of the cases where I was dealing with patients where access was difficult and visibility was low generally. It was a leap of faith at some point to trust what you're looking at on the computer to be correct. Because we all know you have some patients where you're doing a lower molar implant, for example, and
We've lost you again, sir.
you cannot see, which is making visibility more challenging. And it was very strange for drilling in the place that has been planned at time. Having who knows, hopefully one day in the future.
Yes, sir. Definitely. Another thing I wanted to mention, like you said, in response to Dr. Grover sir's question, that you have to be able to do without the guide. So, can you hear me, sir? I think we've lost him, sir. Hello, sir. Grover, sir, I think we have seems to have lost Dr. Mahindra's connectivity.
Yes, sir. I do believe that, sir.
So, like you were saying, sir, that semi-guided or whatever it is.
Sorry,
Yes.
the
Sorry.
reception went.
Is he back, sir?
Can you repeat the question?
Yes, sir. Now, I
So
was
sorry about that.
asking you, when you responded to Dr. Grover's query about semi-guided surgery, it's again the same analogy of the Google Maps. We old timers know our way all over the place. We don't need to follow any maps most of the times. Like old time surgeons know the anatomy of the entire tissue. Nowadays, the new drivers who are hitting the blocks follow only the Google Maps. So I think we must be able to do everything without the surgery, without the guide itself, and use it only in the critical cases until and unless we are fully sure about using it for all the cases. So,
Yes. So I completely. The question was a little bit broken, and I think it's reception on my side. So sorry about that. But I think what you was asking was if you've got experience in doing the surgery, and you know what you're dealing with, why introduce something that could create problems? And as I mentioned earlier, you need to understand how to place implants without the digital technology first. You need to know how to do it without the guides. The guide is there then to guide you. And even as a surgical practitioner, if you have the guide, it will allow you to do the procedures in a less invasive method. Because at the moment, as an experienced surgeon, the only way you're going to visualize your anatomy is by retracting the soft tissues further, raising larger flaps, and that is inevitably going to cause more trauma to the patient and an increase in healing time. And with the navigation system, you can avoid that because you can visualize the anatomy on the screen.
Thank you so much, sir. I'll just hand over the screen to Dr. Grover, sir.
Thank you, Dr. Mahindra, once again, and thank you, Dr. Dani, for those wonderful questions. And you have rightly, pointed out that old-time surgeons they still rely on their memory, and the new entrants in the field would rely on the Google Maps, just as a Google map. That was a wonderful analogy. With these words, Dr. Amit Mahindra, we would request you to join the Indian Society of Periodontology again sometimes, because we would like to hear some more wonderful lectures from your side, and I hope you do promise us that. Thank you.
Well, thank you very much for the invite. It's been a pleasure. And yes, next time I'll have more cases prepared to show you, and I'll get a lot more photographs taken in advance, so
Wonderful,
I can show you more of the work and let you know how things develop in this area.
Thank you.
Thank you. Thanks
Thank
very
you,
much.
sir.
Thank you, sir.
Thank
It
you.
was really a very informative session on guided implant surgery for implant placement. The presentation epitomized everything in a beautiful way. It was indeed brainstorming. Thank you, Doctor.
Well, thank you very much. Thank you.
Thank you, Dr. Nitin Dani and Dr. H.S. Grover, for your valuable comments and time. We are so happy to have both of you with us today. Thank you.
Thank you so much, sir.
Thank you. Thank you very much.
Hello.
Praveen, are we live now?
Not yet, sir. It's getting, yes.
Okay. So you let us know when we are live. Okay, when you have admitted the people, then you let us know. We can start at that time.
So what are we planning to start now? Sir, we'll play the video, sir.
Yes, sir. Good to go.
A very good afternoon to all the worthy delegates here. A good afternoon and greetings from Indian Society of Periodontology. And we hope under the present circumstances, all of you are safe, sound, staying put wherever you are. And under these circumstances, ISP has taken this initiative of ensuring that science doesn't stop, that science continues to grow, continues to be delivered, no matter the hardships that we face, no matter the situations that we are into right now. So taking it from there, we have today put together a beautiful program, and I'll talk to you about the program in a little while. But amongst us, we are fortunate to have with us the secretary of ISP, who is a panelist also, so he'll be speaking a lot later. But we also have the president of Indian Society of Periodontology, Dr. Nivya Pandit. So if I may, with your permission, if I can call upon her to inaugurate, to start the session, so that we can kick ahead the program further on. Ma'am, please.
Good afternoon, everyone. Thank you, Dr. Ashish, for inviting me in this forum. And as you said, COVID has really made things very different and very difficult also. And this last year activities were not exactly what we are doing in the Society of Periodontology. They were somewhat away from that because the whole scenario has changed. We cannot meet physically. We cannot have many things what we would otherwise have devised. And because just as you said, science does not stop. We were able to take up a few of projects, and one of the good ones among them was this whatever guidelines we formulated related with the periosystemic link. And it has taken a lot of time to ultimately reach a very good document, which will be very useful for all the practitioners, even these physicians or diabetologists and periodontists, of course. And it's if we are able to disseminate this to many people right from the beginning of their dental careers, we would be able to actually guide them towards management of this one of the most prevalent diseases in a better way, as combined with the physicians also. And we need to work upon this, and we need to actually do a lot of advertisement of this, how the thing should be managed, and how in the present scenario we can have a better understanding of the link, and also how to manage our patients in the best ways. And as all of you know that we have a document in the both journal in the diabetology section, as well as from the society's journal. And one of the three main members who were the brainchild behind this was Dr. Ashish Jain, Dr. Ashish Kumar, and Dr. Vishaka Grover, who have worked relentlessly for about 4 or 5 months to get whatever we have. So today, as I come to know that we are going a step ahead in disseminating whatever we have done over a period of time, taking into consideration a few of the diabetologists and the topmost brains in the physicians who would who along with us made a sort of simple to understand way of dealing with the disease, and that could be understood even by the final year BDS or interns and all. And everyone was welcome on this forum to have basic knowledge about what we ultimately came to that. With these few words, I would provide the best of luck to this forum, and hope that this would be very beneficial to the all the members of the society, as well as the budding periodontists or budding even dentists, who are the first ones to see these patients. Yes, thank you. Thanks a lot.
Thank you very much, ma'am. Thanks for your kind words and continuous support as always. Unfortunately, fortunately, we all got into this situation when you had taken over the office. That's how the coincidence stays. But we must appreciate the way you have steered the society even under these difficult times, and thanks are due for all your efforts in steering the society forward. So, friends, let's get going now. I'll just try to put up a base for the conversation, and then would want to make a little silent exit, because then the field would be open for the centurions or the veterans or the stalwarts of perio, the photographs of whom you see on the screen, and I'll introduce all of them one by one. But before we do that, let me just brief you about the whole idea of the program and the zest of the program, how it is going to be. We are not going to waste too much of time in things which are not important, because what we want to bring on an ISP platform is a 60-minute of pure clinical science. Okay, and that's what it would be. We won't have any of the presentations. We won't have any of the PPTs around. Whatever you will hear would come straight from the horse's mouth, from the veterans, from the luminaries that you see on the screen. What we are going to, the topic of discussion today is essentially oral health and diabetes, but oral health and diabetes from the viewpoint, we all know that oral health and diabetes are interlinked. Most in the present scenario, we are hearing about diabetes, and now with fungal infections coming up, oral health also, making way into the general systemic health of an individual. But today we are concerned, we are focused on the clinical management of a diabetic patient in a dental clinic. As ma'am said, Dr. Pandit said, a couple of months back, Indian Society of Periodontology and RSSDI, which is the research society for studies of diabetes in India. It's a huge diabetic society in India with membership, I think, extending more than 5,000 diabetologists. So around 27, 28 members from ISP and 27, 28 members from RSSDI came together on a platform which was very ably, very generously supported by Colgate, and I must appreciate the support that we receive from Colgate for all the activities that we do, more so if it has to do with periosystemic link. Colgate has always been very upfront about their support, and thanks are due to Dr. Sunil from Colgate for his always being there as Colgate support to the events that we do at ISP. So anyways, so RSSDI and Indian Society of Periodontology, they sat together, more than 53 of the members. It was a huge task. We had deliberations which went on for probably 34, 35 meetings. It took us almost more than 4 months, I would say. And as a result of which, we came out with a wonderful, good clinical practice recommendation guidelines for the management of periodontal disease in a diabetic patient. Those guidelines are, can we, Praveen, can you just pick up those guidelines and share with us if it is possible?
Yes, sir.
Yeah. So these guidelines are published in Journal of ISP, January edition, and also in the Journal of RSSDI. To share with you, this is actually the only the second document globally which has been prepared with the Perio Society and the Diabetic Society. The first document was with European Federation of Perio and International Endodontic Society. This is the second global document. These are free to download, and in the last 4 months, I'm happy to share with you that in the last 4 months, we have been this particular document has seen more than 3,000 downloads. It is really one of the most read document as of now. So you can probably pick it up from there. The panelists that you see here are the ones who are majorly responsible for bringing out this document. These panelists were the group leads for us in that document. If that document, this 25, 30 page document has seen the light of the day, it is essentially because all these panelists and the group leaders of the panel who had actually worked day and night relentlessly to bring this document. And we are going to really discuss a lot, what is relevant clinically from the document. If any one of you really want to go into the depth of it, I would say that, please download this document, keep it with you in your clinics, in your library. I hope it's worth a keep. And when we started this program, also let me share that when we started this program, we thought that we will have a attendance of say 200, 300 participants. And it gives me immense pleasure to share that as I speak, we have already crossed 1,325 registrations. The fact numbers are okay, but the fact that there are so many registered delegates with us, our room is full here. I mean, we had the capacity of 500, and we are full to the brim. Others are actually now going on to YouTube, and the fact that we have been able to get such a huge number probably says that there is a demand of such a topic, such a clinical skill discussions, and if this goes well, we ensure you this is not going to be the first and the last. Also, in the participant, I see a lot of senior life members who are joined with us. KK Gupta, Baljit. I would not be able to take all the names. Pooja ma'am, Bela Dave ma'am. I see a lot of them here. So welcome all of you, honorable life members. It's really very heartening to see the life members on the other side of the table. But of course, that also means a lot of pressure on the panelists. But my panelists are quite confident, I'm sure. So let me move ahead with the introduction of our honorable panelists. Rather, we are honored to have them on board. On the top is His Master's Voice, Dr. Nitin Dani, who's from Nasik, a very seasoned ISP, very active ISP member. More than that, a wonderful human being, an excellent company, and he's always there to contribute. An excellent clinician, had done wonders in academics as long as he stayed, and we are really going to hear from him a lot today. And I can tell you, we have learned a lot from him in terms of public speaking. So welcome, Dr. Nitin Dani. We are very glad that you could find time to be with us. On the second row, we have Dr. Neeraj Deshpande, a young member. I would say young because he's younger to us at least. So a young ISP member, but now he is in Sumandi Vidyapeeth, the banner of which you can see on his screen, and has actually been elevated to be in the capacity of a registrar in the university, which goes on to speak his capabilities not only as a periodontist but also in the administration. So thank you, Neeraj, for being with us. Middle of the second row is our dear friend, Dr. Anil Milak. Anybody who's traveling to Kerala can certainly not afford to miss his home. Certainly cannot afford to miss his hospitality. We had the fortune of being with him last year, multiple occasions actually, and we are actually yearning that when the flights are on and there is no quarantine and things are off, so the first trip would be to Anil's place. He's the principal at Puducherry Dental College, of course, the professor and the head of the department as well, and who had contributed immensely to our document. And we'll hear a lot from him again. On the right, I see Dr. Abhay Kolte. Most of us know him already, not that anybody else is not known, but Abhay Kolte, who was the secretary not long back of the society, who steered the society from wherever we landed. But it was his leadership in those 3 years of his tenure that society is back on its feet now, and he actually single-handedly steered the society at that point in time. So we have Dr. Abhay Kolte with us from Nagpur, who is the professor head at VSPM Dental College. I really don't need any. In fact, Vishaka said we have CVs of all of them. I said I don't really need CVs of any one of them. We know them too well. In the last row, we have in the center Dr. Biju Thomas from Mangalore. uh, who appears to be younger than all of us. But let me share that with you, that my first PG convention as a student, as a PG student, was when he was the organizer of that PG convention in Bangalore. So he appears young, but he's actually, very young as well, and a very, very senior, very thorough gentleman, but more importantly, a wonderful academician to the core. Thank you very much, Bidu sir, being with us. We have Dr. H.S. Grover on the right of the last row, who is currently the secretary of the society. I would say reluctantly, because he, of course, did not want to take that mental load, but we force him to continue as secretary, because the work that he is continuing to do is par excellence. He has been into academics not long back, and today with so much of work going on in the society, most in the present times. Thank you very much, sir, for finding time to be with us and enlighten the panel and the delegates around. And then on the left of the screen is Dr. Vishakha Grover, whom I did not deliberately, shared with you earlier. So Dr. Vishakha Grover, I'm fortunate for her to be working with us in our department as an associate professor. But more than that, she in fact is she's a copywriter for us. So whatever document that comes out of ISP, that document certainly comes out from her desk first. She is a very thorough scientist, I would say. I work with her very closely on various projects, so I can vouch for her scientific capabilities and scientific acumen and scientific temperament. So she's the one who's going to lead the discussions today as a panel discussion moderator. We also had amongst the panelists Dr. Ashish Kumar, our editor, who somehow really could not make it today because of his calling in his own college in some selection committees. But he's trying his best to join us at some point in time if he could. He's, of course, as we all know, the editor of Indian Society of Periodontology. Himanshu, welcome. Praved, Jinkta, Shimla, Dr. Shiva Manjunath. I see so many senior names around. Thank you very much for coming. I mean, it's guys, Dr. Gagan Jaiswal. Guys, it's going to be a tough job, believe me. We have a lot of people around who's listening. So okay, so now I'll leave to Dr. Vishakha. Next 60 minutes are yours.
Thank you so much, sir. Thank you so much for handing me over and introducing everybody so well. Then actually, all of them are, they don't need any introduction kind of preliminaries in perio. So without taking any further time, I will start right away with my discussion for today, oral disease and perio and diabetes, oral health and diabetes. So my first query as an opening batsman to our current ISP secretary, Sir Dr. Grover, sir. Sir, my first query to you in this discussion goes that why diabetes as a disease is considered important for the oral health status of an individual?
First of all, a very good afternoon to everyone. My apologies that I had to change my device because there was a little technical problem with my laptop, and I hope I am audible.
Yes, sir. Yes, sir.
Thank you, Dr. Vishakha, Dr. Ashish, first for the nice words he spoke about everyone. Hello to all my co-panelists and the president of the ISP, and of course, a very warm good afternoon to all my delegates who are here. Taking up the first question, Dr. Vishakha, you said why diabetes as a disease is considered important for the oral health status of an individual. To give you an answer, periodontology is no longer a profession whose sole driving force is the saving of teeth. Rather, diagnosis and treatment is directed towards controlling infection and establishing an oral health status which passes the test of patients' experiences and perceptions of their own conditions. In short, that is their oral health related quality of life. Thus, in my opinion, we can rephrase this question as why diabetes as a disease is considered important for the oral health related quality of life of an individual rather than only the oral health status. When we chose an answer, we do not concern ourselves only within the boundaries of periodontal disease, but also look at other conditions such as dental caries, which also include root caries, tooth loss, xerostomia, taste impairment, oral candidiasis, multiple abscesses, burning mouth syndrome, and all of these conditions negatively affect a patient's oral health related quality of life. Diabetes, as we all understand, is a hormonal disease which is characterized by changes in carbohydrate, protein, and lipid metabolism. Thus, a quantitative or a qualitative decrease in insulin hampers the transport of glucose from the blood into the cells, where normally glucose would be required to be used for energy purposes. Consequently, since it is not being transported to the cells, the cell metabolic functions are disrupted. In addition, glucose, which is now retained within the bloodstream, cause hyperglycemia, which in turn cause microvascular and macrovascular complications affecting multiple organ systems, especially end organs like the glomerulus of the kidney, skin, and of course, our very own periodontium, which also is an end organ. So, indirectly, since the periodontium is the support for the teeth, uh, indirectly we can say that when the periodontium suffers, the hard tooth tissue also suffers, and therefore we see many diabetic manifestations in the oral cavity. Many of these manifestations are of course reversible because there is a body of evidence which shows that the treatment of diabetes has an impact on improving the oral health status and imparting a positive oral health related quality of life for the suffering patients. This part I will of course be dealing in my next answer. Thank you.
Yes, sir. Sir, that is what exactly, very well said and explained, but that is what the next thing is. If disease has so much so impact on the oral health, how to what extent the treatment of diabetes actually leads to improvement in the oral health status for the patient?
Very true statement, Dr. Vishakha. To answer that, medical management of diabetes involves a combination of diet, exercise, weight reduction, and medications. The goal of diabetic management is to maintain blood glucose levels as near to the normal range as possible. Several long-term studies have clearly documented the tremendous reduction in diabetic complications that can be achieved through good glucose management, and it holds true for the oral cavity also. All patients with type 1 diabetes take insulin by injection, as do many with type 2. Insulins, which are classified as rapid, short, intermediate, or long acting, and along with that, oral agents which are commonly used, such as sulfonylureas, biguanides, megalitinides, thiazolidine diones, and alpha glucosidase inhibitors. All of these are used either as standalone or in combination therapies. The response to therapy may not be favorable in patients with poor glycemic control, and such patients would continue to exhibit gingival redness and bleeding, as also other manifestations such as gingival abscesses, candidiasis, etc. So the key here is not the treatment of diabetes as such, but to bring the condition to a well-controlled level, which we can say is HbA1c less than 7%. If diabetes is poorly controlled, therapeutic pathways may need further modifications, such as addition of antibiotics and combinations thereof. However, the greater the expression of age and rage, the more difficult it becomes to reverse the oral manifestations. Diet is also a medicine in diabetics. Therefore, dietary intervention that reduce or alter serum lipid profiles have proved to be effective for many diabetic oral manifestations. The reduction of serum lipids in diabetic patients will provide some protection against lipid-induced alterations of immune cell phenotypes responsible for increased serum pro-inflammatory cytokines and thus impaired local tissue response. This may reduce the risk for development of periodontal disease and other oral manifestations and have a positive impact on the oral health quality of life of a patient. Thank you.
Thank you, sir. Thank you so much. Thank you putting in so much and say in an elaborate answer that how diabetes is affecting the oral health. Now, just looking at the other side of the coin, I'll pass my query to my second expert, Dr. Anil Miller. Sir, sir, I would like to know that is, we got to hear that diabetes affect the periodontal or oral health status, but is the reverse relation, that is how oral health impact the pathogenesis of diabetes, and does the severity of periodontal disease or oral disease has any correlation to the glycemic level? Because nowadays we are hearing so much about the bidirectional thing. We know that diabetes affects periodontal disease and perio affects diabetes. So how is the second this second causal effect? What is your opinion about it?
Good afternoon, everyone. Respected President MFIA Madam, moderators Ashish Jain, Vishaka and Ashish, and co-panelists. First of all, let me thank for having me as the panelist and taking over from where Dr. Grover said. We all know that oral health has definitely an impact on the pathogenesis of diabetes, and there is a definite correlation with diabetic levels of the individual and what role the oral health has to play. And that is why we say that oral cavity is definitely a mirror of systemic diseases. And we know the role of periodontal medicine and a lot of literature pertaining to that. Diabetes mellitus definitely is a syndrome of abnormal carbohydrate, fat, and protein metabolism, already detailed by Dr. Grover sir, that results in acute and chronic complications due to absolute or relative lack of insulin. Briefly on the categories of diabetes, we know that type 1, which results from absolute insulin deficiency, type 2, which is a result of insulin resistance and insulin secretory defect, and third, gestational condition of abnormal glucose tolerance during pregnancy. Now, the evidence on the role of periodontal disease in the pathogens of diabetes, the common intermediate is what normally we include is altered cellular immune response, elevated inflammatory mediators, microangiopathy, advanced glycated end products, and proliferation of periodontal pathogens. So in case of any disease, oral health, specifically the periodontal disease, it's characterized by an increase in the levels of inflammatory mediators, which we know that, and host-derived mediators such as interleukin-6, interleukin-1 beta, prostaglandin E2, tumor necrosis factor alpha, and MMPs. When there is an increase in the level, definitely this elevated systemic inflammation eventually contributes to insulin resistance, which definitely brings about the suppression of insulin signaling pathway, leading to diabetic complications. Now, the severity of oral disease is directly proportional to the diabetic levels of individuals. Now, there are a lot of literature showing that the increased risk of hypoglycemia correlating with severe periodontitis, and also an increased HbA1c level in individuals with diabetes. We all know that HbA1c levels 4 to 5.6% is normal, 5.7 to 6.4% are the patients who can have the risk of having diabetes, and 6 to 8 onwards, the patients are diabetic patients but can be under control, and 8% onwards, the patients are chronic diabetic patients. So chronic inflammatory diseases like periodontitis definitely increases the circulatory inflammatory mediators, and this long-standing inflammation can cause insulin resistance, therefore by leading to hyperglycemic state. And chronic severe periodontitis has shown that, all the literature has shown that, predicted the development of diabetic complications. The most recent, we know that 2017 classification of periodontal disease condition has envisioned some of the periodontal biomarkers, including inflammatory mediators, as measures to augment the information provided by the standard clinical parameters to assess the grade and the associated systemic effect of periodontal disease in susceptible individuals. So this is basically the oral health. This is the pathogen of oral health, how it affects the pathogenesis of diabetes, and definitely it has got a correlation with the diabetic status as such.
Thank you, sir. And exactly, I will say I got your point that how these two things are related, and hope so that audience is also clear with that. But then as it is affecting the pathogenesis, does improving the oral health status tends to control or improve the glycemic status of the diabetic? So here also, since it is part of the pathogenesis, so does controlling the periodontal disease or oral disease, periodontal inflammation, it leads to a betterment of the diabetic status of the patient?
As we know that oral cavity is definitely the entry point to your digestive and respiratory tracts. And these bacteria can cause diseases. That is why body's natural defense and good oral health care, we all say that the regular brushing and flossing will keep bacteria under control. But without proper hygiene, bacterial can reach levels that might lead to oral infections, such as dental caries and periodontal disease, and even later causing elevation of the systemic levels of certain systemic diseases as such. So studies have suggested that oral bacteria and the inflammation associated with severe form of periodontal disease play a major role in certain diseases such as diabetes, atherosclerosis, rheumatoid arthritis, pulmonary infections, etc., which definitely lowers the body's resistance to infection, making oral health problems more severe. Now, periodontal attachment loss, we know that the bone loss due to severe periodontitis results in tooth loss and masticatory function, which in turn, loss of masticatory function can affect nutrition, as subjects with masticatory dysfunction experience changes in their dietary habits, usually incorporating more starch and fats and less fresh fruit and vegetables in their diet, specifically in geriatric population. Now, literature has shown that non-surgical periodontal therapy, irrespective of the type what we do, has a positive effect on improving the quality or improving the level of, lowering the level of the glycemic, bringing out a lower level of glycemic control. And non-surgical periodontal therapy has shown to influence glycemic control, evidenced by the reduction of HbA1c level up to 0.36%. Now, HbA1c reduction from the meta-analysis ranged from 0.27% to 0.48% at 3 to 4 months after periodontal therapy. And data have not been much on the effect for 6 months regarding the study pertaining to 6 months or more are insufficient. And there is no evidence to support that one periodontal therapy was more effective than another in improving glycemic control in diabetes patients. But definitely, the effect of periodontal therapy in diabetic patients has shown an improvement in glycemic level, as evidenced by the reduction of HbA1c levels in short-term intervals and 3 months follow-up. So to protect your oral care, we know that what are the practices normally we do to maintain the good oral hygiene. And definitely, depending upon the HbA1c levels, we can have frequent monitoring, which will definitely help the glycemic control. So maintaining the oral hygiene definitely plays a important role in controlling the glycemic level.
Thank you, Anil sir. So objectively, that's really appreciable. And just taking a minute to move forward to the next panelist, I'm happy to see many queries coming into the chat box, but I will just suggest that yes, keep on pouring in, but we will probably having answers to a lot of these queries during the discussion itself, as I'll be touching upon next of next sections in our discussion. So good to start with the NSPT as sir mentioned. So I'll move to Abhay sir, my third expert for the panel discussion. Good afternoon, sir. Sir, kindly, I will look forward if you can kindly elucidate on various clinical signs and symptoms, or the kind of case history, case finding that shall make us a little suspicious, make us suspect a diabetes, presence of diabetes in a patient who is actually not a known diabetic. And what should actually warrant us that we should look into we should ask for a complete diagnostic workup in that patient. What things in a dental clinic for us to look forward to, that we can suspect diabetes in this case.
Yes, so friends, looking at the close association of diabetes mellitus and the oral cavity, in fact, the oral diseases and especially the periodontal diseases, and also the valuable inputs by the previous speakers, Dr. Grover sir and Dr. Anil. It is, we all would realize the fact that both the diseases are closely related with each other. And if we go by the statistics, there are around 8% of the whole population which is affected with diabetes mellitus. And a step further, 4% of the entire population is suspected to be affected with diabetes. But then these patients are not aware that they have been affected with diabetes or maybe a pre-diabetic condition. So it is at most important for all of us to have a close watch, have a close observation on the patients who enter the dental clinics, and especially the patients wherein we come across patients above 50 years of age, because these are the patients who are most likely to be affected with diabetes mellitus. Now, going by the literature, the classical signs of symptoms of diabetes include polydipsia, polyphagia, and polyuria. Now, these are the things which are taken to be recorded in a proper medical history. And if one takes or records a proper medical history, one would realize the fact that patients do agree if at all they suffer from any of these symptoms, and they do tell the clinician, yes, that he is suffering from maybe increased thirst, increased craving for food, or maybe multiple or frequent urination, which otherwise the patient would not know that these are the symptoms of diabetes mellitus. And if we go on to observe the patient, 50 years and above age of the patient surely should be a suspicion. Then secondly, if the patient is obese, if the patient's waist circumference is increased, if the patient has a family history of diabetes, if any of his family members have been affected previously with diabetes, and if in a female patient there's a history of gestational diabetes, or maybe the weight of the offspring is more than 9 pounds, then definitely it should arouse suspicion in the clinician's mind. And so these are the patients which should be taken up for a complete diagnostic workup. Now, if we go by the other symptoms and other features, increased blood pressure, if a patient is hypertensive, if there is increase in weight loss in the recent past few months, if there is malaise, weakness, or lethargy in the patient is not feeling proper, he's not feeling fresh in doing his routine activities, if he has a sedentary lifestyle wherein he does not do physical activity for more than 3 days in a week, then these are the criteria wherein the patient should be taken up for a complete diagnostic workup for diabetes. Now, as far as the complications of diabetes is concerned, everyone of you is aware about the complications with regards to retinopathy, nephropathy, neuropathy, cardiovascular diseases, and of course, the altered wound healing. And going a step further, adding to this, the sixth complication, that is periodontal disease. So if the patient gives a history of any of these diseases, then definitely the question with regards to diabetes should be prompted to the patient, and his diagnostic workup should be taken up. As far as the oral findings are concerned, the patient do suffer from dry mouth, there's burning of mouth, and there's loss of taste sensation, and most of the time there is sticky saliva or pasty saliva, and the patient may suffer from halitosis. And this halitosis is typical in nature, wherein there is ketone or fruit odor to the halitosis which is present. And with regards to periodontal findings, definitely the severity of the disease would be on a higher side because of the immune changes which occur within the body, and the defense mechanism of the body is not able to respond to the microbial onslaught, and so the destruction is more as compared to the amount of local deposits. So in other words, if we want to say the local deposits and the destruction or severity of the disease are not commensurate with each other. We have a more severe disease in diabetic individuals when we compare it with non-diabetic individuals. And one of the most important diagnostic criteria, I would say, is multiple periodontal abscesses. Now, there have been cases which have been diagnosed into dental clinical setups, and the most common finding is the multiple periodontal abscesses. So the clinician should be aware of all these conditions, all these features, so that the complete diagnostic workup for the patients can be undertaken.
Right. So in your view, a very careful listening session and a very careful visual inspection, both should actually be the part of examination that can give, maybe for people who don't know that they are diabetics, maybe we can give them the first sign. Saying that, having said that, I will say, still for our knowledge sake, please brief us about what are the standard diagnostic criteria for a case of diabetes, what all tests we can look into. And apart from that, do you feel that there should be some device or some sort of arrangement for screening, like a point of care kind of device in the dental clinic settings, which can basically, where we can right away rapidly chairside, we can check the diabetic status if we have such suspicion, and then thereafter we can follow on into the standard diagnostic. Sir, please, what is your pick on that?
Yes, definitely. After going in for the clinical examination, a detailed clinical examination and proper observation of the patient, the way he walks into the dental clinic, would give us a lot of indications about the patient's systemic health, about the patient's general condition. Now, when it comes to your question, there are three different sub parts related to it. And the first and foremost is the diagnostic criteria as far as diagnosis of diabetes mellitus is concerned. Here, I would want to share the fact that there are two different conditions wherein we need to define the pre-diabetes and the diabetes, fully blown diabetes. In cases of pre-diabetes, we do have, in both of these cases, in fact, we do have quite a few methods by which we can evaluate the plasma glucose estimation. And first and foremost amongst this is the fasting plasma glucose estimation. Then we have the postprandial or 2 hours postprandial plasma glucose estimation. We also have the HbA1c levels, the glycosylated hemoglobin levels. We also have the random blood sugar estimation or a random plasma glucose estimation. Now, if in cases of pre-diabetes and impaired fasting glucose would be in the range of 100 to 125 mg per dl. In cases of impaired glucose tolerance, 2 hours post 2 hours post plasma glucose, it needs to be in between 140 to 199 mg per dl, whereas the HbA1c levels should be somewhere in between 5.7 to 6.4%. So if these are the levels present in between these ranges, then definitely one can diagnose these cases as pre-diabetes. And these are the people who need to take extra care so that their diabetic condition can be reversed. because if the physical activity is induced in these patients, then definitely there are all the chances that the condition of the patient may improve. His glucose levels may improve quite a bit. And when it comes to diabetes, the fasting blood glucose levels should be greater than or equal to 126 mg per dl. When it comes to fasting plasma glucose levels greater than 126 mg per dl, or in cases of post meal or 2 hours postprandial, it should be greater than 200 mg per dl. So these are the two ones. And the HbA1c levels, definitely if they are above 6.5%, then we can diagnose the case of diabetes mellitus. The advantage with HbA1c levels is that we get the entire picture of the patient's condition, the glucose condition, the blood glucose condition over a period of 3 months, 2 to 3 months. And the last and foremost is the random blood sugar estimation, wherein if the values are above 200 mg per dl, then definitely the patient is suffering from diabetes mellitus. Now, the second aspect of your question is regards to whether there should be a point of for diagnosis of diabetes mellitus in the dental clinic. Definitely looking at the close association between the two diseases, we need to have each and every dental clinic equipped as a center for diagnosis of diabetes mellitus. Though we may not have all the techniques, we may not have all the equipments which are required for it, but definitely if we go in for, there are two methods by which we can very well screen the patients as far as diabetes is concerned. The first one is the blood capillary method, wherein by the use of glucometer, which many of you would be utilizing in their respective homes, wherein your elders, your parents, or maybe your grandparents may be utilizing these techniques on a regular basis. So that is one of the methods. The second one is HbA1c levels, but then having an HbA1c analyzer for analyzing HbA1c levels in a dental clinic would add up to the cost of the patient as well as to the cost of the clinician. So these are the two methods by which we can screen the patients as far as dental clinics are concerned, and having a screening for every patient of which we are suspicious of is an essential, is a mandatory thing as far as dental clinics are concerned.
Yes, sir, I believe because both the diseases being so prevalent, and there's a high chance that we as dentists very often witness such patients in our practices. So I think it is a good go, because that will lead to an early identification, early referral, early diagnosis and management that actually reduces the morbidity of the disease. I feel that's really very well said. Sir, thank you so much, Abhay sir. Next on board, I'll call upon Dr. Neeraj sir to share my next query. Sir, once we are done with that, there is a patient who is diabetic, and we are to attend to him in our dental practice. So for such a patient who is a known diabetic, is already on medication, maybe having oral hypoglycemic, maybe on insulin, what do you suggest are the best timing or best management kind of protocol, that how we should deal with such patient, so that we should minimize the risk of their hypoglycemic episode, because these patients are known to be having lot fluctuation in their glycemic level.
Right. Basically, when we encounter or come across the diabetic patient, first we have to see the past reports and do some screening. As Abhay sir has rightly told, that we should have some self-monitoring blood glucose tools such as glucometer in the clinic, wherein we can do the screening. And even if patient has some past report, first we have to ensure whether patient is a well-controlled diabetes or poorly controlled diabetes. If the patient is well-controlled diabetes, then we usually go ahead with the conventional treatment. If the patient is poorly controlled diabetic, then we have to refer the patient to the physician and get the sugar level controlled. And now, second aspect of planning the appointment for such patient, diabetic patient. In general, the patients with the diabetes should schedule, for such patient, we should schedule the appointments in the morning time, because there are some endogenous cortisol levels which are higher during the morning time. And what cortisol does, it raises the blood sugar level, thereby decreasing the risk of hypoglycemia, because hypoglycemia at times is very lethal in a dental clinic.
Yes.
Secondly, appointments for the patients who are on short or long-acting insulin should be arranged in such a way that they do not interfere with the peak insulin activity, which increases again the risk of hypoglycemia. Now, thirdly, it is crucial that when such patients, you give appointment to the diabetic patient, they have eaten normally. They should have their normal diet and should have taken all the drugs, diabetic drug, before they come to the clinic. Because missing onto any of the aspect, food or take a drug, may end up patient into a hypoglycemic or hyperglycemic episode. So instruct the patient to have a good normal diet and have taken medications before coming to the clinic. If you have a procedure wherein you have to modify or alter the diet of the patient, like for example, if you want to do any conscious sedation procedure where you have to ask patient to come nil by mouth or something, like alter the patient's diet, then in such cases you have to consult the patient physician, and accordingly you have to alter the medication before you plan the appointment for the patient. So only in such cases wherein you have to alter the diet of the patient, what we need to do is we have to have a consultation with the patient physician and alter the medication, because then again that should not result in the hypoglycemic episode. And then when we plan any of the surgical treatment for the diabetic patient, if the patient is well controlled diabetes, we treat or do all the surgical treatment as a conventional therapy, as a conventional patient. If the patient's food intake may be compromised because of any of the oral or dental surgery, then we should have a backup plan wherein if we are not able to, if we have to ask patient to alter the diet, then we have to devise some therapy wherein we have to give the patient some alternative medications to compensate that aspect. But otherwise, in general, as a rule and as a advisory, morning appointments are always preferable for such patient.
Right. So well-controlled diabetics are as good as any
Routine.
normal individual
Yes.
for us to treat.
Yes,
but
routine
yes, moderately controlled or anybody with a known history of diabetes, we need to be careful for and in
Yes.
physician consultation.
Yeah.
That's right. Right, sir. Thank you so much, sir. Next, sir, Dani, sir. I'll call upon you because I need your expert opinion on a very, I will say, controversial, little debatable thing, that use of antibiotics, which is very commonly actually talked in context of diabetic individuals. What do you suggest that the use of antibiotics in these patients, does it give us any additional benefit while we treat them, or in your view, in what all conditions we should recommend the usage of antibiotics while we manage them for dental disease?
Good afternoon, everybody.
Yes, sir. Yes.
And good afternoon, Vishaka. Thank you very much for asking a very pertinent question.
Yes.
Because we all know dentists in general and Indian dentists in particular are a much maligned lot, because we indiscriminately prescribe antibiotic for each and every dental condition. And especially talking about antibiotics during periodontal treatment, I'd like to categorize the use of antibiotics first, whether it is used as a therapy, that is a treatment for periodontitis, or whether it is used as prophylaxis to prevent either bacteremia or prevent any post-operative infection.
Right.
So now looking at the therapeutic point of view, we all know that periodontitis cannot be treated by antibiotic as a monotherapy. If at all, it has to be used as an adjunctive therapy. But even in adjunctive therapy, it is really not advised to use antibiotic for any mild to moderate type of periodontitis. If you have a severe case or a case what was known as a rapidly progressing type or an aggressive type in the past, where we suspect some tissue penetration of bacteria, especially
Hi. As we all know, the periodontal disease is one of the integral part in dentistry, and the survey shows that 95% of the population are affected with periodontal disease. Here, we as a periodontist are taking an effort to get into the masses of the population to create an awareness among the general public and to create an impact as well as on the treatment line and to create an impact on the urban as well as the rural population in the coming years. So, we are creating an attempt as a President-elect of Indian Society of Periodontology to have a proper screening, charting and a treatment line for the patients and to have a benefit for them as such. Thank you.
Friends, periodontal disease leads to loss of teeth, and this loss of teeth has to be rectified by way of placing artificial teeth. And who else better than a periodontist would be able to restore the teeth, and this by way of dental implants. Dental implants has been aggressively being practiced these days into dental clinics, and periodontist is one of the best specialists in terms of practicing implant dentistry because he knows the details nuances and also the structures which are involved into placement of dental implants. So whenever you are experiencing dental loss or tooth loss, better go to a dental surgeon and go in for dental implant therapy. Dear friends, on behalf of the Indian Society of Periodontology, I wish to inform you that according to the data of WHO, we have 80% of our population which is affected with some or the other sort of periodontal diseases. Periodontal diseases are gum diseases and which increase in severity and lead to periodontitis, which ultimately leads to tooth loss. So, if we consider the huge population, if we consider our country as the second most populous country of the world, then definitely it's a huge healthcare burden over us. And if we consider the clinical data, it reflects that very less number of patients are being treated for periodontal conditions into our clinical practices. And this is basically because of the fact that we devote less time into diagnosing these conditions. Since these conditions are asymptomatic conditions, there is a great possibility of them being missed upon in the initial examination. So, I would request all of you to devote adequate time into diagnosing these conditions at the initial screening visits so that we would be able to provide a healthy periodontium and a healthy masticatory apparatuses to our patients. Thank you.
Aesthetic and smile designing is incomplete without the proper care of the pink. The judicious balance of white and pink is a prerequisite for aesthetic periodontal outcome. The various aesthetic periodontal surgeries, various aesthetic periodontal treatments like periodontal plastic surgery and even the newer advances in periodontal microsurgery are very handy in comprehensive aesthetic periodontal care for the patients.
India happens to be the diabetic capital of the world. India also has the largest population of hypertensive. Alongside India also have the highest prevalence of periodontal disease. Of late, the literature is flooded with the correlation of periodontal health and the systemic health. There have been enough evidence everywhere around the world with conferences, with workshops, with consensus meetings happening together, wherein it has been almost conclusively said that a poor oral health, a poor periodontal health can actually worsen the systemic health as well. So within the Indian perspective, Indian Society of Periodontology takes the lead, takes the charge and makes sure that all of our brother dentists are aware enough for not only diagnosing the patient from the periodontal point of view, but also giving him a good oral health so that he can live well, he can have a good systemic health also.
I'm a periodontist. A periodontist is someone who is a gum specialist. As we all know, teeth are held in the mouth because of the strong gums. And if the gums are not strong, the teeth will tend to fall off. In India, a lot of people suffer from gum diseases. Almost 80% of the adult population has some form of gum disease or the other. One of the points regarding gum disease is that it is entirely preventable. So if you visit a dentist regularly and get all the regular checkups and treatment done, you can have a teeth that will last for a lifetime. You need not wear any false teeth or dentures, and you can chew happily ever after and have a well balanced diet. The key to it is that you must have good oral hygiene practices, clean your teeth regularly, and visit a dentist and do all the treatment that is recommended by a dentist.
Now, we have our branch is periodontology, and basically it deals with the structure which is called as periodontium, which in common terms, which means the structures which support the teeth. Now, a structure which supports the teeth means that if tooth has to remain in oral cavity, the structure have to be in a healthy state. Now, we always, as you know, concentrate on treatments like orthodontics, that is treatment of malocclusion, root canal treatments. We have FPDs, RPDs, replacement of all these, missing teeth, which gets concentrated too much. But if we go to the background of this and we realize that, can we have an orthodontic treatment without a healthy periodontium? After all, movement of teeth is just based on bone and periodontal ligament, which is a part of periodontium. Have you asked any endodontist, would they do a root canal treatment in a mobile tooth? They will not, because after they see an X-ray and they see the extent of caries, the next thing which they see is the amount of support which is present. Take a tooth to them which is mobile, and the thing they will ask is whether the prognosis is good or not, whether we should do a root canal or not. So that
Good to go, 12 o'clock?
Yes, sir.
Yeah, you're on.
Good noon to all of you. Now we are moving to our next session. Exactly my point, your take, with Dr. Arun Gomes as moderator. Professor Dr. Arun Gomes is a BDS alumni of the Goa Dental College and MDS alumni of the Government Dental College and Hospital, Nagpur. Having obtained his master's degree in periodontology under the guidance of Professor Dr. R.K. Yeltiwar at the Nagpur University, he joined academics at the PMNM Dental College, Bagalkot in 1995. After academic stints at Al-Amin Dental College, Bijapur, and SDM Dental College, Dharwad, he is presently heading the Department of Periodontology and Oral Implantology at the Uttaranchal Dental and Medical Research Institute, Dehradun. He has conducted CDE programs in periodontology and has many national and international publications. Over to you, sir.
Very good afternoon to you all, and thank you, sir, for your kind words. And without much ado, we shall start our presentation. So, a warm welcome to all of you all to this mini symposium, exactly my point and your take. And we have on our panel today two academicians par excellence, Professor Dr. Shiva Manjunath, who is alumni, BDS alumni from the College of Dental Surgery at Mangalore, and an MDS alumni from the Government Dental College at Bengaluru. And he's presently heading the Department of Periodontology and Oral Implantology at the Institute of Dental Sciences at Bareilly. And also on the panel, we have Professor Dr. Vivek Bains, who is a BDS and MDS alumni from the Government Dental College and Hospital at Patiala, and presently heading the Department of Periodontology at the Saraswati Dental College and Hospital, Lucknow. Welcome, Professor Shiva Manjunath and Professor Dr. Vivek Bains. And warm welcome to all of you all. With the permission of the chair, we would like to start this topic, which is periodontitis and heart attack. Is it a myth? Is it a reality? We know that cardiovascular disease, which encompasses atherosclerotic diseases, coronary artery diseases, cerebrovascular diseases, peripheral vascular diseases, and in their fatal sequelae, it always mostly leads to heart attack. And cardiovascular disease amongst the non-communicable diseases accounts for about 41 million deaths, or 71% of all global deaths. In fact, according to the report of the World Heart Federation of 29 September 2020, it is around more than 75% of cardiovascular deaths take place in low and medium income countries. It is inclusive of 45% of non-communicable disease-induced mortality. And if you look at the Indian context, according to the Institute for Health Metrics and Evaluation, as recently as 15th April 2021, if we include communicable and non-communicable, including RTAs, that's road traffic accidents, you have ischemic heart disease and cerebral stroke accounting for as much as nearly 35,000 deaths per week. And if you look at the risk factors of cardiovascular disease, it encompasses high blood pressure, unhealthy diet, including high cholesterol, sedentary lifestyles, use of alcohol, use of tobacco, diabetes. But these are modifiable. And along with that, there is chronic elevations in the systemic inflammatory burden as causally related to cardiovascular disease development, and sometimes it's fateful sequelae. And is this inflammatory burden due to periodontitis, which is also a non-communicable disease said to be 6th most common human disease in the world? Can this periodontitis be considered a modifiable, a non-traditional risk factor for cardiovascular disease? And this is exactly what we are going to discuss in this symposium, whether this is a myth or a reality. Is it causal, whereby the chronic inflammatory environment elicited by periodontitis, can it potentiate an inflammatory condition leading to cardiovascular disease? Or is it just non-causal, wherein both of them, they share risk factors like smoking, diabetes, age, sex, genetic background, and psychosomatic disorders? So if you look further, we see a lot of literature linking periodontitis as a risk factor for coronary heart disease. Starting from the 1998 of Beck et al., then the Person and Person article in 2005, even the consensus statement from the editors of the American Journal of Cardiology and the Journal of Periodontology in 2006, leading to a World Congress of the American Academy of Periodontology and the European Federation of Periodontology, and a lot of articles in 2010 with respect to that. And this was a photograph of the people at the World Congress. And more recently, a Congress wherein the European Federation of Periodontology, along with the World Heart Federation, released a consensus statement as recently as 2019. So on our panel, we have got Professor Dr. Shiva Manjunath, who will be discussing whether people with periodontitis, do they have a higher prevalence of subclinical cardiovascular disease, coronary artery disease, myocardial infarction, coronary events, and peripheral artery disease. Remember, all these lead to fatal sequelae like heart attack, which is the topic of today. As well as we would like to know from Professor Shiva Manjunath whether people with periodontitis, do they have a higher risk of cardiovascular disease sequelae, fatalities, cerebral stroke, heart failure, atrial fibrillation? Do people with periodontitis and already having a history of cardiovascular disease, do they have a higher odds ratio, a higher hazard ratio of experiencing a second coronary event which could be fatal? Do people with a history of cardiovascular disease have a different incidence or a different progression of periodontitis? Are there mechanisms wherein there is a higher incidence of the pathognomic bacteria of the periodontal disease causing a bacteremia following oral functions or interventions in periodontitis patients as compared to healthy patients, periodontally healthy patients? And do these bacteria which are associated with periodontal disease, are they present, or are there virulence factors present, or their products present in atheroma lesions? And then later on, Professor Dr. Vivek is going to take us through the pathophysiology of atherosclerosis. He will look at the cellular and molecular level, wherein the bacteria or the bacterial products and virulence factors, are they involved in the pathophysiology of formation of atherosclerotic plaques? When I say plaques, I don't mean dental plaque here, I mean the atheromas. Is there an increased production or levels of inflammatory mediators in periodontitis patients? And to wind it up, we shall just look at the cardiovascular risks and complications of periodontal therapeutic interventions. So much for the introduction. I hand over the floor to Professor Dr. Shiva Manjunath. Please carry on, Dr. Shiva.
Thank you very much, sir, for the wonderful introduction. I think you just set the right track of today's topic. So before starting, I would extend my thanks to the ISP for giving the opportunity to share my views on this very demanding topic. So exactly my point of view take. A topic where does there any link between periodontitis heart attack or myth or a reality? Now, today's sessions, you will understand that more than anything else, the evidence which is available right now, it cannot be a myth. It most likely a reality. With that, we'll just move on See, as Dr. Aaron already explained, cardiovascular disease is a group of disease, right? So it is consist of coronary heart disease, cerebrovascular disease, peripheral disease, rheumatic heart disease, congenital heart disease, deep vein thrombosis, and so on. When today's topic is will periodontitis will cause a heart attack? By knowing before that, cardiovascular disease has got a multiple reasons for it to happen in a heart attack. Now, an estimated 17.9 million people have died from cardiovascular disease in 2016, representing the global death. Of this, 85% were due to heart attack and stroke. See, this is in 2016. By now, the statistics must have been really increased. In India, it was more than 63% of non-communicable disease. The major chunk is about cardiovascular disease. So where are we talking about the statistics of cardiovascular disease? Point is, what is the burden which is going to happen on the public, on the society, on the country? The global cost of the cardiovascular disease is said to be approximately $1,044 million. You just can't even think the amount of the burden which is going to happen to the society. Trust me, WHO is already declared by 2030, we will be the capitals of diabetes and cardiovascular disease. So the amount of expenditure is going to be on the population is very high. Are we connected as a periodontist to this? Where are we connected to this? That's what today we are going to talk about. When so much of evidence available from the hunter, the poke of infection theory, long back, probably from 1920 and onwards, even till Offenbacher, when he explained about the link of systemic disease and the oral cavity, several thousands and thousands of research have been done. Hundreds of articles of a high standard evidence is available. But what do we take? What exactly we should understand? It is all about the meta-analysis and systematic review, which has been wonderfully explained in the recent literature. So we need to do an evidence-based practice. For that, we need to have an evidence-based literature. Any postgraduates who are going to listen to this should go through this couple of articles. Wonderfully written articles, that is periodontal disease and association of atherosclerotic diseases, periodontitis and cardiovascular disease as a consensus report, and so on. And if you read this, you will have a clear-cut picture on what exactly the link between these two things. Okay, let's talk about it's a periodontitis per se itself. Periodontitis is also a non-communicable disease with a high prevalence of 45% to 50% overall. The most severe form is about 11.2%. Now, there is now a significant evidence to support independent association between severe periodontitis and several non-communicable disease, including diabetes and cardiovascular disease. My dear friends, this is explained in Trinity in 2014. But trust me, the incidence and the prevalence is not that low in India. It is higher. So, but only thing is we don't have any substantial final reports in that what is the amount of periodontal disease we have in our country. To know all that, you need to have an evidence on the association between periodontitis and cardiovascular disease. Now, Didar et al. In 2014 explained in an article of Journal of Atherosclerosis, does any people with the severe periodontitis have a higher prevalence of subclinical cardiovascular disease? Now, whenever there is a periodontitis, the byproducts of the periodontitis, the microbial of the periodontitis, and the inflammatory cytokines, which is going to have an effect on the endothelial dysfunction. How do you measure the endothelial dysfunction? By a flow-mediated dilation, arterial stiffness, greater thickness of carotid intima media, and elevated arterial calcification score. By this, we can assess that there is an endothelial dysfunction, and this gentleman found out that whenever there is a severe periodontitis, these features were very much evident. Now, this is another wonderful article by Dietrich et al. In 2013, wonderful systematic review. He explains that an increased risk of first coronary event in patients with clinically diagnosed periodontitis or more severe periodontitis compared to the patient with less periodontitis. And there is a strong association between periodontitis and a higher cardiovascular mortality. He compiled 20 to 30 studies and he finally gets the information on the basis of randomized control trials, on the basis of case control studies. There is a substantial evidence saying that there is a strong association between periodontitis and the higher cardiovascular mortality. Now, this is another beautiful study by Taiwanese National Health Insurance Research. More than few lakh samples were taken from the insurance data, and they found out that there was a strong association of cardiovascular disease, particularly about atrial fibrillation and congestive heart failure with the periodontitis patients. This is not a 1 or 2 samples. It is about almost like about 8 to 9 lakhs subjects were the data were taken. And this was explained by Chin Lin et al. In a nationwide population-based cohort study. Now, do we have an evidence of a higher incidence of bacteremia following oral infection or oral function? We all know by now, so much of this we have gone through again and again. A simple function like toothbrushing, flossing, chewing, biting an apple causes oral bacteremia. This was explained by Toms et al. And later in Balijo in 2017, in the randomized control trials, concluded that periodontal therapy induced bacteremia in both gingivitis and periodontitis patients, but the magnitude is more in the periodontitis. So what does it do? When there is a bacteremia, this will go into the circulation and it will cause an endothelial dysfunction. Now, what is the evidence? This should be the strongest evidence to say that there is no direct connections. Now, we know that hypothetically, the periodontal pathogenic bacteria, which transfers and reaches to the endothelial dysfunction and causes atheroma. Now, from the atheroma, the tissues have been taken and subjected for a test of DNA and RNA of the microbial flora of the periodontal pocket. And it was found that that was the same kind of a DNA and RNA which was seen in the atheromas also. This was explained by Armingor et al. And it is demonstrated that P. gingivalis and AA tissue, it's found in the atherothrombotic tissues when culturing atheroma samples. Now, it's not that that's it. We found atheroma and there is a presence of the same amount of bacteria. We don't have much studies where these bacteria again placed into the different individuals and induce atherosclerosis. It is ethically not possible, legally not possible, but in some of the animal studies where it was found that P. gingivalis has been shown to accelerate atherosclerosis in the murine models to induce fatty streaks in the aorta and induce aortic and coronary lesions after bacteremia of a normocolistomic pigs. So a polymicrobial infection was shown to induce aortic toll-like receptors and inflammasome signaling with an oxidative stress reaction generated by aortic endothelial events. P. gingivalis to host cell entry and promote atherothrombotic lesions in an experimental models. That is enough to say that these toll-like receptors, which is being produced in the aortic endothelial surface because of the periodontal pathogens. Now, we all know it, there is a levels of inflammatory mediators and which can increase in the periodontitis, can lead to the pathophysiology of the atherosclerosis. How does it happen? There is an evidence of significantly higher level of fibrinogen periodontitis patient versus healthy controls. We all know that the fibrinogen is going to cause some kind of an atherosclerotic changes. Later in Sibra et al. Also explained wonderfully about the role of acute phase proteins, especially when a severe amount of periodontitis happens. It stimulates the acute phase reactants, and this acute phase reactants will lead to the formation of there is atherosclerotic changes. Periodontal therapy appears to result in a significant decrease in the fibrinogen level. That indirectly says that periodontal treatment will reduce the chances of atherosclerotic changes. There is evidence from different studies of significantly higher level of platelet activation markers in periodontitis patients and will be reversed by periodontal treatment. Now, this is something which all of us, any research student will love to know about this. Do we have any genetic link? Yes, there is a highly pleiotropic genetic locus, CDKN2B, AS1 chromosome 9, P21.3 is the location where associated with the coronary artery disease, type 2 diabetes, ischemic stroke, Alzheimer's disease is also consistently associated with the periodontitis, which is explained very well by Arabi et al. In 2019 and Munz et al. In 2018. And also, there is a strong link of some of the genetical factor, which is something like plasminogen as a shared genetic risk factor with the coronary artery disease and also with the periodontitis, explained by Schaefer et al. These shared genetic factors suggest a mechanistic link of immunological commonalities between coronary artery disease and periodontitis. Now, this is something which is very nice. Evidence from interventional studies. Until unless we don't have any interventional studies, we don't have a proof. Several recent evidence says that there is an evidence for interventional study. That means what? The periodontitis is causing an atherosclerosis changes, and if you treat periodontitis, the chances of atherosclerotic events will be reducing. It is not one or two, several hundreds of studies have been proved that there is a decrease in the cardiovascular unwanted events if there is a periodontal treatment. Both primary prevention and secondary prevention has been done, and lots of studies have been explaining, and this definitely Dr. Aaron is going to touch upon at the end of this presentation. So with all these things, I would like to conclude that there is a consistent and strong epidemiological evidence that shares the periodontitis impacts increased risk for future atherosclerotic cardiovascular disease. The impact of periodontitis on atherosclerotic cardiovascular disease is biologically plausible, and translocated circulating oral microbiota may directly or indirectly induce systemic inflammation that impacts the pathogenesis of atherothrombogenesis. Several evidence suggests that primary and secondary interventions in periodontitis can reduce the possible risk of atherosclerotic cardiovascular disease. So, the overall one step ahead, a periodontal health can lead to an overall health. With that, I'm thanking all of you for patience listening, and thank you very much for ISP for giving the opportunity to share my views. And Dr. Aaron, over to you.
Yes, thank you, Dr. Shiva. And thank you for that insight into the epidemiological associations between periodontitis and cardiovascular disease and the sequelae, as well as the possibility, the evidence with respect to the biological plausibility relating bacterial infection and systemic infection to cardiovascular disease. I hand over the floor now to Dr. Baines, and it's all yours, Doctor.
Dr. Vivek is being audible.
Dr. Vivek, maybe you have to unmute yourself.
Hello, am I audible now?
Yes, you're audible now, Dr. Vivek.
Thank you. Good afternoon, everyone. Thank you, Dr. Aaron, and thank you, Dr. Shiva, for providing the insight to the topic. Now, let me start with my presentation, that is giving the biological possibility linking the periodontitis with a heart attack. A heart attack occurs when the heart muscle doesn't get enough blood supply, and coronary heart disease is the leading cause of heart attack, in which the coronary arteries become clogged with the atheroma, resulting in atherosclerosis. So thus, atherosclerosis is the underlying pathogenesis of heart attack and other cardiac events, and it is the leading cause of death in Western world. And now, in Indian subcontinent, prevalence is increasing due to changes in the lifestyle. It is important to understand the pathogenesis, as it is critical for establishing the causality, for the identification of the patient populations that may benefit from periodontal intervention, for the design of the relevant treatment strategies. The pathophysiology and the biological plausibility linking the two can be better understood based on various mechanistic studies. Now, atheroma is an abnormal accumulation of the material in the inner layer of the artery. It consists of the fibrous capsule composed of the smooth muscle cells and the collagen covered over the soft grammatous core of the lipid. Various hypotheses has been given for the atherosclerosis, amongst them response to injury hypothesis by Ross in 1973 and inflammatory hypothesis are most popular hypotheses. Cellular components of the atherosclerosis include endothelium, smooth muscle cells, monocyte-derived macrophages, T lymphocytes, and platelets, and cellular interaction between these cells results in atherosclerosis. This is a schematic diagram showing the mechanism of the atherosclerosis. In response to the injury, endothelial dysfunction occurs that results in increased permeability, leukocyte adhesion, monocyte adhesion and immigration, further results in macrophage activation and smooth muscle recruitment. This results further in the formation of the foam cells by the engulfment of the lipid low-density lipoproteins by the macrophages and the smooth muscles, and further final formation of the atheroma. Depending on the fibrous cap, thin or thick, outcome may be come. Now, the interlink between the pancreatitis and the cardiovascular disease may require the understanding of the endothelial dysfunction, role of monocytes, lymphocytes, mast cells, pattern recognition receptors, inflammasomes, mitochondrial dysfunction and the oxidative distress, and lipid peroxidations. Endothelium in normal condition have tight endothelial cell junctions. Vascular tonicity is maintained by the vasodilators and the vasoconstrictors. Non-adherence of the inflammatory cells is there, and there is inhibition of the platelet aggregation. However, when the injury occurs, laminar flow becomes oscillatory flow and endothelium becomes activated. There is increase in the permeability and increased recruitment of the leukocyte into the intima. Monocytes play important role in atherogenesis. In normal arterial endothelium, it resists the contact of leukocytes with the endothelium. However, in the inflammation, adhesion molecule expresses and monocyte adhere to the endothelium and then migrate into the intima, where they get converted into the macrophages and scavenge the low-density lipoproteins and converted into the foam cells. Similarly, Toy lymphocytes also plays important role in atherogenesis, and they enter into the intima under the influence of the chemokines, where they are encountered by the antigens of endogenous and microbial origin and releases pro-inflammatory cytokines or anti-inflammatory cytokines. Further, crosstalk between the T lymphocytes and mononuclear macrophage may result in the release of the mediators from the macrophage. Similarly, mast cells also play a role in the atherogenesis, and it enters into the intima, where they get degranulate and release various mediators that increases the inflammation and conversion of angiotensin 1 to angiotensin 2. Further, the pattern recognition receptors are important for recognition of microbe-associated molecular pattern, damage-associated molecular pattern, and hemostatic altering molecular patterns. Two types of pattern recognition receptors are the plasma membrane and endoplasmic receptors that are toll-like receptors which activate the nutrient factor kappa B and interferon gamma, interferon regulatory factors, and C-type lectin receptors. And another is the cytosolic receptors that includes NOD-like receptors and the RIG1 and cytosolic DNA receptors. Inflammasomes are macromolecular multiprotein intracellular complexes consisting of NLRP3, adaptor, and caspase. So they are activated by the DAMPs or by the nuclear factor kappa B signaling and resulting in the maturation of interleukin 1 beta and interleukin 18. Further, mitochondrial dysfunction may occur when in order to accommodate for the function, there may be fusion and the fission in the mitochondria. An imbalanced activity of the fusion and the fission results in loss of oxidative phosphorylation, mitochondrial depletion, and ROS production. Further, the impairment in the removal of the damaged and the dysfunctional mitochondria leads to accumulation of the DAMPs, and that further increases the inflammation through toll-like receptors, NOD-like receptors, or the STING DNA sensing system. Lipid peroxidation also play an important role in atherogenesis by endothelial dysfunction, foam cell formation, smooth muscle cell proliferation and migration, and pro-atherosclerotic function of the platelets. Capsule et al. Provided a potential mechanism linking the periodontal infections with the endothelial dysfunction. This schematic diagram suggested that P. gingivalis with fimbriae can invade into the endothelial lining, where they can survive and replicate. Further, they can result in the endothelial activation expression of the additional molecules, secretion of the cytokines resulting in the monocytes recruitment into the intima. Further, P-gingivalis activate the autoimmune response via the molecular mimicry, resulting in the destruction of the endothelium, and endothelial cell apoptosis can occur. Further, the Proforma gingivalis may result in the plaque maturation by the release of by smooth muscle proliferation, extracellular matrix synthesis, neointima formation, and macrophages apoptosis. This can further result in the rupture of the plaque by endothelium apoptosis, and as well as by the macrophage apoptosis. This can further result in the release of the matrix metalloproteinases from the mast cells and the T cells. Shanklin and the Luce summarized the inflammatory mechanisms linking the periodontal disease to cardiovascular disease, and they proposed because of pancreatitis, a host immune response results in increase in the pro-inflammatory state, innate and the adaptive immune system, dyslipidemia and lipid peroxidations, prothrombic state, and cross-reactive autoantibody due to molecular mimicry. Recently, in the 2020, in Herrera in 2020, summarized in a narrative review about the evidences for the microbiological mechanisms in atherosclerosis. It suggested that parodontopathogens can reach the systemic vascular tissues. Parodontopathogens can reach and colonize the atheroma plaque. Parodontopathogens can induce or promote the atherosclerosis in animals model of the disease. Live parodontopathogens detect in the atheromatous plaque, and in vitro evidence of invasion of pathogens in endothelial cells. In vitro and in vivo evidences that non-invasive mutant causes significantly reduced pathology in animal models. Periodontal isolates from human atheromas can cause disease in the animal models of the infection. They further summarized the various systemic markers in the periodontal link atherosclerosis that have evidences. And these are the markers which are actually, for which the evidence is available. These are the C-reactive proteins, interleukins, matrix metalloproteinase 8, nitric oxide, thrombotic and hemostatic markers like fibrinogen, antiphospholipid antibodies, low density lipoprotein, total cholesterol, high density lipoprotein, oxidized lipoproteins as associated phospholipase, adiponectin, etc. Now, what is the take-home message from the presentation? The emerging scientific evidences are available for bacteremia and bacterial end products, vascular endothelial activation and degeneration, common risk and the genetic susceptible factors leading to increased inflammatory responses, activation of the innate immune signaling, prothrombotic and procoagulant events, oral bacteria may cause atheromatic plaque disruption, autoimmune response to the periodontal bacteria, lipopolysaccharide mediated mitochondrial dysfunction, and induction of the oxidative stress and lipid peroxidation. In the end, exactly my point is evidences are emerging to prove biological plausibility for periodontitis-linked atherosclerosis, and more emphasis is required for translation of bench research to bedside research. Further, we periodontists may, rather should contribute in the improvement of overall health of the mankind by controlling the periodontitis, which is a modifiable risk factor. That's all from my side. Thank you. In the end, I would like to thank everyone and ISP for providing me the opportunity.
Thank you, Professor Dr. Vivek Bains. That was a very insightful presentation at a cellular and molecular level of the association of periodontitis and cardiovascular disease, be it in the endothelial dysfunction of for the pathophysiology of atherosclerotic plaque, or the molecular mimicry of putative periodontopathogens and their products like Porphyrimus gingivalis in the causing of the atheromas. So we shall now continue with the final summary, and yes, so I thank Dr. Professor Shiva Manjunath and Dr. Vivek Bains And we have got a few take-home points from the various literature that they have seen, wherein there is a strong epidemiological evidence that periodontitis or periodontal diseases imparts an increased risk for future atherosclerotic cardiovascular disease and their fateful sequelae. Dr. Shiva Manjunath has further talked about the impact of periodontitis on cardiovascular disease. It is biologically plausible because of translocated circulating oral microbiota, and that periodontitis can induce systemic inflammation. And Dr. Vivek Bains has shown that how this induces endothelial dysfunction and impacts upon the development of atherothrombogenesis. But what we didn't talk about was peri-implantitis and cardiovascular disease. Is there an association? Yes, both of them have inflammation as a component of both. However, there are too few studies and absolutely no meta-analysis analyzing this relationship. So I would recommend you, all you young postgraduates, as soon as you'll pass out, maybe you all can take this up as a research topic. And maybe the Nobel Prize nomination is waiting for you if you can prove that. However, a lot of authors till date have shown that as such, there is no association proved. So basically, a take-home point is periodontitis, is it a comorbidity in cardiovascular disease? We have seen that periodontitis is a modifiable risk factor of cardiovascular disease and its sequelae. So, since it's a modifiable risk factor, can we reduce the incidence of cardiovascular disease, or rather the sequelae of atherosclerotic cardiovascular disease? Can we reduce it by increasing the frequency and the efficiency of toothbrushing, increasing our efficiency of dental prophylaxis, increasing dental visits, increasing the periodontal efficiency of periodontal treatment? If you look at the De Oliveira study of 2010, which was a Scottish health survey done in close to 12,000 men and women with a mean age of 50 years, they saw that those people who self-reported that they toothbrushed less than one time a day, they had a hazard ratio of 1.8 times those who reported that they toothbrushed more than twice a day. In other words, 59 of the 538 people had a cardiovascular problem, the emergency during the scope of this study, while only 308 of 8,500 nearly participants who brushed twice a day had a cardiovascular emergency. Similarly, the Holmlund et al. Study of 2010, wherein they checked about 9,000 patients with periodontitis, and those who are poor responders to treatment, they identified that they had a greater incidence of atherosclerotic cardiovascular disease events. Therefore, they concluded that if you can perform successful periodontal disease, you could probably reduce the incidence of atherosclerotic cardiovascular disease events. Similarly, the Sen et al. Study, or the atherosclerosis risk in communities study, which analyzed just under 7,000 participants over 15 years, they showed that regular dental care had a lower risk for ischemic stroke. And the Korean study, that is the Korean National Health Screening Study of Park et al., showed that an increased presence of periodontitis or dental caries lesions had an increased risk of future major cardiovascular events, which included death, which included acute myocardial infarction, heart failure, and stroke. What about the effect of preventive periodontal treatment on cardiovascular disease events? Yes, the progression of atherosclerotic cardiovascular disease may be influenced by successful periodontal treatment, according to the consensus statement of Singh et al. And do the periodontitis treatment change surrogate parameters of cardiovascular disease? Moderate evidence. As far as improvements in endothelial function, absolutely no effect on lipid fractions, and a sort of limited evidence whether this successful treatment of periodontitis will reduce arterial blood pressure, subclinical atherosclerotic cardiovascular disease, and absolute insufficient evidence where it will change the biomarkers of coagulation, endothelial cell activation, and oxidative stress. So, what are the recommendations that we can give physicians who are treating cardiovascular disease people? So, patients with cardiovascular disease should be advised that periodontitis may have a negative impact on the cardiovascular disease progression and increase the risk of cardiovascular disease emergencies. The effect of periodontal therapy may therefore have a positive impact upon cardiovascular health. This is what we have to impress upon our brethren from the cardiology wing. But we also have to tell that patients who have an extensive tooth loss should be encouraged to pursue dental rehabilitation such that they can restore their adequate mastication for proper nutrition. So physicians should be advised that they should tell their patients with cardiovascular disease, ask them about a prior diagnosis of periodontitis, ask them about signs and symptoms contributing to periodontitis, and if they have a positive history of either, then a periodontal evaluation is required ASAP. If there is a negative history, then they should seek one in time and seek appropriate periodontal care and maintenance. What about recommendations to the oral health professional? They should be advising patients with periodontitis that they are likely to be at a higher risk. I said likely because it's not absolutely certain. They are at a higher risk for cardiovascular disease, and that they should manage the cardiovascular risk factors, which are not only smoking, sedentary lifestyle, blood pressure, lipid and glucose management, but your periodontal illness is also a cardiovascular risk factor, and they should manage it with sufficient periodontal therapy and sufficient periodontal maintenance. And the key word here is maintenance therapy. So a proper history of all risk factors is necessary, but remember that patients with a risk of endocarditis should always be pre-medicated with antibiotics prior you doing periodontal therapy on them. So the patient is advised a personalized oral health hair hygiene, which includes twice daily brushing, because we have seen that in past literature, which includes interdental cleaning, because we know that plaque and gingivitis probably starts in the interdental area first, and maybe use of adjunctive chemical plaque control. Monitor them for their parietal status. Any non-surgical periodontal therapy done in short appointments, preferably in the morning, and an advanced therapy for the periodontal hair disease may be started as soon as the cardiovascular status permits. Please be sure to consult your physician, especially if the patient's BP is more than 180 by 100 millimeters of mercury, or if the patient is on an anticoagulant therapy. So, talking about the anticoagulant therapy, remember that patients who are with an antiplatelet therapy and you're doing a low bleeding risk procedure, it is not necessary to discontinue the therapy. Okay. And if there is a patient who is taking dual platelet therapy, that is aspirin plus clopidogrel, and there is a medium risk, you can still manage this patient with a local hemostatic agent according to Nepinas and Natwani. So there is no necessity to discontinue a therapy, but yes, there may be a chance for postoperative hemorrhage, which you can control with a local hemostatic agent. With these take-home messages, I now end and open the floor to questions and answers. Yes. I have got some questions coming in, and I've got a question here from Dr. Srinivas Murthy. Is the association or relationship between cardiovascular disease and periodontal disease very definite and very specific, or is it dependent on occurrence of risk factors and confounding factors? I think so. What Dr. Murthy is trying to say is, are we making a big issue of a small tissue? Dr. Shiva, can you take that?
Yes, yes. Thank you very much for the nice question. Now, in the whole presentation, all of us were talking about evidence. We have been talking about all sorts of evidence. Let's say the highest amount of evidence we have is the systematic review, and everything explains about that, even with the independent confounding factors. There are some studies which have been done with the independent confounding factors. But in one literature speaks about it is not done that the athiroma which has been already formed and isolate that athiroma and get the DNA and RNA of the bacteria and then introduce it to the another animal and then produce an atherosclerosis. This is being still not established yet. But otherwise, in most of the research, most of the study, at today's evidence says that yes, there is a possibility and independent of the confounding factors.
Yeah, thank you, Dr. Shiva. I think so you made it quite clear. I have another question from, I guess this is a PG student from a Dr. Priya. In research methodology, what type of study should be designed so as to prove or disprove the links between cardiovascular disease and periodontitis? Dr. Vivek, can you help us?
Yes, sir. Yeah, definitely, sir. A wonderful question. So, as we know that the highest level of evidence is the meta-analysis of the randomized clinical trial. However, randomized clinical trial in this situation is not ethically possible, or we can say very less number of randomized clinical trial is there. Therefore, the mechanistic trials and the marginal model, which was prescribed based on the epidemiological studies, has been used. So we can say in the current scenario, although there are no randomized clinical trial and because of ethical reasons, no such more long-term studies can be done. But the important part is that longitudinal studies that shows the incidence of the events may be helpful in understanding and in preventing such disease. I think longitudinal studies are better. This is my take, sir.
I just would like to add one point here. For example, with the clinical study, with the longitudinal study, intervention studies, if we add up another link of biomarkers, if we can assess the biomarkers in the clinical studies,
surrogate markers if we add.
Little more strong evidence, because that's the only evidence we have. What are the biomarkers or biochemical changes which is going to happen, change in the body? So it is because of our scenario, the cost of the biomarkers is very expensive. So it is difficult to inculcate so many biomarkers to do that. That might be a drawback. Otherwise, if you introduce a biomarkers along with that clinical study, I think it can be a wonderful conclusion.
Yes, thank you so much, doctors. Dr. Tenzin is asking, is there conclusive proof that periodontitis and cardiovascular disease have a genetic predisposition?
Yes. Can I take this, Dr.
Yes, Dr. Shiva.
Yeah. See, I just explained in one of the slides where there is one locus of chromosome 9 and P21.3, there is CDKNA13. There is one location of the gene which is very vulnerable for cardiovascular disease, Alzheimer's disease, and diabetes. And it has been proved this is the area already genetical predisposition or genetical weakness. Now, so far, it is not really isolated what is the gene responsible for the periodontitis, but it's only an association. Whenever these patients, this genetical problem and the patients add some periodontitis also, it is an association. But so far, the exact gene which is responsible for periodontitis is still not very clear about it. So probably in the coming days, where there is too much of genetic studies, can give a proof of this, I think.
Yeah, thank you, doctor. The last question I'll take, because we are running short of time, and that is from Dr. Mahesh. Do we not stop blood thinners before periodontal surgery and other procedures like tooth extraction? Yes, Dr. Mahesh, that's a very interesting question that you have asked, and a very practical question. Do we stop the blood thinners? When you talk of blood thinners, you're talking about not only antiplatelet therapy, you're talking of anticoagulant therapy. So when you're talking of antiplatelet therapy, there'll be single antiplatelet therapy, there'll be dual antiplatelet therapy. Single being like most common is your ASA or your aspirin, salicylic acid, 75, or some people give it as 81 milligrams. And this has been shown to be effective, and a lot of cardiovascular patients are taking it. Dual antiplatelet therapy, usually you'll get clopidogrel also. Now, the point is that if you're doing a low bleeding risk procedure, then there should be no reason to be stopping this, because first of all, it's a chronic dosage that you're taking. By stopping it for 1 day or 2 days, you're not going to change the effect of that medication much. But and in effect, if you stop it for more number of days, the beneficial of the effects of that antiplatelet therapy will also get voided, and the patient may have a cardiovascular sequelae in your dental chair. So it would not be advisable to stop it. However, you should understand that there may be a chance of bleeding, so you should be ready to take care of the bleeding in your dental office. However, if you are still worried, especially if the person is taking dual antiplatelet therapy, and your procedure you're doing is a medium risk for hemorrhage, then what you can do is do a bleeding time prior to your procedure and see whether that is within limits, and then carry on with your procedure. But when it comes to anticoagulant therapy, in this case, you have to be doing your INH. And if the INH is too high, then you'll be consulting the physicians and accordingly moderating the dose. Also, you have to understand, if the person is taking anticoagulant therapy, then he must be having something more severe or more recent. There might have been a myocardial infarction, which is more recent. So is your procedure really necessary, or can it be postponed? So all these things have to be taken into account before you elect to do the procedure in consultation with the physician. So with the permission from the chair, I'll stop now. I won't be able to take any more questions. And I'd like to conclude that we have talked about the epidemiological associations between periodontitis and cardiovascular disease. We have seen articles by Dietrich in 2013, by Herrera et al. In 2019, which talk about such epidemiological associations. We have talked about mechanisms of biologic plausibility relating to bacterial infections as per the articles of Reyes et al. In 2013, and systemic inflammation according to Schenkin and Luz in 2013, Schenkin et al. In 2019. We have seen intervention studies wherein if we treat the periodontitis, the chances of having cardiovascular sequelae is lesser. But at the same time, not all patients with periodontitis do definitely have a cardiovascular disease emergency. So it's not necessary that all patients with periodontitis have cardiovascular problems. So there is no cause and effect relationship over there. Not all periodontitis patients undergoing successful therapy will definitely escape from a cardiovascular disease sequelae. But at least, so is there a relationship? This puts a question mark. But at least we can say that evidence suggests that if we can lower the periodontal inflammation, we can lower the odds ratio to have a cardiovascular emergency. We also can state very safely that is safe to do treatment in a patient who is having cardiovascular disease. So therefore, we must at a local level educate our brethren in the cardiology department, those who are managing cardiovascular disease patients, about the benefits of periodontal therapy and the maintenance, periodontal maintenance on a long term as a means to probably decrease the incidence of cardiovascular disease sequelae. And at a second level, maybe we should design randomized controlled trials, longitudinal trials, as Dr. Shiva said, to further prove such associations in an Indian subset of populations with cohorts specific to various risk factors peculiar to Indian population. Like whatever studies we have is about smoking, not about tobacco chewing. Whatever studies we have is not about the rampant diabetes and obesity and the diet and sedentary lifestyle in an Indian population. So maybe we can design studies with such type of cohorts and all up to the younger fledgling periodontists in the audience to take up this research project in the near future. With this, I thank Dr. Shiva Manjunath and Dr. Vivek Bains for spending their time for this symposium. And I thank the organizing committee of this convention and the head office for giving me this opportunity to chair this session. Thank you so much.
Thank you, sir.
On behalf of the Indian Society of Periodontology, we take immense pleasure in thanking Dr. Aaron for his excellent moderation of this session. We all had our share of knowledge to take from this session, sir. And thanks a lot for moderating it in an interesting way with scientific literature all lined up to shed light on this topic, Dr. Aaron. Thank you for your valuable time. Thank you.
Sir has not joined as yet.
Sir.
Dr. Dani, Dr. Mangesh has joined in the panelist. We can start the session.
A very good afternoon to all of you. Now we are moving to our next session with Dr. Mangesh B. Patnaik as moderator. Professor Dr. Mangesh B. Patnaik completed his MDS in periodontology from Nagpur University in 1988. Dr. Mangesh has a teaching experience of 30 years for undergraduate and 15 years for postgraduates. He was the professor and head Department of Periodontology, Government Dental College and Hospital, Nagpur. Presently working as the Dean, Government Dental College and Hospital, Nagpur. Dr. Mangesh is a DCI member since 15 years, and Dr. Mangesh has published more than 60 articles in national and international journals. He was a scientific convener at ISP National Conference 1992, Aurangabad. Dr. Mangesh has chaired scientific sessions at state and national conferences. Dr. Mangesh is an EC member at the ISP head office. Moving on to Dr. Mangesh. Thank you.
Thank you for a very nice introduction. Today we are here for the panel discussion, point and counterpoint. My take, your views. And we have got two panelists, Dr. Amit Bharadwaj, who will be speaking for statistically significance, and Dr. Hari Kumar Menon, who will be for clinically relevant. So I welcome both the panelists and I will give their brief introduction to you. Professor Amit Bharadwaj is working in the Department of Periodontology at Faculty of Dental Sciences, HGT University, Gurugram. He has 12 years of experience and he is himself has done PhD. He is PhD guide and also he is the head of the PhD cell in the HGT University. He has 68 national and international publications to his credit. He is a member of Indian Dental Association, Indian Society of Oral Implantology, Indian Society of Periodontology, and International Association of General Dentists. He worked as a scientific convener and chairperson for 10 scientific sessions, attended 47 national international conferences, presented 15 scientific papers in national conferences and 2 posters. With this great biodata, Dr. Amit Bharadwaj will be speaking for statistically significance of the intervention. And Dr. Hari Kumar Menon, he is the additional professor in periodontics. He has got 17 years of teaching experience at Government Dental College, Kozhikode. He was the topper in '92 for periodontology and recipient of ISP gold medal. He has piloted pioneer project work in developing fish-derived collagen chitosan film as a GTR membrane. He has got advanced training in periodontal microsurgery from Karl Zeiss, Germany, lasers, implants from Baden, Germany, and research methodology. He has 25 publications to his credit, and he is a sought-after speaker for many regional, state, and national level continuing education programs in perio. He is also invited faculty for postgraduates, refresher programs, and has served as CDE convener of IDM Malabar branch. He is a Rotarian hardcore and past president of Society of Periodontologists and Implantologists of Kerala SPIC, and has conducted a few hands-on workshops, training sessions, live surgical demonstrations, point counterpoint sessions, panel discussions, and symposia. Now, before we move on to the speakers, I will just introduce you with the subject on which my panelists will be speaking. So here we are on the panel discussion of exactly my point, your take.
Slideshow view, sir.
So this is my parent institution. I am the alumni of GDC Nagpur and presently working as professor and HOD. So to point of statistical significance and counterpoint of clinical relevance of influence of periodontal therapy on systemic parameters. This is what is statistical significance is, and this is what is clinical relevance is. Statistical significance is an intentional attributable thing, whereas clinical relevance is for the treatment effect. These are the types of studies which are carried out for the statistical evaluation of evidence and the clinical evaluation of evidence. These are the systemic conditions which are generally influenced by periodontal interventions, the atherosclerotic vascular diseases, the cardiovascular conditions, and the cerebrovascular conditions. The endocrine conditions, mainly diabetes, the adverse pregnancy outcomes, the PTLMs, the pulmonary infections, COPDs, chronic kidney disease, and rheumatoid arthritis. And these are the different treatment modalities for different systemic conditions which have been tried as an interventional strategy. For atherosclerotic vascular diseases, all the non-surgical therapy with and without antibiotics, and standard therapies, full mouth disinfections with and without antibiotics. For diabetes, the mechanical treatment, the non-surgical with and without adjunctive antibiotics, then topical antibiotics, extractions, and periodontal surgery. For adverse pregnancy outcomes, we have SRP with and without metronidazole or placebo, pulmonary infections, and then chronic renal diseases. These are the systemic parameters used by various authors and researchers. Those in the bold are the ones which we will be dealing with in our presentations. For vascular diseases, for diabetes, for adverse pregnancy, for pulmonary, for renal disease, and for rheumatoid arthritis. So with this, I move on to Dr. Amit Bharadwaj for his presentation on the statistical significance. Dr. Amit, please.
Hello. Hello. Thank you, sir, for nice introduction. Hello.
Yes, I can hear you.
Okay. So I will be starting my presentation on influence of periodontal therapy on systemic parameters, statistically significant or clinically relevant. So I will be dealing with the statistically significant part. Statistically significant means static is a determination that relationship between two or more variables is caused by something other than chance. Statistical significance is used to provide evidence concerning the possibility of null hypothesis, which hypothesizes that there is nothing more than a random chance in the data. Statistical hypothesis testing is used to determine whether the result of data set is statistically significant. So there are few terms which we usually see in all our articles in research methodologies: null hypothesis, p-value, and significance level. All these three terms will finally lead us to statistically significance. The null hypothesis is a default assumption that there is no statistical significance, that nothing observed has changed, or there is no association or relationship between observed data sets. The p-value is a probability value. The significance level is a level in which we usually keep 0.05%, but it can be adjusted according to the field of study. The history of statistical significance goes back to 1925 when a British statistician, Fisher, gave the threshold of 0.05. But later it was assumed in 2010 that academic journals are using this value as a baseline, whereas they started telling it as a p hacking. And in 2016, American Statistical Association issued a statement that saying that p-value should never be used as a substitute for scientific rigor. And that is hoped to steer research into post-p 0.05 era. So this is a very important point to be noticed. Now coming to our topic, periodontal medicine says that is a emerging branch which gives establishment of two-way relationship between periodontal disease and systemic disease, both in health as well as in disease. William and Offenberg 2000 says that periodontal medicine deals with a two-way relationship in which periodontal disease in an individual way be powerful influence on an individual systemic health or disease, or more customarily understood role of systemic disease on influencing an individual's periodontal health and disease. Bartold say that there is a relationship between systemic disease and periodontal disease, and he marked 42 diseases which has relationship with periodontal disease. So where we get the strength of evidence? In any evidence-based studies, we need to consider meta-analysis, systemic reviews, and randomized controlled trial to come to any conclusion. And in today's presentation, I have included all the articles out of these three categories only. And most studies which I have found have researched association in terms of effect of periodontal therapy on cardiovascular disease, diabetes mellitus, adverse pregnancy outcome, respiratory disease, renal disease, and rheumatoid diseases. So in this systemic review, they did a systemic review on atherosclerotic profile and effect of periodontal therapy on that. They have used various studies using the central database of Cochrane, PubMed, Embase, and they have met 25 trials to meet their eligibility criteria. Systemic parameters which they have evaluated is CRP, interleukin-6, tumor necrosis factor alpha, fibrinogen, total cholesterol, and triglyceride. And they have showed that endothelial function improves constantly with the improvement in the periodontal status. And periodontal patients with comorbidity benefited most from periodontal therapy. And they have concluded that periodontal therapy improves endothelial function and reduces biomarkers of atherosclerosis diseases. Then study from Milan et al. Also on cardiovascular diseases and effect of periodontal treatment says that systemic parameters like C-reactive proteins, tumor necrosis factor alpha, interleukin-6, leukocyte, fibrinogen level, effect of lipid parameters, low density lipoprotein cholesterol, all have reduced due to proper periodontal treatment. In conclusion, they have said periodontal treatment has a beneficial effect on some of the biochemical parameters considered to represent cardiovascular disease. So my point in this is non-surgical periodontal therapy with or without adjunctive is helpful. Standard versus intensive periodontal therapy is helpful. Full mouth disinfection is helpful. Full mouth subgingival debridement alone is also helpful. And various studies by Hada et al., Zous et al., and Bukhari et al. Says that a decrease in CRP inflammatory values was noted to be statistically significant when patients were submitted to non-surgical periodontal treatment in contrast to receiving no treatment at all. And to conclude, periodontal treatment produces a progressive reduction in systemic inflammation and improvement in endothelial functions. Now come to diabetes mellitus. Again, a systematic review and meta-analysis done in 2020 says that A1C level improves after doing a periodontal therapy. In this analysis, they suggested that periodontal treatment leads to an improvement in glycemic control in type 2 diabetes patient for at least 3 months. Similar study by Liu et al., which is also a randomized control type, non-surgical periodontal treatment can reduce HbA1c percent in type 2 diabetes mellitus. Only one parameter they have studied, which is HbA1c, and there was an absolute difference. So in conclusion, they said non-surgical periodontal treatment was associated with reduction in HbA1c percentage. Again, in trials, one study published again on RCTs, which was also emphasized on hemoglobin levels, and they concluded that a moderate reduction in HbA1c after non-surgical therapy in patient with type 2 diabetes mellitus. Glycemic control study was again RCT and systemic review was done by Shen et al. And they also concluded that the effect of periodontal therapy on glycemic control in people with type 2 diabetes mellitus. But all of these 3 or 4 studies have gave emphasis on HbA1c. Now my point is mechanical non-surgical periodontal therapy only is useful. Non-surgical periodontal therapy without and with adjunct to antibiotic is also useful. Topical application of antibiotics is useful. Extraction of hopeless teeth is useful. And periodontal surgical therapy is also useful. Al McKay, Wang et al. And Tusbing et al. Concluded the non-surgical and surgical periodontal therapy with or without use of antibiotic significantly improved the metabolic outcome in addition to periodontal health in diabetic subjects with chronic periodontitis. Now coming to adverse pregnancy outcome, this was a systematic review done between 2000 to 2018 article published in PubMed, Medline, Embase databases. And the parameters they studied were preterm birth and low birth weights. And they concluded that there is a effect of non-surgical periodont therapy during the pregnancy on these 2 parameters. One more systematic review with meta-analysis done by Silva et al. Using the same basis, PubMed, Scopus, Cochrane, Web of Science, ProQuest, etc. They have concluded that pregnant women with chronic periodontitis underwent non-surgical periodontal therapy compared with untreated group. And they said that intra-pregnancy non-surgical periodontal therapy improved periodontal clinical parameters and reduced biomarker levels from GCF and blood serums. And ultimately, they all concluded that biomarker level reduces after a periodontal therapy. So my point is scaling and root planning with antibiotic therapy, and Khernar et al., Reddy et al. Concluded that an increase in severity of periodontitis results in evaluation of serum IgM antibody concentration, which might contribute to risk of adverse pregnancy outcome. Non-surgical periodontal therapy showed positive response to therapeutic intervention in related to pregnancy outcome and parameters also. Now coming to COPD, this was a systematic review by Apos et al. And they have used various databases to see the potential benefit of periodontal therapy on severe COPD outcomes. And the parameters used were exacerbation rate, lung function, quality of life, FEV, that is forced expiratory volume, and forced vital capacity. And they concluded that in addition, periodontal therapy in COPD is associated with lower hospitalization rate and reduces all cause mortality. So my point is chemical antimicrobial rinses, mechanical tooth debridement, scaling and root planing will increase total vital capacity and exhalation volume. And studies by Vidal, Pinto, Zhou et al. Said that the mechanical removal of oral biofilm in combination with the use of chlorhexidine can reduce the chances of pneumonia. And periodontal therapy in COPD patient with chronic periodontitis may improve lung function and decreases the frequency of COPD exacerbation. Now coming to renal, this was a study, Chobron et al. On eGFR rate of periodontal therapy. They have used Medline, Embase, Cochrane databases to come to conclusion. Parameter evaluated is eGFR, and they say that there is a positive outcome on related to treatment with periodontal therapy. Again, a systematic review by Delbove et al. To assess the effect of periodontal therapy on GFR, systemic inflammation, and mortality in patients with chronic renal diseases. They concluded on parameters on GFR, CRPs, and IL-6. Within the limitations of present study, that levels of these markers reduces with the periodontal therapy. So my point is, non-surgical periodontology is effective in reducing the renal diseases. Tesse et al. And Almeida et al. Concluded that periodontal treatment had statistically significant positive effect on GFR. Periodontal treatment seems to improve renal status, and results are encouraging, especially for reduction of systemic inflammation. Now, rheumatoid arthritis, again they say that it has effect on level of inflammatory biomarkers. Interleukin-1 beta and tumor necrosis factor alpha were screened during these analysis, and they concluded that periodontal inflammation, periodontal therapy has an effect on reduction of these parameters. Again, a study on rheumatoid heart diseases said that in generalized periodontitis patient, periodontal therapy has effect on reduction of parameters. Significant improvement in condition of tooth, patient treated according to treatment regimen by clinical criteria, and indices of paraclinical index, assessment of periodontal tissue after immediate and long term. The benefits of treatment scheme in patients with periodontitis associated with CRSD compared with the result of traditional treatment of generalized periodontitis. One study by Sylvester et al. Said that level of ESR, CRP, IL-6 and TNF alpha reduces after treatment. Non-surgical treatment improves the periodontal condition of patient with periodontitis and rheumatoid arthritis. A study by Cledaro et al. Said that ESR, C-reactive protein, patient assessment of rheumatoid activity using visual analytic scale, tender swollen joints, count showed a trend towards reduction. Disease activity scale also reduced in the patient who are undergoing periodontal treatment. So my point is non-surgical periodontal therapy is useful. Pino et al. And Sari et al. Also concluded altered local oxidative stress profile was associated with presence of periodontitis. Non-surgical therapy have shown to improve inflammatory outcomes. So exactly my point is, though we have seen that statistical significance is present between the treatment and the reduction in biomarkers, but statistical significance seeks to verify that an effect is taking place. It can be a helpful tool for decision maker when taking into account the result of particular studies. However, it should not be the primary determinant of truth, efficacy, or importance. A stricter focus on scientific rigor and smaller p-values will reduce the chance of false positive and irreproducibility in statistical research. So these are some references which I have quoted earlier also. Thank you, organizing committee members, for giving me an opportunity. Dr. Mangesh sir for moderation and Dr. Hari Kumar to be my co-panelist.
Thank you, Dr. Amit, for a very statistically significant presentation. and all the parameters used by the researchers have very well been dealt with you in detail, and all the meta-analyses and the literature reviews have been very properly been executed. And I think the presentation is mostly self-explanatory. So with the take-home point is that the intervention in these systemic conditions is beneficial, and this beneficial effect is statistically significant. Now it's time for Dr. Harikumar Menon to give his presentation on clinical relevance.
Thank you, sir. Shall I share the screen? Am I audible, sir?
Yeah.
So good afternoon. Good afternoon. Thank you, Mangesh sir, for that wonderful introduction and the initial remarks you made in this particular session. And Amit has continued it beautifully, quoting a lot of relevant studies, proving his point of statistical significance. So before talking about my point of clinical relevance, let me start with a famous quote by Albert Einstein. Not everything that can be counted counts, and not everything that counts can be counted. We can translate this quote into our scenario, which states that one second, sir. Let me. So sorry for the interruption. So Albert Einstein has said that not everything that counts can be counted, and not everything that counts that can be counted cannot count. So when we translate it to our situation, not everything that is statistically significant can be clinically relevant, and not everything that is clinically relevant can be statistically significant. Now, as Dr. Amit told exactly, statistical significance is a mathematical concept based on null hypothesis significance testing. But clinical significance is a nebulous or ill-defined concept with no agreed rules. Now, statistical significance we assign to a particular study based on the p-value statistic. You can see it here, based on the p-value statistic. And if the p-value is less than 0.05, we call the study statistically significant. If it is not that, we call it statistically insignificant. Now, there are certain issues with p-value statistic. One is it is dichotomous. It will give you an idea regarding whether it is statistically significant or statistically not significant. And it is influenced by the sample size. And the results are not generalizable to a wider population, because in small sample size studies, there is lack of generalizability to the wider population. And more importantly, it gives no idea on the magnitude and direction of the effect. Now, coming to clinical relevance, what is clinical relevance or what is clinical significance? It was Jacobson et al. In 1984 first proposed clinical significance to determine the practical value of a treatment as opposed to statistical significance. Later, Lefort et al. In 1993 extended this particular terminology, and he said that statistical clinical significance should reflect the extent of change, whether the change makes a real difference in the lives of subjects, how long the effect lasts, its cost effectiveness, and the ease of implementation in a clinical setup. So that is the definition given by Lefort. Now let us see what are the importance of assessing or inferring clinical relevance. It is important that statistical significance, especially it is important than statistical significance, especially for clinical studies. Why? Because this is the area of evidence-based decision making, and we treat patients based on the best evidence available. Applicability of this evidence in a clinical setting is very, very important. And this clinical applicability of evidence is not always related to statistical significance. And for this, proper clinical interpretation of the research is very important. And clinical interpretation on treatment outcomes becomes more important because it directly influences patient safety and efficacy. So the research outcomes should be analyzed for their clinical relevance rather than just for the statistical relevance. That is the importance of clinical relevance. Now I will present before you a few tools and estimates used to assess clinical relevance. When you read an article or when you read a study publication, these are the things we have to look into if we want to assess or infer clinical relevance from that particular study. Patient report, patient-centered outcome measures, whether the study quotes or the study address outcome measures pertaining to tangible outcomes or true outcomes like comfort of the patient, function, aesthetics, etc. Second is the clinician's judgment on the applicability of new therapy, if it is a particular therapy, or the existing one, in terms of cost benefit, that is money, cost utility, that is the perception values, then cost effectiveness, that is physical values, and risk benefit. So the clinician should judge whether this particular statistically significant outcome can be applied to the clinical situation safely. Next tool is change in behavior of the patient. What change in behavior the outcome has created? What improvement in quality of life the outcome has created? And the evidence that has produced from the result from the study, is it based on a long-term impact? Is it making a long-term impact? And then interpretation of outcomes based on its generalizability, that is efficacy to effectiveness. Then another parameter which infer clinical relevance is effect size. Effect size is actually a statistical concept that measures the magnitude or strength of the association between two variables. Usually, the effect size we commonly do are the standardized mean difference. You can see it here, the standardized mean difference, that is difference between the mean of control group and test group. Then either or else we can use the odds ratio or relative risk or even correlation coefficient. So when you analyze a study, look into the effect size measures, so that it will give us some idea regarding clinical relevance. When you analyze clinical trials or randomized control trials, there is something called NNT, number needed to treat, that has to be expressed. If a high NNT is expressed, that indicate less effective the treatment. So that has to be looked into. Then confidence interval is another estimate that is very much of significance. It is an interval estimate within which the true population value lies. Width of the confidence interval gives information on the magnitude of the effect size. Symmetry of the confidence interval on either side of the point estimate gives the direction of the effect size. And the presence of null value or line of no effect in confidence interval make the outcome statistically insignificant. So the interval estimate of confidence interval give you lot of idea, lot of inference regarding the clinical relevance and even the statistical significance. So confidence interval is important. Here you can see in the diagram, this is the confidence interval and this is the point estimate. Here it includes the null value. So this is not statistically significant. Here the study lies on the right hand side of the line of no effect or the null value. So it is had a positive effect. Here it is unclear effect. If it is on the left hand side, it has got a negative effect. So that is how we interpret confidence interval. And this gives a lot of information in inferring clinical relevance also. Another estimate is minimum clinically important difference. There are studies which exhibit or which shows minimum clinically important difference in the outcome. So in this particular case, this is the minimum clinically important difference, and the consensus is that if the minimum clinically important difference is ahead of the point estimate, that study is considered to be, that outcome is considered to be clinically relevant. Now, final point to infer clinical relevance is magnitude-based inferences. That is, when you read an article, we see lot of statistical jargons, but the article should contain texts like almost certainly beneficial, probably beneficial, possibly beneficial, likely beneficial, or certainly harmful, probably harmful. That sort of text messages should be there in the text part of the article to infer clinical relevance, like this. Here you can see. When it is close to the null value, this is a trivial effect, very small effect. Here, this study has got a good positive effect. This study has got a certainly beneficial effect. Similarly, this study has got a negative, possibly harmful effect. And this particular study has got a very likely harmful effect. So these sort of inferences we have to look into. Now, to put it together, clinical relevance is assessed based on two parameters. One is the nature of the benefit, whether it is tangible or intangible. And the other one is the size of the treatment effect size, whether it is large and small. And we can put it into a 2x2 table. And level of clinical relevance can be assessed as level 1, level 2, level 3, and level 4. If the nature of the benefit, outcome of the benefit is tangible and the effect size is large, it has got level 1 clinical relevance. If the nature of the benefit is tangible and the effect size is small, it has got level 2 clinical relevance. If the nature of the benefit is intangible and large effect size, it is level 3. And if the nature of the benefit is intangible, it has got a small effect size, it is only level 4 clinical evidence. So that way we can categorize level of significance, clinical relevance, level of clinical relevance. Now coming to my point, the question today is, for this session, is influence of periodontal therapy on systemic parameters, whether it is statistically significant or clinically relevant. Dr. Amit has explained very well, quoting the statistical significance extracted from the studies in the literature. Now, my point is, in the light of the available evidence, it may be statistically significant, but not clinically relevant or clinically meaningful. Before substantiating my point, we can look into the updates on periodontal disease and systemic diseases. And literature has proven that there is a bidirectional relationship between periodontitis and many systemic diseases and conditions, as Dr. Mangesh Patnaik sir has clearly explained in the beginning. And almost 57 studies and conditions are now researched in relation to periodontitis. And from this point, we will get two questions. Are periodontal disease and systemic diseases are causally related or causally associated? And what is the influence of periodontal therapy on systemic parameters? Now, addressing the first question, are periodontal disease and systemic diseases are causally associated? When we look into the literature, we have a lot of observation studies, systematic reviews of observation studies, report to fail that has failed to prove causality, and they have established only some sort of association, but they have failed to prove any causality. And this particular point, During the EFP AAP workshop on periodontitis and systemic disease in 2012, they have concluded the following way. The reported associations between periodontitis and systemic disease does not imply causality, and the establishment of causality will require new studies that fulfill the Bradford Hill criteria or similar criteria. So causality is a question that we are keeping for the future. Now, so coming to the today's session question, that is whether the periodontal therapy, what is the influence of periodontal therapy on systemic parameters? To prove the clinical relevance, I went through the literature, I searched the literature by appropriate mesh terms and found studies relevant to this pertaining to this particular question. Depending on the systemic disease of interest, systemic outcome parameters that disease that are looked for. I got many observation studies and I found few prospective studies and very little randomized clinical trials. Confounding is a major problem in observation studies, which can distort the study results and question the generalizability of the statistical significance obtained from the observation studies. And we got few randomized clinical trials because ethics, cost, and time are the major issues to conduct good randomized control trials. So, after critically analyzing the clinical relevance of the published article, I am coming to my point, that is whatever statistical significant evidence we have in terms of influence of periodontal therapy on systemic parameters, we cannot attribute clinical relevance to these findings in most of the situations because of the following considerations. One is the design of the study. We are having observation studies or those studies which are more concentrated on the lower part of the evidence pyramid, and hence confounders will distort the validity of these study designs. Even though we have few randomized control trials, they are studied with small sample size, and it is limited to only non-surgical periodontal interventions in almost all times. And there is totally a lack of effectiveness trials or trials conducted on large sample size to improve the generalizability of the statistically significant results to the population. There is a lack of tangible outcome measures reported in many of these studies. And the lack of studies reporting outcome measures on a long-term basis is also lacking. And there is lack of data from multi-centric studies. And among the studies that are reported, there is a lot of heterogeneity in the study inclusions. And the systemic markers assessed in these studies have got poor predictive value. So based on these informations, I will stick on to my point that whatever statistical significance we got, they may not be clinically relevant when we extract or infer clinical relevance from these published studies. I'll give you examples of few studies. This is an interventional trial that is done in 2020, that's published in 2020. It is a randomized control trial, so there is good validity. But the problem is the sample size is very less, 63 patients, and the period of assessment is only 6 months, and the parameter assessed is CRP. So it won't give you any clinical relevance prima facie. Although it is statistically, the periodontal intervention is statistically significant, we cannot extract clinical relevance from this. Another study in 2020, published in 2020, related to diabetes and periodontal non-surgical periodontal intervention. It is also an interventional study, so there is good validity. The subject studied is only 75. Only 3 months evaluation period is given for that. Tumor necrosis factor alpha is the marker that is studied. This particular study also won't give any sort of clinical relevance, as I explained before. Now, there are two studies which showed some amount of clinical relevance. Regarding periodontitis and diabetes mellitus, there are two systematic reviews by Simpson et al. And Tu et al. In 2010, which combined evidence from randomized control trials, suggested statistically significant effect in reduction in HbA1c levels following periodontal therapy. And they have very well given in the study that the size of the effect showed some clinical relevance. So they have got some sort of good effect size to prove clinical relevance. The second study is a prospective diabetes study from United Kingdom. And what they have quoted is, there is a 35% less risk in microvascular complications for every 1% reduction in HbA1c. And there is a 10% reduction in mortality for every 0.2% reduction in HbA1c. See, the explanation given by them is very well related to tangible outcome measures, that is hardcore outcome measures, that is regarding the microvascular complications and the reduction in mortality pertaining to every amount of point decrease in HbA1c levels following periodontal intervention. So that can be this study can be considered as a particular study where we can derive some sort of clinical relevance following a periodontal intervention in diabetic patients. So although there are few studies, in general the studies available in literature lacks point to substantiate clinical relevance to prove the influence of periodontal therapy on improvement of systemic parameters. Now I'll give you the checklist to assess validity of a study. These are the three things that we have to look to when we assess statistical significance and strength of the study design, strength of the study, validity of the study. Apart from this, you have to, as I mentioned before, these are the things we have to look into when you read an article to extract clinical relevance, to infer clinical relevance, whether patient-centered outcome measures are reported, whether clinical applicability of that particular outcome is there based on ethics, cost, and risk, long-term impact of the outcome has been studied or not, effect size, whether it is standardized and reported, the magnitude and direction of effect size reported with confidence interval. So actually we don't need any p-value. We need actually the summary measure point estimate described in an interval estimate of confidence interval to prove clinical relevance and statistical significance. Now whether minimum clinically important difference outcome reported and number needed to treat reported and outcome reported in terms of magnitude based inferences. So this is a checklist which we can use to infer clinical relevance from published articles. So with that, I statistically significant and clinically relevant acknowledgements to organizers of ISP PG Convention 2021. Beautiful way for giving me an opportunity to share my views in this beautiful virtual platform. Big thanks to Dr. Mangesh Patnaik sir, who guided us throughout this presentation, and Dr. Amit Bharadwaj, who very well expressed the importance of statistical significance along with my side. Special thanks to Dr. Abhay Kolte and Dr. Anilam for the help rendered, and members of Department of Periodontics, GDC Kozhikode. And I recommend all postgraduates to this new released book by Hirschfield and Chappell in 2021. It is available as ebook right now. I have gone through a few pages, and that will give us better insight into how to infer clinical relevance based on evidence they have given and the biologic plausibility. Thank you. These are my references. So thank you, everyone. With that, I conclude this particular talk on clinical relevance. Thank you, sir.
Thank you, Dr. Harikumar Menon, for an excellent clinically relevant talk on the topic of today's panel discussion. So both my panelists have statistically significantly and clinically relevantly spoken on the topic of discussion. Now, as we all know, statistical significance is the quantitative measurement, whereas clinical relevance is the quantitative effect. And to highlight my point, what we have been discussing for the last half an hour are the two questions. Does the presence or severity of periodontal disease affect these conditions? And if the answer is yes, then we go to the next question. Does the periodontal treatment aimed at reducing the bacterial challenge and minimizing inflammation have a measurable effect on these conditions? So there is a yes to the first question, then only there is a clinical significance or statistical significance or clinical relevance to the intervention which we carry out. So these are the systemic diseases.
So start your slideshows.
Yeah. So we have in all 20 studies quoted in the two panelists' lectures, and I have prepared a table out of this. So both statistically significant and clinical relevant studies in atherosclerosis, one study is there. In cardiovascular disease also there is, when both are there, one study. Diabetes, 4 studies are statistically significant, whereas only 3 are clinically relevant. And in metabolic syndrome, one is a statistical significant studies. In adverse pregnancy outcome, one each is statistically significant and clinically relevant, and only clinically relevant. COPD also one statistically significant. In CKD, one each in both only clinical and only statistical. And in rheumatic disease also both in one study and only clinical relevance in 2 studies. So out of 20 studies, 11 show both clinical significance as well as clinical relevance. One study show only statistical significance and 8 studies show only clinical relevance. And none of the studies were neither statistically significant or clinically relevant. So this highlights the importance of both the parameters. Both clinical significance as well as statistical significance are equally important. And as Dr. Harikumar had said, that even though there is statistical significance, it is not necessary that it will show clinical relevance. So from practical point of view, from clinical point of view, we should, when both of them go hand in hand, it is a very positive thing to happen. But from if only statistical significance is there and no clinical relevance is there, then in the practical point of view, it carries no meaning, because the patient perception, it does not depend on statistical significance, but it depends on the clinical relevance. And in this pandemic of COVID-19, I think this rule can be applicable of statistical significance and clinical relevance to whatever interventions have been done in the treatment of COVID and now in the mucormycosis. So all these principles are being applied there also. And that is what is, I think, is the take home message. So I thank both the panelists for their beautiful and fantastic presentations and the organizers. One thing I would like to appreciate the organizers for selecting the moderator from Nagpur and the panelists from Delhi and Kozhikode. So North, Central and South conglomeration is there in this selection of the moderator and the panelists. Now there are 2 questions.
No. After everything is over, I will just conclude. That's all. After your thank you, like yesterday. Okay? Yeah, bye.
Thanks to everybody. And now coming on to the questions. The first question goes to Dr. Amit from Dr. Aniban. It says, what is type 3 diabetes?
Hello, sir. They say some literature is available on type 3 diabetes, and they say that it is in between the type 1 and type 2 in association with Alzheimer's disease. When patient is having dementia, Alzheimer's disease is positive, he is diagnosed with Alzheimer's disease, and in association with type 1 and type 2, these 3 will combinedly said as type 3 diabetes mellitus. But the term is not yet officially accepted.
Accepted in the literature.
Yes, sir. Yes.
And there is one more.
Not audible, sir.
We can't hear anything from you, Mangesh, sir.
Yes, am I audible?
Just about. We can't hear you, sir.
Yes, sir. Am I audible?
Only we can hear you asking us whether you are audible. After that, we cannot hear you.
There is a question for Dr. Hari Kumar.
Yes, sir.
Dr. Hari Kumar,
Yeah,
please.
I am here. I am here. Yes, sir.
Yeah. Why oral health is not considered in systemic health? This is from the technical team, Dr. Vishal Kumar.
Definitely, as rightly pointed out, this is what exact the discussion we had in the last session, counterpoint session by Dr. Aaron Gomez. We should make our fellow doctors aware about the importance of oral health, especially periodontal health, so that they will be able to refer patients to, and they will be able to advise them regarding the importance of oral health, because many of these oral conditions, especially periodontal conditions or other inflammatory conditions, can negatively affect their systemic health. So as per the statistically significant evidence available, this is having value in making patients aware of the importance of periodontal inflammation that can negatively affect their systemic health, especially this listed cardiovascular, diabetes, respiratory, adverse pregnancy, etc., etc. And also the importance of periodontal intervention that can improve their systemic status. So oral health should be brought into the light of with due importance in front of the colleagues of our medical profession, to make them aware regarding the importance of oral health. That's a very relevant question, and it is very well depicted in the initial slides, that initial videos that we have before every day during this PG convention.
So I think Dr. Hari Kumar has rightly pointed out that this is actually this can be the theme of the as in the videos which show, no. So the importance of oral health in systemic health, and oral health to be the part of systemic health. So if we take home this message and stress the importance of oral health and periodontal health, so if not the systemic health, at least the periodontal health of the population will definitely improve.
Definitely, sir.
Yes. So thank you, Dr. Amit and Dr. Hari Kumar, for excellent presentation and then apt answers to the queries. I think the audience is satisfied with the queries, answers to the queries. So a big thank you to the panelists, to the organizers, to the ISP head office for making this event possible and making it successful.
Thank you, sir.
Thank you.
Thank you very much.
Thank you, sir.
Good afternoon. On behalf of Indian Society of Periodontology, we express our sincere gratitude and pleasure in thanking Dr. Mangesh Patnaik for his excellent way of moderation of this session. It was really a thought provoking session which shed light in this spectacular topic. Thanks a lot, Dr. Mangesh Patnaik, for moderating this session in an excellent and interesting way with all scientific evidences and enlightening us with your experiences and knowledge. Thank you.
Thank you all for
Thank you all.
joining us in this program.
See you again, sir. Bye.
Thank you, sir. Thank you.
Thank you, everybody.
Thank you.
I think, Jilu, this is the end of today's program, so I'll just take over. Can you hear me?
Yes, sir. Yes, sir.
Thank you very much, all the delegates who joined us in the Didar Singh Rial main auditorium for today's session. It was a wonderful session that kickstart with some amazing presentations. We started off with the excellent presentation in the morning session by Dr. Alian Romanos on the gummy smile and the combo treatment in 2025, followed by mind-blowing presentation by Dr. Amit Mohindra on guided implant surgery and real-time videography. We have to really appreciate the efforts taken by these international speakers whose timelines are about 4.5 hours behind us, who have got up early in the morning on a weekend at around 4 o'clock or 5 o'clock in the morning and delivered such excellent presentations. Then we also had two wonderful discussions on the perio-medicine aspect of periodontitis and heart attack, whether it is a myth and reality, and whether periodontal therapy can influence systemic parameters, whether they are clinically or statistically significant and relevant. So again, a wonderful day's program comes to an end. Well, Saturday being the middle day of any conference and convention is always the banquet day. But unfortunately, we are all sitting at home. So we can only join each other for the banquet in mind, in soul, and in spirit. So unfortunately, we cannot meet, but the moment the COVID is over, we are all going to get together again, whether it is a convention or a conference. And see you all tomorrow at 9 o'clock. We're going to start off with another international keynote speaker on the management of extraction socket in the periodontitis patients, and wrapping it up with another point-counterpoint session. Glad to have all of you here for today's session, and see you tomorrow. Goodbye. Jai ISP.
Goodbye. Thank you, sir. Bye.
okay. That's okay. So
okay.
And then there's a huge response. I've been told that we are close to probably over 900 registrations already.
Oh, that's great. That's exciting.
And across the globe. So in fact, this probably would be one of the most well-attended perio webinar across the globe. The other day we were in a webinar with Shor Lapira and Ilor Shapira, and then we had been saying the top on the list is with us today. He is Professor Alessandro Quarento. Professor Alessandro Quarento is a senior clinical specialist in the Department of Newcastle. In 2019, he was awarded the National Scientific Qualification from the Ministry of Education, University and Research, which is the highest academic qualification in Italy, and qualifies for a full professorship. From 2018 to 2020, he has been the Professor of Periodontics at the School of Dentistry and Oral Health of the Griffith University, Queensland, where he also served as a Director of Specialist Program of Clinical Dentistry specifically. Previously, he has been the lead of the discipline of periodontics and implantology at the University of Western Australia. He was the founding leader of this group's research program in oral implantology and periodontics from 2016 to 18. He also coordinated the specialist clinical service in perio and implants of the Center. He has also worked as senior lecturer at the prestigious University of Otago, New Zealand. Over the years, Professor Quarento has actively conducted research in the broad fields of peri-implant tissues, post-extraction implants, bone-to-implant interface, alveolar ridge preservation, periodontal regeneration, implant surfaces, immediate loading, non-surgical periodontal therapy, and systematic reviews in implant dentistry and periodontology. The topic that he has chosen for today to share with us is on periodontal regeneration, which certainly is a very, very exciting topic and is probably one of the most intriguing topic in the field of periodontology, which has more questions than answers ever since it started. So we are hoping that we will be able to have answers to some of those questions which we have always been hunting in the literature from the man himself. So Dr. Alex, we invite you for this wonderful opportunity, and thank you very much from the entire society for having spared your valuable time. We know we have actually pulled you out of surgery and out of your clinics for this time, but we really appreciate your efforts. Thank you very much. And now if you want to take over.
And thank you for the very kind introduction, Dr. Aziz. And I'm very happy, excited to be here today with all of you. And I would like to thank the Indian Society of Periodontology and the president, Dr. Naimfia, for the kind invitation and for organizing this webinar. So, as you have heard, I'm based in Newcastle and in Sydney. So I live in the area of New South Wales in Australia. It's a beautiful area on the Pacific coast. And as you can see in Newcastle, we are surrounded by water, and that's where we have our specialist practice as my specialist suite. And I have recently joined, after my relocation to New South Wales, the postgrad teaching team in periodontics and oral implantology at the Sydney Dental Hospital and University of Sydney. So let's start with the topic of today, that is regeneration, fact and fiction. And let's start from what is unfortunately the case in many countries and many dental practices. So have you ever considered that there are many teeth that are every year extracted for periodontal reasons, but when we look at this teeth, as in this paper from 2002 that was carried out in the former Eastern Germany, many of these teeth actually have a significant residual attachment in terms of periodontal support. of up to 70% in teeth that don't have any caries, don't have any need of root canal treatment. So unfortunately, the threshold for periodontal extractions seems to be very low, and this is very alarming. And that's what happens in the everyday clinical scenario. If you look at this case, a young graduate from Western Australia has done this extraction on a tooth that could have been completely restored, and in a very enthusiastic way has placed a implant, unfortunately in a position that was not ideal to be restored. And so the only treatment in this young lady with a high smile line and high aesthetic demands was to extract the implant and starting again from scratch. And even when we need to extract teeth because the overall prognosis is questionable or hopeless, and we selectively decide with the patient to go for extraction. Well, the gold standard, of course, is placing implant, but we have to consider that also in the case in which we place implant in a proper three-dimensional position that can be restored in a correct way, as in this case of a alveolar ridge preservation and a placement of a single implant, what is the most, I would say, correct number that we can give to our patients in terms of long-term survival, and I'm talking about at least 10 years. So if we want to be very upfront and give some correct numbers, we should look at papers like this one that's been published by the group of Dirks and Berglund some years ago, assessing a population of 600 patients in Sweden that have received implants over a time of 9 years. And what we know is that we have an early failure of around 4.4% and a late failure, so after the restoration, around 4.2%. So overall, the risk of losing an implant over 9 years is around 8.5%. And this should be the numbers that we should share with our patients. So we should talk about a survival rate that is around 92 or 91% along 9 years. So you understand the importance of trying to save in teeth through overall a comprehensive multidisciplinary dental treatment, which includes periodontal surgery. And today we will discuss about regenerative surgery. Because otherwise, the risk is that we will operate under what I call the law of the dental implant. So what is the law of the dental implant? It's an idea that I've published as editorial a couple of years ago, thinking about a psychological law, that is the law of the hammer or the law of the tool. So the law of the hammer is a psychological law that is based on a cognitive limit, on a cognitive bias. That is, if we only know how to use an instrument, we will use that instrument for every purpose. So if we know only how to use a hammer, we will think that everything that we encounter needs pounding. And this is my 15-month old boy, Leonardo, and you can see that if you give to Leonardo a hammer, it will start to pound everything because it doesn't know the difference between a hammer and a nail, a hammer and a bulb, so it will use it in every condition. And that's the same for the law of the dental implant. If we train our students, our future colleagues, our future specialists, only giving them implant skills, they will think that every patient that they encounter need several dental implants. They need probably extraction and replacement of teeth with implants. And so we could have something like this. So we could end up with dental metallurgy. So we definitely have to avoid to operate under the law of the dental implant. Implants are a great way to replace teeth that are missing, not to treat periodontal disease or endodontic problems or restorative problems. So periodontal surgery has great potentials. And when we talk about periodontal surgery, there are, of course, several different ways of classifying it. So my personal classification that I use is a distinction between access surgery and pocket reduction. That is an open flap debridement and modified with mount flap. A resective surgery that aims at eliminating pockets and usually is combined with a perio-pros treatment. And of course, we have reconstructive surgery. So this is about the management of residual pockets, residual furcation involvement. And we have then, of course, mucogingival or plastic periodontal surgery, which is a complete different type of procedure. So again, the main topic today will be reconstructive surgery, and I will try to do it looking at the fact and the fiction. So I will use this evidence-based traffic light. So when we have fact, we will have a green light. When we have limited evidence, we'll have an orange light. When we don't have evidence, we will have a red light. But at the same time, when we take decision for our patients, we cannot base our decision only on evidence-based dentistry. As you can see in this editorial, it's important to understand that we need clinical knowledge, we need clinical judgment, and most of all, critical thinking. So knowledge is not just a synonymous of information, but is an educated interpretation of information that we will share with our patients. Because otherwise we will end up in a different paradox, which is the paradox of the parachute. So I think that based on our critical thinking, we all agree that jumping from an aircraft with a parachute or without makes a big difference. But if we want to look for evidence based from this point of view that the use of the parachute reduces death and major trauma compared to jumping from an aircraft without it, well, we don't have evidence from the scientific point of view. Even if we look at both randomized clinical trials and systematic review. So that's the same for our clinical decisions. I mean, there are a series of clinical decisions that we have to take based on our critical thinking. We cannot only apply evidence-based dentistry, because otherwise we will find a condition in which a series of procedures that make sense to perform are not performed because there is not enough evidence. So that's the introduction that I wanted to share with you. And this is my agenda today about reconstructive or regenerative surgery. So we'll talk about a series of basic concepts that actually are very important. Many clinical concepts for single roof teeth that can be applied also on molars where we don't have furcation involvement. Clinical and patient-related outcomes and the histological outcomes will be part of the conclusion of the presentation, with some slides to summarize the findings from this point of view. And finally, we will draw some conclusions. So when we talk about periodontal regeneration, should that we all know the didactic definition. So it's a restoration of lost periodontal support. So that includes new cementum, periodontal ligament, and alveolar bone. And of course, the only way to confirm periodontal regeneration is through histological analysis, which is not possible in everyday clinical practice. So we cannot do, of course, on our patients. And when we talk about regeneration, again, histologically, we should find a new attachment with new collagen fibers that are inserted on a root surface that has lost periodontal ligament because of periodontal disease. Again, this can be confirmed through histologic analysis, but unfortunately it's not what we can do on a daily basis. That's the reason that we need surrogate clinical parameters. And from this point of view, I believe that the composite outcome measures that have been recently proposed by my great mentor and friend, Professor Trombelli, are among the best ones that we can use on a daily basis to understand if by using a regenerative approach with the proper flap and biomaterials, we have achieved regeneration. So what we can use is a gain of clinical attachment level of at least 3 millimeter and a pocket closure combined with a pocket closure so that the probing depth is less than 4 millimeter and without bleeding. So if we meet these two combined criteria, we probably have achieved regeneration. Of course, we can use our radiographic findings, and that's also very important. But that's the best way to assess the results of our surgery. So starting from the beginning, the management of intraosseous defects is a procedure that nowadays we do thanks to a series of very important intuitive clinical observations from Pritchard in the 50s that observe how the management of the infrabony defects could result in bone filling. And that's the same of the paper from Rosling, in which observe how we can obtain more bone fillings when we manage an infrabony defect without bone recontouring. So to achieve periodontal regeneration, we need a series of conditions. So from the site point of view and from the systemic point of view, I would say that we need a proper blood supply in the defect, a wound stability with primary intention healing of the area of the surgery. And when we talk about wound stability, we also mean fibrin adhesion to the roof surface. If this fibrin adhesion is broken by different factors that we will discuss, it's very possible that instead of having regeneration, we will have a healing with long junctional epithelium. And we need time. We need time so the biology can work. On top of that, we always need a supporting structure that in some type of defects will be given by the morphology of the defect and the soft tissue. In other conditions, we will need barriers and membrane. We need cells, and we need ideally periodontal ligament cells if we want to achieve complete regeneration and not just bone filling. And we need carriers for our cell information that can be our amelogenin, it can be our biomaterials. So, which are the main clinical indications? What's the rationale of performing a regenerative, again, I would say reconstructive, because we don't always have histological evidence procedure. So we usually approach deep angular vertical intraosseous defects, so with at least 3 millimeter of intrabony component. And the rationale is to have an increase in the periodontal attachment of teeth that otherwise would be severely compromised and could be considered as teeth to be extracted. A decrease in the pockets so that they can be maintained by our patient. And the results, as we have already discussed, should be we should have additional gain in clinical attachment compared to what we would achieve only with the open flap debridement or modified with band flap. So with this procedure, with the open flap, probably we would achieve a clinical gain of up 1.3 millimeters. With reconstructive surgeries, if we look at a series of review, and there is also this recent one from Nibali and the European Federation of Periodontology, we can obtain an additional gain of attachment of up 1.5 millimeter on average. So again, overall, we should achieve at least 3 millimeter of curl gain with a successful regenerative procedures. And what's the rationale for the patient? Why they should undergo a regenerative procedures and have also additional costs in terms of biomaterials and procedures? Well, we want to maintain teeth that are functional and comfortable, preserving a acceptable level of aesthetics, as in this case, delay the tooth extraction on a medium to long term, and that can decrease the financial burden for our patient. And if you look, for example, at some North American literature, or this review from CAO 2015, it stresses the important point that it can be also a clinical strategy that can result in a defensible and prudent approach by the clinicians, because otherwise the patient could raise questions and problems about a early extraction. So overall, our periodontal surgery, if successful, will contribute to achieve what is periodontal stability, which is the final outcomes of our periodontal therapy. So a condition with minimal full mouth bleeding or probing, minimal number of pockets, and pockets that can be maintained by our patients. Overall improvement in other clinical parameters like plaque score, furcation involvement, mobility, and most of importantly, lack of progression of periodontal destruction. So our patient should fall into the periodontitis stable patients. So let's start to talk about the factors about the defects. So I'm sure that you are, most of you are familiar with the classification of the defects. So we can have suprabony defects, and these are the ones that we cannot predictably regenerate with reconstructive surgery. And then we will have a series of intraosseous defects. The general classification adds infrabony, which includes intrabony, interradicular, basically furcation involvement, craters. They all have the base of the defect that is apical compared to the alveolar crest bone level. And when we look at the intrabony, they are the one with 3, 2, or 1 residual walls. So the number of walls that faces the tooth. And in a clinical reality, we have many scenarios in which there is a combination of residual walls, usually 3 or 2 in the most apical part and 1 or 2 in the most coronal. So today we will focus mainly on the intrabony defects. So some basic clinical concept. Again, with our surgical approach, we want to create space for the blood clot and the fibrin to adhere to the root surface. Stability of this blood clot, again, so that the fibrin can be nicely adherent to the root surface. Soft tissue protection from the bacterial penetration, so a primary closure, as in this case. So the combination, we will see, of the flap design, the suture technique, the use of biomaterials will help in achieving these 3 conditions. And when we talk about the flap, ideally it should completely preserve the soft tissues. So we have a series of papilla preservation technique, and we will go into detail. It is usually a full thickness flap because we want to avoid perforation. We want to have nice thick tissues around our regenerating area. And a passive primary closure that protects the regenerating area, because again, the exposure of the graft, the exposure of the membrane can definitely compromise our results. And that's the reason that in some cases we will use periosteal incision to have a flap that will be passively mobile in a coronal direction. So when we talk about flap design, I think that the contemporary approach, and again, if you look at the review that I was quoting earlier from Nibali 2020, that is from the European Federation of Periodontology, has been published on JCP. So the contemporary approach is definitely wherever we can with a papilla preservation approach. So the papilla preservation can be with a double flap reflection or a single flap reflection. The double flap so the papilla preservation and all its variants. It's a full thickness flap in which, as you can see in the drawing, schematic drawing, and then we see some clinical cases, we carry out an incision at the base of the papilla. We try to preserve keratinized tissue in the buccal flap and also on the papilla. And then we move gently the papilla, usually from the buccal to the palatal or the lingual, and we can assess our defect. When there is not enough space in the interdental area, so it's less than 2 millimeters, and we cannot even adopt the simplified papilla preservation technique, we will still use a full thickness flap, and we will see which one. There are other variants of papilla preservation flaps that actually are not used very commonly, so I will just skip because of time constraint. So the papilla preservation flaps have been then combined with a minimally invasive approach. So the minimally invasive approach in periodontal surgery has been introduced for the first time, I would say, by Harold, with a minimal flap reflection, special blades, minimal wound, and very soft handling of the soft tissue and also of the hard tissues. And what happened is that mainly the group of Cortolini has adopted the papilla preservation flap, so the double flap reflection, with a minimal invasive approach, so with high magnification and very small sutures. And this has resulted in very interesting outcomes. But one of the main big changers is actually all an Italian story, and I'm very proud from this point of view of being an Italian periodontist. That is the single flap reflection procedure. So it's still a papilla preservation, but as you can see, we will approach the defect only from one side. That can be either buccal, facial, or it can be oral, so palatal or lingual, depending on the position of the defect. And we will see that on average, probably, if we look at the literature, we can expect that 50% of the defects can be approached from a single flap approach. So it's not that uncommon, the condition in which we can adopt this flap design, which is very easy in terms of flap design. It can be problematic in terms, of course, of management of the defect and the bribe. So we will see into detail, but before of that, some other basic concepts about regeneration. So if we look at the historical concepts of GTR, we know that the key cell in regeneration are the PDL cells. They are the ones that are able to regenerate periodontal ligament, bone, and new attachment. It's not the bone cells, as we know from the study from Niemann and Kering, and it's definitely not the epithelial cells or the fibroblasts. So with this concept in mind, that's the way that GTR, as we know, has been developed. So it's the use of a barrier membrane that initially was considered important only for epithelial exclusion. Nowadays, we know that actually the barrier helps in providing space maintenance, in stabilizing the wound when we have defects that are not containing. When we have defects that are containing by themselves and we can adopt a nice flap design, we don't use any more barriers because unfortunately, even if they are resorbable, we always have a risk of exposure and complications. So these are our main regenerative materials. This is a very simplified description, but we have membranes, mainly resorbable. We don't use any more non-resorbable because when we use non-resorbable, they, of course, they will help, especially if they have a titanium frame in maintaining the space for the blood clot, but we need a second surgery, and this can result in bone resorption or in a recession. So we usually main resorbable we mainly use a resorbable collagen membrane. we have a series of graphs, and we will see the rationale using the graphs. And another big game changer that can be combined, and it's usually combined with a single flap approach, is all the biological active products. And I will mainly talk about endogen or amelogenin because that's the only one available in Australia, New Zealand, and Italy. That is where I practice in the last 10 years. Of course, we can also combine all these materials. And if you want to have a nice narrative review that actually looks also at the evidence of histology, this one from Skule in 2015, period 2000, is an excellent paper. So what about graft? Well, when it comes to graft, we have a limited, because of course we are always talking about a limited number of patients. We have a limited evidence of regeneration from the histological point of view with new attachment, histological evidence of regeneration with new bone and new cementum for most of the biomaterials. So I mean autogenous, allogenic, xenogenic, and to some limited event also synthetic materials. So it's good to have all these biomaterials because we also know that in some populations, some patients, we may have reserve in using either a biomaterial of animal origin or human origin that is not from the same subject. So we still use autogenous bone, usually combined with xenogenic or allogenic, and we know that it can help with regeneration even if there is a quite fast resorption. When it comes to allogenic, so from same species but different individuals, we know that the FTBA, so the dry frozen bone of allogenic origin, has theoretically a osteogenic, so osteoproliferative action as well, because it may contain BMP. The problem is that we don't know how much BMP each sample contains. And this is about allogenic. When it comes to xenogenic, they are of animal origins, usually bovine origins, and the treatment is to have this material safe is such that once they are being de-antigenized, they are similar, very similar, I would say, to alloplastic materials, to synthetic hydroxyapatite. But we have a lot of evidence, of course, of a real regeneration with xenogenic biomaterials. So overall, most of these biomaterial have an osteoconductive action as a scaffold. Some of them they have osteoinductive action, so they can promote regeneration adjacent to the graft. And some of them, mainly the DFDBA, have also ability to contain bone-forming cells like the ones in the BMPs, and so they have osteogenic action. So we have evidence. We don't have enough histological evidence, of course, because of ethical problems in doing histology on humans. And if we think about the concept again of GTR, this graft cannot work in terms of GTR, in terms of recruiting PDL cells, but they definitely have an additional action, as we have seen, in terms of regeneration. So we know that they have an additional help in terms of space provision when, for example, we have a one-wall deep angular defect. They help in blood class stability and supporting, again, the soft tissue when we have a non-containing defects. And it's difficult, again, to compare the regenerative procedures with or without biomaterials. This study from Farina, Trombelli, and Rasperini, it's a very nice study. It's a pragmatic study in which once the periodontists, they are all expert periodontists, raised the flap, they decided, depending on the morphology of the defect, if they use only if they had to use only amelogenin or a combination of amelogenin and xenograft. And even if they were not calibrated, most of the clinicians use the combination with the one-wall residual defect or with a wide two-wall residual defect. So that's the rationale of using the graft. Because if we have a very narrow defect with the 3 residual walls, probably in most of the cases we opt for endogain. And that is gradually bringing us to talk about amelogenin and endogain. So first of all, is there any evidence that the generic roof surface decontamination or conditioning has a adjunctive effect in terms of regeneration? Well, it's a limited evidence. So if we look at the review from Mariotti, the evidence is there is no evidence. But the rationale, again, we have to think also from a critical point of view. There is definitely a rationale. There is definitely a something that is obvious in demineralize the dentine surface, so the roof surface, so that we can have deposition of new cementum through induction of mesenchymal cells and a improved adhesion of fibrin. So overall, the surface biomodification is something that we can do. We can do with different products, as you can see, but we have limited evidence that he has an adjunctive effect. And that's different from when we use the pref gel on and then we use amelogenin. Because with amelogenin and endogain, we have a lot, I would say, an impressive evidence that it can help with regeneration. So, as you know, the amelogenin gel is composed mainly of protein that are of porcine origin, and again are enamel proteins, and most of them are amelogenin. And in a series of studies, you can definitely go over this review for Myron 2014, but also other additional review. We have seen how they the application of endogain of a roof surface as a series of actions that favor regeneration and new clinical attachment. So overall, we have a increasing expression of growth and differentiating factors, so osteoinductive effect, an increased cell proliferation of cells that can contribute to regeneration, and mainly PDL cells. We have a decreased osteoclastic activity, so bone resorption activity, and upregulation of bone formation markers and growth factors. On top of that, we have an increased migration and proliferation of immune cells that will contribute to or remove what we consider, let's call the granulation tissue full of bacteria, and increase angiogenesis and also biofilm removal. So the actions of endogain are very impressive and at different levels, as you can see. And it's completely safe. This is a study that we carried out some years ago on a New Zealand rabbit model. And we have created these 8mm defects. And some of them were just filled with endogain, and some of them were left spontaneously healing. And we haven't observed any significant difference in the inflammatory process and healing process between the endogain and the positive and the negative control. So the endogain around bone defects is resorbed in 4 weeks, and that's probably what happens in our patients. So the question again is, should we combine or not, to graft or not to graft? It definitely helps when we have unfavorable anatomy. So we will use again our amelogenin and our biomaterial in what we call a sandwich approach. And that's something that, to some extent, again, if we look at the literature, is confirmed. In many studies, there have been a better gain of periodontal attachment and PIPD reduction when we have used GTR concept with xenografts, but to some extent also when we combine xenograft or allograft to amelogeny. So let's move to the aspects related to our patient. So let's start from the assessment of the overall assessment of our patient. So when we select our patient, first of all, we have to consider factors at local, behavioral, and systemic level. So local level, we'll check in the next slide. Behavioral level, we definitely know that smoking has a negative impact in any procedure that we perform, both non-surgical and surgical. And when we approach the defect with regenerative procedures, we have to seriously and honestly discuss with our patient which are the risk of failure because of smoking. At systemic level, again, it's always good to treat patients that are controlled from diabetic point of view and other general condition, including stress. So we know that, there is no strong evidence, but we know that some condition like vitamin deficiency, poor nutrition, hormone changes can have a negative impact. And also age plays a role. You will see 2 or 3 cases, and I will tell you which one is the young patient and which one is the senior. So of course, the regenerating potential, even when everything goes more or less well in terms of the clinical procedures, is different between a senior patient and a patient that is a young adult or a young person. So when it comes to the overall or periodontal assessment of our patient, periodontal regeneration, of course, is applied after the initial phase and after the reevaluation. So if you look, for example, again at the guidelines from the European Federation of Periodontology, they even recommend of waiting at least 6 months from the initial phase. And that's what in many cases we do. Sometimes we do it a little bit early, but we definitely need to have a patient with a low full mouth bleeding score, with a good plaque control, good commitment to the therapy. So a patient that has been already able to attend all the appointments that we need for the initial phase, the reevaluation. In terms of smoking, again, we know that no smoker or what we call in Europe light smoker can definitely heal better than heavy smokers. There is a dose-dependent effect, as has been shown in this series of papers from 2080, and as you can see, is very impressive. The difference between smoker and non-smokers. How about the tooth? The teeth that are involved in the procedures? Well, we have to assess the vitality of the tooth. So a endodontic diagnosis and assessment is very important. We are talking about teeth that sometimes have deep defects up to the apex of the roof, but they are still completely vital. So sometimes we can even opt for a strategic root canal therapy. But if there is indication for root canal therapy, this has to be done definitely before the regenerative procedures. And when it comes to mobility, well, grade 2 and grade 3, they definitely need splinting before the periodontal surgery. And how about the defect morphology? Again, we have to assess carefully, and we can do it during the non-surgical therapy at the reevaluation, but usually we have confirmation at the time of the surgery when we have numbed the patient and we have performed the bone sounding. We need to have a clear idea about the number of residual bone involves on the area of the defect. In this case, well, only one in the most coronal and 2 on the most apical portion. The depth of the defect. Again, we manage with regenerative procedure defect that have at least 3 millimeter of intrabony component. Otherwise, we can go for a resective surgery or open flap debridement. So in this case, you can see how the intrabony defect component is definitely very deep. We have a probing of 10 millimeter, almost 10 millimeters, and probably 5 to 6 millimeter are intrabony. The width, the angle, is very important. So, especially in with traditional approach of a envelope flap or with double flap reflection, we know that if the angle is wider than 25 degrees, probably the regenerating potential is decreased. And again, we have talked about the endodontic status and the mobility, but all these factors are necessary to select the proper flap design and regenerative strategy. Again, this case has been managed with a combination of endogain, allogenic graft and membrane, because you can see how it's not containing, it's not self-containing, it's very wide. So if we use only endogain, the risk is that the flap will collapse and we will not have space for the blood clot, we will not have a nice adhesion of the fibrin on the roof surface. And we also have to consider the flap design on the base of the clinical condition. Again, when we have more than 2 millimeter of interdental space, as in this case, we can definitely go for a double flap approach with the modified papilla preservation technique. And we will see a case about it. When this space is narrower, so it's less than 2 millimeter, we will need a simplify. In the dentulous ridge, the incision will be crestal. But the other important factor, and there will be a very important slide I will share with you, is that we will have to understand if our intrabony defect involve more than 1/3 of the roof. So basically, if it's only on the buccal side or the lingual side and on one interdental side, we usually can approach with a single flap approach. If it's more than 1/3, we will definitely need to raise a double flap. So that's another important factor in selecting our flap design. So again, the interdental space, but also the extent in terms of buccal lingual extension of our defect. So again, when we have a defect that extends for more than 1/3 of the roof and the tooth surface, and we have at least 2 millimeter of interdental space, that's where the double flap approach with a modified papilla preservation technique works very well. So the modified papilla preservation technique was introduced in the mid-90s by Cortellini and Tonetti. It was a modification of the Takei technique. Takei technique was a preservation of the papilla just for preserving aesthetics. And Tonetti has had the intuition that by using this technique, it could preserve the soft tissue integrity in the interproximal area, and that could have been definitely helpful in a GTR approach, so in a regenerative approach with membrane. And this group of researchers, in a series of studies, they have clinical results at 20 years. They definitely confirm how we can obtain better clinical outcomes with a modified papilla preservation technique, so with a double flap reflection technique, compared to conventional flap design. So let's see a case. We have, as you can see, sufficient interdental space. We have a deep intrabony defect on both the buccal and the lingual. It's quite narrow, and it seems like having 2 residual walls on the most coronal part and 3 on the most apical. So we have approached it with a modified papilla preservation technique. So it's a double flap approach in which we preserve the papilla. So after we have numbed the area, we will perform an incision at the base of the papilla, and we will try to preserve keratinized tissue on both the surgical papilla and the buccal flap. Then, with a series of miniaturized instruments, and these are a periost elevator from U3D designed by Professor Trombelli is extremely helpful. We will start to raise with a full thickness flap the buccal flap. After that, we will desiccate, undermine, I would say, with our 15C or microblades, the papilla in the interdental area. And then we will extend the incision on the lingual part of the flap without cutting interdentally. When we see that the papilla is nicely mobile, we will combine pulling movements on the lingual aspects with our periost elevator and pushing, very gentle pushing movements on the buccal aspect, and that will allow us to reflect the papilla on the lingual aspect and maintaining a completely preserved. We will start then the degranulation of the defect, which means the removal of the degenerated, infected and necrotic tissue. And we will use Mini 5, sling tips, and Hirschfield files. So when the defect is nicely debrided, we will select the regenerative strategy. So in this case, we have opted for all endogain. It was part of a course back in Italy. And as you can see how the lingual papilla has been very nicely dislocated and preserved. If you use a biomaterials or membrane, you will need periosteal incision with your 15C or microblades. You need very small automatic tweezers and micro scissors. And also with this suture, we usually use 5-7-0 sutures. So what I usually recommend to my students and during my courses is to start with a pre-suture. So in this case, we have raised the flap so that the flap has no tension also on the two nearby teeth. So you can start by suturing the nearby teeth after the flap is nicely passive. Then you can prepare your horizontal internal mattress in the surgical area. And before closing it, you can place all the biomaterials. And that limits the time that the biomaterial is exposed to the mouth. And then what we need is just time and be sure that the area has a primary closure, there is blood clot stability, there is no trauma. So we see also the post-op instructions, they are very important. So what will happen in the first part of the healing, in the first 10 days? As you can see, we have a inflammation that overlaps between day 1 and day 3, early and late inflammation. Then we start to observe the formation of granulation tissue. And at the same time, we have also wound contraction. So that's the importance of having, our flap nicely passive. And then we will have collagen accumulation and over the time, over months, maturation and regeneration. So you can see how the healing has been very nice, and 6 months following the procedure, we have already achieved our composite criteria. And again, the healing will run over the months with angiogenesis, formation of the extracellular matrix. So that's the modified papilla preservation technique. When we don't have, when we don't have enough space, so it's less than 2 millimeters, we can use the simplified papilla preservation technique, which is just a diagonal incision, and then the procedure is very similar. It's more tricky because your papilla will be very tiny, so there is some risk of necrosis. When we don't have space at all, or we are concerned about the management of the papilla, we can do a full thickness flap, trying to preserve the maximum soft tissue in the papilla. And the way to do it is by moving your blade always from the interdental area to the mid-buccal of both the side of the papilla. And what you can obtain, we'll see, it's a very nice papilla that maintain all the volume, and then you can perform your surgical procedure. And that's usually what we need in some, let's see, in some posterior areas. So it's basically a modification of what has been described by Michaelides in 1996. And you can see again how the papilla is preserved in all its volume. But the main game changer again has been first the application of these double flap procedures with a minimal invasive approach, and this has been mainly described by Cortellini and Tonetti, and then understanding that we can approach actually many of the defects with a single flap. So even when we have a narrow area, by not moving the papilla, we minimize the risk of necrosis. So the single flap approach has been proposed by, again, Trombelli and Cortellini, so two separate research groups at the same time with different names. But the rationale is to have a increased excellent stability of the flap, the blood clot, the vascular and the wound structure. We have, of course, the interproximal supracrestal soft tissue more intact than a double flap reflection. And there are also some histological data from this Japanese group that when you compare a single flap reflection with a double flap reflection, the wound healing is faster and better in the single flap, especially in terms of type 3 collagen synthesis, which is very important for our regeneration. The question is, of course, how often we can adopt this approach. Well, and that's the important slide I would like to share with you. Actually, it is quite common if you look at the literature, because at least 50% of our defects, looking at this paper from Tal 1984, are either on the buccal or the lingual aspect mainly. So they are the number of defects that have both the buccal and the lingual resorb, except for the craters, is quite high. So we have a significant number of 4-wall, 3-walls, 2-walls, 1-wall defects. Of course, we can regenerate the hemisepta and the craters, but we can regenerate all the others, and we can approach either from the buccal or from the palatal and lingual aspect with a single flap design. So let's see the procedure. The procedure, as you can see, and as Professor Trombelli says, is a very simple, it's even too simple. He says there is a stupid procedure for smart people. So it's basically an incision that is diagonal and that maintain the base of the papilla and is done at a level that you can maintain keratinized tissue on both the levels, but at the same time you can approach to the defect. After the cleaning, in terms of suture, we see that it's very simplified and easy because one of the two flaps is stable. And ideally, usually we can maintain a greater volume of intact supracrestal soft tissue, and we'll have also a better stabilization of the wound and a good patient comfort. So let's see this case. You can see a very deep defect in terms of probing depth and also intrabony component of the defect, and it's also quite wide. It's a senior patient, and that's the case I want to show you in terms of how, unfortunately, the soft tissues is in the senior patient. It's not always a great result. But again, let's see step by step how to perform the single flap approach. So the incision is done at the base of the papilla, and we follow the outline of the angular defect, and at a level that will allow us to maintain keratinized tissue, but also to access easily to the defect. So that's our defect before we remove the granulation tissue and before we raise and extend the flap on the two next teeth. And that's after we have done the degranulation and we have extended slightly the flap. So you can see that we have an intrabony component that is around 7 to 8 millimeters. It's quite deep. So we already have instrumented our roof surface with the slim tips, with the ISP, with the Mini 5, and we are ready to use the pref gel to condition the roof surface. After that, we first apply a layer of endocrine also on the supracrestal component of the tooth. We know that it's not predictable to regenerate, but we will try to manage also this one. And then in this case, we have used a xenograft on top of the endocrine gel, and it's already mixed with endocrine gel. And then you can apply some more endocrine gel. In terms of sutures, it's usually a combination of a horizontal internal mattress at the base of the papilla, a second horizontal internal mattress that approximates the connective tissue. Sometimes we, especially with this thick biotype or phenotype, we need some additional single sutures. And let's see, the healing at 2 weeks is not great in terms of soft tissues, but there's been a progression of maturation. And at 9 months, you can see how we have basically closed our defect. And 1 year we will also probe. And we have just given time to biology again to play and does their role. At the same time, what we need to achieve this regeneration in terms of blood clot stability, primary closure of the wound, and space maintenance has been done through the flap design, and all the carriers that we need for regeneration have been provided by the biomaterial, in this case, amelogenin and xenograft, that have also, in case of the xenograft, contributed to space provision. And that's another case. Again, this is to show you the differences between the approach from Trombelli and Cortellini, but it's very similar. The only difference in the case of Cortellini approach is that they use microscope and smaller sutures and a very limited mesiodistal extension. You can see how the healing can be extremely good in terms of primary closure and maintenance of intact soft tissues. So it's very important, our equipment, again, a surgical kit with precision instruments. If you want to have a list of the instruments that we use, just feel free to email me or contact me through our website. Small sutures also, in terms of suture, we usually use monofilament that can be proline or can be EPTFE. You can also consider some resorbable sutures, but not my preferred one. You definitely need a magnifying system and illumination. I personally use quite often the 4.5. Again, you can consider to use the microscope. And these changes in approach also have probably contributed to the positive trends over 2 decades, as shown in this systematic review from 2008, in terms of the positive trends in getting better surgical results over 20 years by different groups. Which are the contraindications to the single flap approach? Well, first of all, we have, of course, hopeless teeth, but that's the case for all regenerative procedures, and most commonly, greater immobility for periodontal reasons. And then the access to the defect. Again, if the defect is more than 1/3, we'll definitely need a double flap. What are the limitations? Well, limited visibility with narrow angle of vision compared to a double flap, need of increased illumination, and need of proper instruments. So again, that's summarizes our approach, and wherever we can, we go for a single flap approach. And that's the reason that we have published a network meta-analysis or review about the effect of the flap design when we use a melogenin in intraosseous defects. So it has been published by Professor Trombelli with ourselves and Professor Tu from the National University of Taiwan. So the PICO criteria were the treatment of intraosseous defects with surgical or non-surgical procedures, with endogain with or without bone replacement graft. And the outcomes that have been assessed were changes in clinical attachment level, probing depth, infrabony component of the defect, and recession. So with the network meta-analysis, you can usually assess and combine and compare studies that usually you cannot compare with a standard meta-analysis. So we have a compare single and double flap approach in studies with 6 to at least 12 months of clinical radiographic observation. So to make a long story short, our main results are that when we use all the single flap approach and variants in terms of changes in clinical attachment level and gain of clinical attachment level using endogain alone, the single flap variants compared to modified Wiedemann flap, papilla preservation, so double flap, papilla preservation with minimal invasive surgery and non-surgical therapy are the best ones. It's interesting how the non-surgical therapy is actually the best one, but we can obtain clinical attachment gain, but usually we don't obtain the same radiographic failing, and there are some other, there are very limited results actually about the non-surgical management of infrabony defects. When we move to endogain plus graft, we don't have information about the non-surgical approach, of course, so it's not possible to do it. We can only use the endogain with the non-surgical approach. And you can see again how the single flap approach and the double flap with minimal invasive procedures are the ones that perform better in terms of gain in clinical attachment. What about probing depth? Again, the single flap approach with endogain alone is the best one, also compared to the non-surgical. And the single flap approach with endogain and graft is the best one compared to the papilla preservation and similar to minimally invasive double flap procedures. And when it comes to infrabony, again, you can see how the two ones that perform better with endogain are probably the single flap approach, the double flap with minimal invasive, and also the non-surgical. But again, the non-surgical has very limited evidence and cannot be combined with the graft, where the single flap approach and the double flap still perform definitely better than a double flap without minimal invasive procedures. So overall, we can say that the single flap approach optimizes the regenerative outcomes of endogain with very good results in terms of clinical attachment gain, reduction of probing depth, and increase of the bone filling. And it's very similar to a double flap approach with minimal invasive procedure. But the question is that if we can use a single flap, we can raise only one flap, why we should raise two flaps if the results are very similar. So again, it's very important to be able to diagnose the morphology of the defect so that we can decide which flap design we will use and which biomaterials we can use. And that brings us to we are almost at the last part of our presentation. So we have seen the selection of the patient, the surgical approach, the regenerative strategy. what can be the results also from the evidence point of view, looking at our recent review in terms of using different flap design and different biomaterials. Let's see how we close, our flaps. So in most of the cases, we use either internal horizontal or internal vertical mattress suture, with or without additional single interrupted suture. So the internal mattress is as you probably already know, is a suture in which on each flap you will go through twice. So we start from the buccal, from the external to the internal part. Then we pass to the lingual, from the internal to the external of the flap. And then we pass again on the lingual flap from the external to the internal surface. And we will see in 1 second, that's exactly what we're doing. And finally, again on the buccal, this time from the internal to the external part of the flap. So what the internal mattress does is that it moves coronally our flap. So it helps, together with the relieving incision, to mobilize our flap coronally and have a nice primary closure that is free of tension. And that's what we want in a regenerative procedure. And is more variant is what we call is the one on the left, is what we call the modify single internal mattress, in which the steps are the same, except for the thing that on the lingual. So just focus on the left video now. On the lingual, we will leave a loop. And when we leave this loop, we use this loop to have a second line of closure. So in 1 second, you will see that we're leaving a loop on the lingual aspect. And in this loop that we leave, that's exactly this one, we will pass the needle from the buccal to the lingual. And this will give us a second line of closure of the flap. And it's a very good procedure and surgical suture that we can use when we want to, again, obtain a complete closure of the papilla with a coronal displacement of our flap. So that's, again, if you focus on the left side, that's the primary closure, primary line of closure of our flap, and then we will have a knot that is a surgical knot. So we use 5 or smaller sutures, and the removal is at 2 weeks. Why 2 weeks? Because we have a series of evidence. It's mainly, of course, animal evidence, so it can be limited, but we know that at 2 weeks, the adhesion of the fibrin to the root surface is stronger, so the tissues are more resistant to the mechanical application that we will have to apply when we need to remove our suture. And that comes from different animal studies. How about the post-op? Antibiotic therapy is quite controversial. Sometimes we use it, but we try to avoid it. It depends on the complexity of the procedures, I would say. Analgesic therapy and ISP, we definitely use it. And in terms of painkiller, again, especially with the single flap procedures, the amount of painkillers that patients need is very limited, and is usually limited to over-the-counter medication like ibuprofen or paracetamol. So the patient will have to avoid normal brushing and flossing in the treated area for 4 weeks and use chlorhexidine. At week 1/2, depends on the cases, it will start to brush with an ultra soft post-op brush, applying chlorhexidine gel. Interdental cleaning devices will be introduced after 4 weeks. And that's when full oral hygiene and mastication is resumed. In terms of a professional recourse, the patient is seen weekly for 6 weeks. At the end of this early healing phase, we will be seen on a 3-month recourse. And the first clinical probing lies gingival debridement and X-rays, even if we are curious, usually will not happen before 6 months, and in most of the cases before 1 year. Again, you can see the orange green light, traffic light, because it's something that there's not evidence in terms of pure evidence-based dentistry. There's not been comparison between different protocols, but it definitely makes sense, and it's common sense and good critical thinking to adopt this type of procedures for the post-op. What about the morbidity? So the discomfort of the patient. It's interesting how the paper from Cortellini has mainly assessed the overall discomfort, and there was very limited discomfort with 70% of patients that they were minimally invasive double flap procedure had not pain at all. The rest had only moderate pain with limited consumption of analgesics, around 2 per day. For the first 2 days. The paper from Skinkai has actually compared double flap to single flap, and in the single flap the number of analgesics was even lower. So overall, the discomfort is very minimal. What are the complications, main complications and failure of regenerative procedures? I mean, flap dehiscence and papilla necrosis is definitely the most problematic complications. And there's not much that we can do it, just be sure that the patient keep clean and already know that unfortunately our result is compromised. Graft exposure, I mean, it can happen, and that's the reason that wherever we don't need, we can only use amelogenin, we will not use it. And that's the same for the membrane exposure and contamination. And the only way to decrease the complications related to the membrane is not using again if we don't need it. So the optimization of the surgical approach, the variables has definitely improved the clinical outcomes, but complication is always something that can happen. And how about histological evidence? And then finally we'll draw our conclusion. So in terms of histology, again, this review from Sculen in period 2000-2015, and also some of his research and also some research from Dr. Asperini show that overall we have some human histological evidence for most of the biomaterials. Again, this table from the Sculen review shows that the regeneration that we can obtain with the different biomaterials in limited case series is around 70% for the combination, around 70% for the barriers, around very limited, I would say 30% for the alloplastic. The xenografts are comparable to the allograft, and with the autograft maybe there is some more evidence. But again, we are talking about studies that have a lot of limitations, small numbers, because it's not, of course, easy and possible to do histology on a big number of patients. But overall, we know that we can obtain some good level of regeneration, new bone and cementum regeneration, if we all the boxes that we see are ticked in terms of patient selection, proper selection of the flap design and biomaterials, and lack of complications. So what are the contraindications and the limits of regenerative procedures? Well, we have to remember that teeth are like human beings. I mean, they can be mortal, of course. So hopeless teeth, I mean, it doesn't make sense if to treat teeth with mobility tree or with other dental problems. The bony defect, including the supracrestal components of intra-bony defects that we try to regenerate, we know that it's not predictable to regenerate. So that brings me to the conclusions. So again, regenerative periodontal surgery, fact and fiction. So the facts are that we can obtain increase in the periodontal attachment of severely compromised teeth, and we can have long-term clinical results and functional tooth retention. I've indicated up to 10 years, but if you look again at the papers from and the studies from Tonetti, is up to 20 years. And that, of course, will also have a positive impact on the financial burden of the patient. We can definitely decrease deep pockets to a more maintainable range. So overall, the outcomes of the periodontal treatment can be driven to periodontal stability. And this can be done with outcomes that are definitely beyond, are better than the one that we can obtain with conventional flap surgery. And nowadays, we can do it with patient-friendly surgical approach, with a minimal invasive access, with a minimally invasive procedure with a single flap. The fiction is that is unpredictable, the regeneration of horizontal and supracrestal defects, and that I would say the real histological regeneration that we can obtain, it's a question mark, because the evidence from the human histological point of view is limited. So with this slide, I've concluded, and I thank again the Indian Society of Periodontology and also our society, the Australian Society of Periodontology, for the nice and kind invitation, and all of you for your attention. Thank you.
Thank you, Dr. Alex. I must say, a very engaging presentation. This can certainly be is reflective, in terms of attendance. When we had at no point in time, we dropped less than 500 on, which is the maximum, entry strength to our this. Not only this, we had at any given point in time more than 200 watching on the YouTube simultaneously. And that's essentially because you spoke so engagingly well, and you touched pretty much each and every topic which our PG is really required to know when it comes down to regenerative. I've been flooded with questions, more so on a private mode. We Indian students are by nature a little shy, so we tend not to be too vocal in terms of asking our teachers. But then, they have certainly asked few questions, and if you have time, can we go over maybe a couple of them if you have time?
Sure, absolutely. Yeah, I'm all yours. I still have some time.
Perfect.
I've 15 minutes actually.
Oh, excellent. So we can really take a lot of questions in that case. So one of the questions that came was from one of the students was when to reprobe the area to evaluate the healing potentials. You mentioned 6 months at one point in time. The literature mentions around 8 months at some, so there's a little conflicting views on that. So what is your take on that?
Absolutely. This is a very interesting question, because again, we are always curious to see our results, and it can be, deleterious for the healing. So again, if we look at also the graphic that I showed to you, for a complete periodontal regeneration, it takes some months. It's not as for non-surgical therapy or open flap debridement, where after usually 8 to 12 weeks, we reevaluate the site. So it's a complex process in which we have a series of biomaterials. So again, there is no strong evidence, and this is also a question that I asked last year when Leonardo Trombelli was our guest in Gold Coast, and we ran a series of educational events. So it's still, and we are all still prudent to wait at least 6 months, because when everything is fine, you may probe even earlier. But if it's prudent to wait at least 6 months. What you can do at 6 months, and probably you've seen in some of the pictures, we can even probe with the flexible plastic probe for implants, which is a little bit, more delicate in terms of the force that we apply. But I would say 6 to 12 months.
Perfect. The other question is, and essentially that comes from one of the senior members who was attending. When we look at the defect per se, hardly do you see a strict 2-wall, 3-wall defect. It's more so a combination, pretty much, and the combination is more. The number of walls keep on increasing as you go up cycle. Yet we don't see too much literature wherein a resective and a regenerative approach is kind of a combination approach, wherein you may want to go with a resective approach coronally and then be regenerative where you get 2 or 3 walls.
Absolutely. I mean, this is an option, and it's a very smart point. Most of the defects, yes, they are combination, as we have discussed, and the best approach is to regenerate first and see the type of healing. If on the more coronal part we have after the healing, we still have a 1-wall defect or a combination 1-wall to 2-wall defect, we can definitely consider a second limited surgical re-enter with a resective approach. This is something that it's always, I would say, wise and smart to share also with the patient and tell them that the procedure consists of 2 interventions. And then if we don't need the second intervention, we will not do it. And what will guide us in deciding if we need a second intervention, I would say that it's mainly the composite criteria that I was saying. It's the gain in attachment level, the reduction of probing depth without bleeding. Otherwise, yes, I totally agree that we may need a combined approach that is regenerative and resective.
Right. One of the questions that has been asked by Dr. Ashish Kumar, who is the editor of our journal Society, he also sat through your lecture for the entire duration. So one of the questions that he has asked is, you mentioned a target FMBS of around 15%.
Yes.
As literature quite clearly says that FMBS of 10% is pretty much in the range of a health. So under those circumstances, would you or would the student or the clinician be rendered more towards an aggressive maintenance to move him to 10% and maintain him on NSPT, or rather, just intervene at 15%?
Well, that's another important comment. Thanks for the question. Yes, ideally, especially if we look at the recent definition of periodontal stability, yes, is 10% full mouth bleeding score. And in my presentation, I've indicated 15. Let's say that 10% is definitely a more prudent level. 50% is something that to some extent, in many cases, before you start with the surgical phase, you may have in your patient, because otherwise, if you already have achieved 10%, probably with your non-surgical therapy, with your phase 1, you already achieved the outcomes of the treatment. So 50% is a reasonable percentage for patients that may need more than one surgery, not only regenerative surgery, but also access surgery, resective surgery. And ideally, our expectation is that after the surgical phase, we will have dropped that percentage to 10%.
Yeah, right. Good. So one of the questions, again, and this is coming out because at ISP we are now coming out with the good clinical practice guidelines for management of periodontal disease in diabetic patients. So one of the questions that we are actually contemplating in the whole, we have around 28 members who are contemplating these guidelines, is what would you suggest in terms of regenerative therapies in uncontrolled diabetes? diabetic. That, controlled, okay, we understand enough evidence is there. They don't behave really differently. But how would you manage an uncontrolled diabetes who has actually been indicated for a regenerative surgery?
Well, it's a very difficult question. I would say that with diabetic patient, especially with uncontrolled, you never know how they will heal in terms of mainly of soft tissues or overall healing. So my suggestion is wherever we can manage non-surgically, and we can try with a new course, at least a second or sometimes even a third course of non-surgical therapy, it would be ideal. If we opt for surgery, we should keep easy. So I would say either only as surgery without any bone recontouring, if possible, or we can, in some selected sites, which is the case of most of the regenerative procedures, so we are talking about selected sites, of course, we can opt for regenerative procedures, but again, try to keep simple also in terms of regenerative strategies. So just try to use amelogenin and bone replacement grafts without membranes, and be sure that you obtain a nice primary closure also with periosteal incision and passivity of the flap, because of course the main problem can be exposure of the graft or necrosis of the papillas.
Perfect. One of the questions is, and I think we'll try to wrap up now. One of the questions is that will the regeneration potential be same around the implants in peri-implantitis as compared to?
That's $1 million question. If you guys are interested in the future, we can have something about peri-implantitis.
Yeah,
it's very low. It's not the one that we have around the teeth. Honestly, first of all, again, talking about regeneration around implants is even more, fiction than around teeth.
Yeah.
In terms of reconstructing bone around implants, again, the histological evidence is very limited. It's mainly the animal studies from person. Having said that, again, we may talk about reconstructive rather than regeneration around peri-implant defects. And when we have the circumferential defects around implants, which is quite common, sometimes we can fill that defect with a biomaterial, with or without membrane. And the results on a short term to medium term are decent, but it's definitely something that is not predictable as it is around teeth.
Yeah. So one of the attendees was rather happy to see the photograph of Dr. Rasparini, who's a great regenerative teacher.
Okay, that's good.
Rasparini, we actually had Donald Trump and Barack Obama as amongst the audiences in your slides. So it was really, really wonderful, Alex, and
thank you.
It has been an amazing lecture, must say. This 1 hour 30 minutes spent with you are probably going to stay with us and the postgraduate students here for a long, long time. So again, from Indian Society of Periodontology, ma'am, you want to say something, Dr. Nemphia?
It was a wonderful lecture. Thank you so much, Alex. It was really very informative, and it must be very helpful to the PGs. Thank you so much.
Yeah. It was my pleasure. Thanks for having me. I'm impressed by the numbers coming from Australia. It's always a small number. That it's good for interaction, but I was very impressed by having 500 people. It was very, very nice. A great experience for me as well.
Pleasure is all ours, and we look forward to more such opportunities. Thank you very much.
Absolutely. Enjoy the rest of your day.
Thank you. Thank you very much, and you have a good one. Thank you.
Bye.
think after 2 minutes only we'll start.
Already 499 हो गया sir, 500.
हाँ ठीक है, वो YouTube में
Yes.
हाँ scenes
Yes.
To welcome you all to this prestigious event of ISP, that is Journey Ahead 2020. I express my sincere gratitude to the ISP head office for allotting us this program, and of course to you all for your esteemed presence in this program that will further dignify and magnify this event. Now you see, when I look back and think of the times some 23 years back when I joined my post-graduation at Government Dental College, Amritsar, as a naive beginner, even though I had the support and guidance of all my respected teachers and the seniors, but I had very limited opportunities to attend such programs. I never had a master to teach me how to select a topic for the dissertation, how to very impressively present a seminar topic, or for that matter, how to write a paper for the publication. So when I think of all these things, I assume that you people, that means today's students, you are much, much better off than we people. Now, I personally feel that probably ISP is the only dental professional body at the specialty level in India that organizes so many student-centered programs. If it is Pariche at the beginning of the career, then there is something called as Samiksha at the exit of the post-graduation. And in between, you all know there are plenty of programs in the form of colloquiums, symposiums, and of course, the two big events that are our annual conferences and the PG conventions. So that way, the Indian Society of Periodontology keeps all our students and the periodontists busy whole of the year. Now, we were supposed to have a Pariche program this year as well, but due to the prevailing situation of the COVID-19 pandemic, it could not happen. Now, even though year 2020 has been declared as 0 year by the ISP head office, but the ISP head office has very successfully kept all the students and periodontists in the country busy with different programs. See, Journey Ahead 2020 is a program in the same series that is being organized with the main aim to introduce our new family members, that is the first year postgraduate students, to the specialty of the periodontology. So in the course of 4 days, students will have the basic orientation regarding a variety of topics, which will tell them that what to do, what not to do, and how to do in the journey of next 3 years. Now see, we have a panel of 18 star speakers and moderators that will take you through this journey in the next 4 days. On the behalf of the organizing committee, I thank all the speakers and moderators for sparing their valuable time for this program. Now, flagging off this journey will be our first star speaker of the day, Dr. Nitin Dani. And the moderator for the first session will be Dr. Anirban Chatterjee. And I have been entrusted with the duty to introduce my dear friend, Dr. Anirban Chatterjee, to this esteemed audience. Dear friends, Dr. Anirban Chatterjee is, of course, a postgraduate in the field of periodontology, and along with that, he has done doctorate in dental sciences, and he's a fellow of implantology from New York. He is ex-vice principal and professor and head of the Department of Periodontics and Implantology, Oxford Dental College and Research Center, Bangalore. Dr. Chatterjee has got, to his credit, a teaching experience of more than 23 years, and he has got, to his credit, publications in international and national journals to the tune of more than 70 articles. He is a reviewer of 9 international and national journals, and he is live member of 5 societies, professional societies. And the big introduction to all of you is that he is one of a good friend of mine and is going to take over as the president of the Indian Society of Periodontology the next year. With this introduction, I hand over the charge to Dr. Anirban Chatterjee to carry forward with the further journey. Thank you so much.
Thank you, Baljit, for a wonderful introduction, and welcome all the participants who are there. So today is the first of our topic of this with the first year's scope of periodontology in dentistry. Like, what is the scope of periodontology? Let me tell you a small story. Means I'll just finish it up as fast as I can. Small story is, I also wanted to become a oral surgeon, but the second option was I want to become a surgeon, something to do with surgery, but somehow I didn't get a seat in surgery. So my principal told me, you want to do some surgeries, the second alternative is periodontology. It's the only, other than oral surgery, is the only surgical department in our dentistry. So I told, fine enough, let me take it up. And I don't regret my principal's words, because it is, I thought, or initially everybody thought, it is just scaling and root planing, but it is not that. Ours is the most, a department or a subject which does maximum amount of research all over the world. And all over the world, we are known as on that note, a implantologist too, because other than India and might be some subcontinent, periodontists are the main implantologists, because for us, tissue, 2 mm of tissue is the issue. If you can get a gain of 2 mm of tissue or even defect fill, that is a big achievement what we get nowadays in this world. So not wasting much of a time, let me introduce to you the first speaker of the day, and the first speaker of this particular program is none other than Dr. Nitin Dani, a person who is respected all over, not only India as a periodontist, all over the world also. He has numerous publications, and he has passed his MDS in 1985 from GDC Mumbai, where a lot of people who are listening, the participants might not have been born also. So we respect him, a very senior periodontist of India, very knowledgeable, and a person who is always in high spirit to give you the knowledge. He has been practicing for last 34 years in Nasik and was in teaching for 24 years. He quit the teaching job in 2015. And he is a past president of our ISP and a man of great stature, a great knowledge. So that's the reason we have given the opening innings to Dr. Nitin Dani, so that he will take it from here. A wonderful, spirited man, always in high spirit to give the knowledge, expert of his knowledge to everyone, each and very helpful, a very dear friend of mine. Nitin Dani sir has always been supportive for all of us, and especially in ISP. So with these few words, I would like to give the pleasure of my introducing Dr. Nitin Dani, ISP past president, to take over and tell the participants about scope of periodontology. Yes, thank you, sir.
Thank you, Dr. Anirban, so much for the kind words. And I'd like to share my screen with all of you, if it is okay.
Pleasure by introducing Dr. Nitin Dani, ISP past
So good morning, everybody. I hope I'm audible to all of you.
Yes, sir. Loud and clear.
Yes, sir.
Also looking fine, sir.
At the outset, I would like to pay my respects to the President of the Indian Society of Periodontology, Dr. Nimfia Pandit ma'am, and the Honorary Secretary, Dr. H.S. Grover sir, for converting this 0 year, as Dr. Anirban sir put it, or the pandemic year, or the 2020 year, into a year of so much of knowledge sharing, where we have been able to connect with people all across the country and the globe. And I'm very thankful for them to allow the conduction of this program, the journey ahead. I would acknowledge the splendid efforts put in by the ISP study group of Chandigarh, Dr. Baljit Singh, the chairman of today's program, and the ISP study group of Rohilkhand, and Dr. Shiva Manjunath, who is the organizing secretary, for allowing me to speak on this topic of the scope of periodontics as a specialty. You might see a different face in front of you, because as I was making this presentation, my granddaughter's a 3-year-old. She said, "You don't look like the picture that has been put up." So I had to put up a recent picture of mine. But the topic very much remains the same: the scope of periodontics as a specialty. Way back in 1982, when I did my MDS, that is actually 38 years ago, MDS was secured only on the availability and merit. When I say availability, it means that postgraduate seats were decided as per availability in the parent college only. So that means if you studied in GDC Mumbai, you would get to do your MDS only in GDC Mumbai and nowhere else. And that too was available only on the basis of your marks that you obtained. So it was the true test of aptitude. If you were good in prosto, you would do MDS in prosto. If you were good in wire straightening and bending, you would do in ortho, and so on and so forth. But in spite of topping Mumbai University in 1982 and securing the highest marks in many subjects, I did my MDS in periodontology. Now you will wonder why I did that. It wasn't my first choice, but it was my only choice at that time. But I do not regret it at all, like Dr. Anirban said. And I'm sure neither will you. Because whatever I have achieved is because of perio, because my master's is in perio, because my MDS is in perio. I was in academics for 24 years. Other than short of becoming the dean of an institute, I have been the professor, an HOD, a MDS guide, an MPhil guide, a PhD guide. And many of my students have gone on and done international and national prize-winning studies in their research and publications because of that. Not only academics, I have also been actively involved in my private dental practice. And because of my training in periodontology, I have specialized in oral rehabilitation. And I have been doing procedures that you see routinely on Facebook nowadays and on Instagram, way back in the 1980s and 90s, where documentation and social media was not so much in vogue. So I have been in practice for 34 years and I'm still counting. And one of my dearest friends, Dr. Vijay Deshmukh, recently renovated his clinic to a state-of-the-art clinic, and somebody asked him at this stage, he's maybe 5 years junior to me, and he said, "I want to practice for another 25 years. Same here, at the age of 60, I would certainly like to practice
till I'm at least 75. And my practice will continue because of my MDS in perio. I'm greatly indebted to the Society of Periodontology, the ISP, for allowing me to be a president in 2017 and has increased my outreach to people all over the globe. When I was a president, I wrote this small piece in the journal of ISP, to do or not to do. That is the question. And if you see the initial lines, I have said, sometimes life brings you full circle to a place where you have been before, just to show you how much you have grown. I don't know who has said it, but like the kind moderator said that in the 80s, it was thought that perio was only a scaling and polishing branch. And whether to do MDS or not was a question on everybody's mind. Not. But this circle of 24 years that has taken place, 34 years, has brought me to a place where I can now definitely tell you the scope of periodontics as a specialty. So way back in 1982, it was BDS or MDS because 3 years was a long time. So people advised, start right after BDS, set up your clinic and establish your practice. And now also people have been advised that because you can use these 3 years to do specialty courses in endos, in implants, in lasers, in aesthetics. What more do you need? But let me tell you, friends, if you are in practice, your patients in your private practice are not as forgiving as your patients in the dental school are. When they come to you in the dental school, they know that you are learning and honing your skills. And you can do all these techniques under the watchful eyes of your mentors, your PG guides, your HODs, which you cannot learn in overnight courses or weekend courses or small modules. So you should do MDS. But then once the MDS done, what is next? A lot of you must be wondering about that. Academics, you all know, is highly competitive in the face of limited opportunities. We have good credentials in private practice. And the best part of MDS is your changed attitude towards patient management. As a BDS, you see a cavity, you drill a hole, you fill it up. As an MDS, you see a tooth that is mobile, you wonder what caused the mobility? How can you stop it? How can you prevent it? How can you manage it? So this entire change of attitude you learn only when you do your masters. Everybody wants to do clinical branches of dentistry. You want to do endo and pedo because maybe they are the most highly paying branches. So with endo and pedo, you generally treat localized disease conditions. You see a tooth that is decayed, you do a root canal. You do a post and core, you do a crown. Orthodontics and prosthodontics people work mainly on the healthy patient. So rarely would an orthodontist work on a diseased mouth. Same way with prosto. And like Dr. Anirban said, oral surgery and perio are the two surgical branches of dentistry. Now let me tell you a little bit more about these branches of dentistry. Now with this so-called aptitude test, why I'm saying so-called, because I feel it doesn't test your aptitude, it only tests the way you can give your examination. But you have choices for doing MDS, choices of subjects and choices of institutes. So generally the toppers select subjects as per the hierarchy of learning or earning capacity. So that's why I said it keeps changing. At our time, orthodontics was right at the top because it was supposed to be an exclusive branch. Then was prosto, then was oral surgery. And then endo, which was known as conservative dentistry or operative dentistry at that time, was way down. But now you can see that the endo is going up and pedo is going up and perio has remained stable where it was.
Another thing you can select is how is the institute? Where do I get to do my MDS? People also go in and see how is the guide? Is he strict? Is he lenient? Does he allow you to do research? Does he allow you to take holidays? How is the hostel? Do you have an air-conditioned hostel? How are my friends? How is the city to live in? What's the nightlife like? Or what's the other scene like? So there are so many things. But there are many others like me who take whatever is available. And after this presentation, I know you will be sure that you have definitely made the right choice. MDS Perio has a great number of benefits. It is a clinical and surgical branch of dentistry. But as compared to OS, it is definitely very much less intense. There are no ward duties. There are no need to study related subjects like physiology and pharmacology and pathology and medicine and furthermore there is no need for further specialization like oncosurgery, cleft palate and lip, trauma. It is a low investment branch with quick returns. You don't need to invest in a hospital or take an attachment to a hospital and do so many other things. But if you like surgery, definitely you want to see blood, this is the branch for you. And you get multiple opportunities in your profession. Let me name a few opportunities that you would get if you do your MDS in Perio. Now, academics is one of the areas where a lot of people did their MDS. So from 1990s, when the private medical and dental colleges started coming up till the 2010, it was the prime reason for doing MDS. You do your MDS, you get a job, your spouse is also an MDS, you get 2 jobs in the family, and you can definitely earn a sizable amount of money by working in limited hours and don't have to worry where the next rupee is going to come from. Now, with the increasing number of postgraduates from the number of postgraduate institutes that are there, it has led to a severe competition for available jobs. Those who are having jobs are not quitting, and the number of jobs available are reducing. So then what do? You do private practice. Dentistry has always been a branch of private practice and not a branch for specialized academics. Private practice has always been the base or backbone of the entire profession. But unfortunately, exclusive perio practice is still a pipe dream. I don't know of many exclusive perio practitioners. I know one practitioner, unfortunately, is no more, the late Dr. Lalit Guglani, who was the founder, secretary of the Indian Society of Periodontology. He had an exclusive perio practice in Mumbai. But I don't know many others than that. In fact, branches known for exclusivity like orthodontics are also shifting to general dental practice. They have a way of getting along with it. They have a multi-speciality clinic. So if you want to do exclusive perio, you have 2 options. You do either consultation practice where you visit all your doctors and do only perio in their clinics, or you join a multi-speciality clinic where you have different specialties coming in to treat different patients. Or you do general dentistry with an emphasis of periodontics. I always say that the periodontist makes the best general dentist because you're aware of all the iatrogenic problems that could be caused and you're keen to avoid that. As periodontists, we are taught about total treatment planning and not limited to only the disease which could be localized. We think about the restorative phase, we think about the maintenance, and there are so many other things we learn about. And then there is, of course, referrals from general dental practitioners. So if you have your own clinic and you have people who want to refer patients to you, you are definitely going to get referrals. The only thing with referrals is you have to be very keen about referring back the patients for the routine treatment and not trying to do everything. And I think maybe it's because of this that I was selected to give a talk and the scope of perio because I have been in academics. I have done consultation exclusive perio practice. I am attached to a multi-specialty clinic. I do general dentistry on a day-to-day basis and I get referrals from my general dental practitioners. In COVID times, we are not having a huge number of patients, but that's how my practice has been. Limited number of patients, do good work, and see that you have patients which keep coming in for you all the time. So as the perio as a branch, the scope, I'm going to use a small analytical technique which has been there for many years, which is known as the SWOT analysis. It is strategic planning technique used to understand a business or project. So we are going to use this technique to analyze our subject, that is periodontics. So it is basically divided into 4 parts. That is S for strengths, W for weaknesses, O for opportunities, and T for threats. So we are going to study the strengths, weaknesses, and opportunities and threats of perio as a specialty in the field of dentistry. So I'm going to start with the strengths of periodontics. See, as dentists, we basically need teeth in the patient's mouth. If the patient loses all their teeth, all the patient needs is a denture. At our times, success of a dentist was gauged by the number of total extractions and complete dentures one did in the clinic. And I'm sure senior practitioners, if they are there in this presentation, they will definitely agree that we used to boast to our colleagues that I did 5 TE CD cases. TE means total extraction, remove everything, and CD is complete denture. But once you do a TE and a CD, this patient comes back only for adjustment of his CD. He will sit in your waiting room and crib that it's hurting here, it's hurting there, it's become loose, I cannot eat, sending a bad message to the other patients who are waiting there. Fortunately, now we have total extraction followed by dentures which are retained by implants, but these also patients will come back for problems. Basically, we need patients to do endo, crown and bridge, aesthetics, ortho. See, these are all the paying branches of dentistry. So if there are no teeth in the mouth, how can you do these treatments? So periodontal treatment basically is mandatory for all the patients to increase the lifespan of the teeth. Many decades ago, people would think that at the age of 60, one would lose all the teeth. Aging has nothing to do with losing teeth. If aging were to do with losing of teeth at 60, I would have lost all my teeth. In fact, people lost their teeth at 60 or had to get extraction because of untreated periodontal disease, which would proceed till it could not be treated at all. And at 60, people lost their teeth. My neighbor, was a doctor, unfortunately is not there anymore. On his 60th birthday, took an appointment with a dentist and got all his teeth removed. I felt very sad. Not only he did that, he did it with his wife also, 5 years down the line. So that is not the way it is. Teeth are designed and they're supposed to be in the mouth for a lifetime. And they can be there only if you do your perio treatment. What is the perio treatment? It is non-surgical, surgical, and maintenance. So moment you do these treatments, you're going to have teeth which are lasting there in the mouth for a lifetime. Now look at certain treatments that are contraindicated in a perio patient. You have a perio patient, and if the following treatments have to be done like ortho, prosto, endo, and aesthetics, the orthodontics is not going to do any treatment in a perio patient. So this whole line is gone. You go to a prosthodontist who's a real honest prosthodontist will not put a bridge in a patient whose abutments are mobile. You go to an aesthetic dentist to correct your spacing, maybe caused due to periodontal disease, and the aesthetic dentist is not going to do it because he knows that the spacing is caused by the periodontal disease. Even an endodontist does not treat a periodontally involved case because of the mobility. He's not sure whether the tooth will become firm or not. In fact, I have got so many of my cases of the previously called aggressive periodontitis, where you see basically flaring of teeth and no other signs of periodontitis like bleeding, swollen gums, from the orthodontist and an aesthetic dentist, because the GPs were confounded with these patients, young patients who came to them for ortho and aesthetic treatment. Now, if you cannot do ortho, prosto, aesthetic, endo, where you're going to get the butter to apply on your bread? Where you're going to get the jam to apply on your bread? Now, if you pay attention to the treatment that is indicated in a periodontal patient, now you have a perio patient, you have done his treatment. He needs orthodontics to correct pathologic migration. She needs prosthodontics to replace the extracted or missing teeth. She needs aesthetics to correct problems of spacing caused by periodontal disease. And in advanced perio cases, to save those teeth, you need to do endodontic treatment. So you have to have a knowledge of doing perio if you're going to do all these treatments. I'll show you some cases. The first is an ortho treatment for a perio patient. Now you look at this typical perio patient, you can see that it's very bad. The oral hygiene is very poor. The gingiva was swollen. You see pus discharge, you see swelling, you see bad discoloration. And if you say that this is due to a maintenance problem, the maintenance problem stems from the fact that these teeth are malaligned. So even if the patient wants to brush their teeth, it's not possible. The patient needs an ortho treatment to maintain, but looking at these teeth, it is difficult to do ortho. So then comes in a periodontist. Now look at the dramatic change that a periodontist has brought in. No swelling, no discoloration, no signs of any pus that are there, but still the malocclusion persists. 164. So now you're going to go in and do ortho treatment. So basically you have a perio patient who is now getting an ortho treatment done after the perio treatment so that everything can be maintained. Now we'll talk of a prosto treatment. This is a patient who came in with an advanced periodontal disease. You can see that the tooth is gone right up to the apex. No bone left here. Now you want to put in a tooth over here. No prosthodontist is going to do any treatment. But if you send it to a periodontist, especially well-meaning periodontist, you can do something like this. Now this looks so natural. So what have we done in this patient is we have done the routine periodontal work like scaling, polishing. We have done flap surgery. We have done ridge augmentation in this, and especially what we have done is we have used the natural tooth as a pontic, and we have splintered it from the palatal side, and post-operatively the patient goes out of the clinic with a wonderful appearance. Why I say wonderful? Because there is no dramatic change in the appearance of this patient other than the fact that this tooth has been back into position. This is a typical post-operative case after perio treatment where there is tremendous amount of spacing, there is tremendous amount of recession. This case might have been done around 30 years ago where we didn't have an access to a lot of aesthetic materials. The problems of the patient were not only were the long teeth spacing, but the angulation which was predisposing to a traumatic occlusion. So this patient underwent extensive endodontic treatment in the anterior region and followed it up by a fixed splint which took care of the mobility, which took care of the spacing, which took care of the sensitivity. And when I say that aesthetic materials were not available, it is this white appearance that is now very unaesthetic. And many times we are dictated by the demands of the patient who want an A1 or A2 shade only, A1 or B1, irrespective of what the other teeth are there. A case of a deep perio lesion in this tooth, which has caused mobility, where we need to do periografting. But when you do periografting, you have to ensure that there is no infection in the apical region, because the actual defect is right up to the apex. So here you need to do an endodontic treatment so that you can get wonderful results. So these are the things that you need to do when you treat a perio patient. So what does a perio treatment does? It restores functions, it emphasizes on regular follow-ups and creates patients for life. I have patients treated 30 years ago who come back for regular follow-ups so that I can maintain their oral hygiene. And I have found in 35 years that scaling is one of the most rewarding treatments. It is fast and effective if one knows really how to do it. It has maximum returns on least investment. Today I do a scaling, tomorrow bleeding has gone, the redness has gone, the halitosis is gone, and it has to be done repeatedly. So you have the same patient coming back for multiple number of times. I'm so happy when my follow-up patients call me either once or twice a year and say, "Doc, we have to come back for our scaling. There are no problems." So you do 300 cases and you can create 300 cases for your follow-ups. You have assured 300 cases, one coming every day for the whole year, just to do a half an hour, 45 minutes of scaling. And that's really good enough. So when you have patients like this, you do non-surgical treatment and you convert it into something like this, where there is absolutely no sign of any disease left. And this can be done in a matter of a day or two. Or you do what we all know is a conventional surgical technique where we see the deep pockets that are there here. We take incisions, we reflect the flap, we debride, and we suture it back. So basically, we have removed all the local irritants and created a maintainable state. When I say maintainable, that means the teeth are free of disease and everything is going to be well maintained, and it is up to us to motivate the patient and to ensure compliance and to do a good supportive periodontal treatment. Our greatest strength, my dear friends, is the tissues we deal with. The gingiva is one of the most forgiving tissues in the human body. And health can be restored in a matter of days. You do a scaling in a case of gingivitis, and down the line in 2 days, no one will believe that the tissue was inflamed a couple of days ago. The PDL or the periodontal ligament has such tremendous healing and regenerating potentials that we can recreate whatever has been lost. And ultimately, our base, that is the bone, can be manipulated by us if we learn how to our advantage. So the strength of perio is that it increases the lifespan of teeth, it restores the natural function, it forms a sound base for other dental treatments, and it is very rewarding for the doctor. Now we come on to weaknesses. Obviously, there have to be weaknesses. There cannot be only strengths. So what could be the weakness of perio? Our greatest weakness is the disease itself. Periodontitis, in most of the cases, is painless and slowly progressing. So the patients, and many times the dentist is also not aware that the gingivitis has progressed to periodontitis. And many times such patient comes in an advanced stage where not much can be done to help the patients. Moreover, patients in such advanced age and advanced disease do not mind losing their teeth. That's a drawback of our Indian population, where dentistry and teeth often don't have a prime place in the things to be done in life. The priorities of people are very much more different. But things are changing. We are definitely evolving and we are paying attention to our teeth. Secondly, periodontitis is associated with the social stigma of poor oral hygiene. You don't go around telling people, hey, look, I have periodontitis, or I have pyorrhea, or I have halitosis, or you just don't do it because people will immediately say that you're not maintaining your oral hygiene. Patients also don't recognize the effects of habits like smoking as well as poor hygiene maintenance. They still believe that you can use twigs or datuns and maintain your teeth or brush just occasionally. So that causes periodontal disease which they are not aware of. And lastly, patients are not aware of the complications of systemic conditions like pregnancy or diabetes. And nowadays, most of these systemic conditions have a bidirectional effect. So not only do diabetes and pregnancy cause a complication in periodontal disease, but periodontal disease also can complicate diabetes and periodontitis and pregnancy, sorry. So all the more reason for us to do periodontal MDS. So patients can blissfully live with such red gums, with losing teeth, having spaces in their mouth, having edentulous areas, having a mouth full of local irritants. Now in this particular slide that I have shown you, this patient came to me because he got this partial denture done, never took it out of the mouth. This tooth migrated and now this denture is not coming out. So they live like this and live till so much of deposit is collected, which itself is a problem for us because they're just not aware or they just don't want to get their perio treatment done. The next weakness is the treatment. Our treatment is not self-advertising. You have patients who do ortho who go about smiling all over the place saying that, look, we are getting ortho treatment done. They put up nice selfies on Facebook and Instagram. And the aesthetic treatments like the laminates, they are published all over the place. But I haven't yet to see someone put a post saying, see, look, I got a perio treatment done and from bleeding gums, I have nice new set of pink gums. So it's not a self-advertising treatment. Our treatment is also very stringent, especially the scaling and associated surgery and dental work. And then the periodontist will keep harping on maintenance, maintenance, and maintenance till the dentist and the patient gets bored. But if you don't do maintenance, you're going to have recurrence, which is another drawback for our perio. And lastly, the post-operative effects. The patient says, I've got sensitivity, I've got long teeth, I've got spacing. So all these are inherent weaknesses of our branch. So we have a gradual unobtrusive progressive disease, which is not, people are not aware. There is a stigma associated with the disease. There is a stringent treatment which has a low glam outcomes. So these are all internalized things. Now look at the opportunities. Now if I do an MDS perio, what opportunities will I have? I'm not only going to learn scaling and root planing and maintenance and routine periodontal flap surgeries. I'm going to learn something much more than that. You are going to learn something much more than that. And you are going to use all what you learn in these next 3 years for creating for yourself a wonderful practice where you're not only going to do your basic work, but you're going to do a lot of aesthetic work, a lot of restorative work. You're going to give patients what they have lost. Losing a periodontal tissue at 30, 40 years ago was like having lost forever. But now you're going to regenerate, regain, and restore everything that you have lost or the patient has lost. So you're going to learn about root coverage, where you're going to get a pink cover for the white teeth. You're going to create ridges which are augmented to receive a wonderful prosthesis, be it a fixed dental prosthesis or be it an implant or be whichever prosthesis you choose. You're going to learn crown lengthening procedures which could be aesthetic and functional and restore the tooth. You're going to learn about manipulation of hard tissue like guided tissue regeneration and guided bone regeneration and you're going to learn all this in the next 3 years, and you're going to be perfect and well trained and well honed when you enter into the big bad world of general dental practice. You're going to be armed with all these new techniques, and your repertoire is going to be full of these techniques which you have perfected under the guidance and mentorship of your wonderful departments. Now you look at this case where you see a root that has been exposed. This is right in the front, maxillary anterior, and the patient is not happy. No matter how many pictures you see on Facebook and how many courses you attend or webinars you attend nowadays, you are not going to be able to learn or perfect the Vista procedure, where you're going to take incisions, you're going to put grafts, you're going to bring the tissue ahead to cover the recession and ultimately get such wonderful results. If you see these results that are there, they are absolutely wonderful. At this stage, let me tell you, all the pictures that I'm showing are not necessarily the work done by me. Some are from my colleagues, some are from my students, and some are even from the internet and the textbooks. The idea of today's lecture is not to show you what I have done or what I can do, but to show you what people have done and what people can do. So Dr. Chatterjee said that for us 2 mm is also a big issue, and you can really understand that this 2 mm is a big issue for the patient itself, because it's right in the front and it's definitely going to cause a problem. You have this patient who's smiling very hesitantly because the teeth are absolutely in disarray. There is no disease in this patient. It is just that some teeth are in altered passive eruption, which means they have not erupted completely. And who better than a periodontist to restore this wonderful smile? You see the zeniths are now perfectly in order, the canines and the laterals and the centrals and the premolars, everything done. And you see a case of severe attrition which has to be elongated with the help of a laminate. So you can do in a nice crown lengthening and put in a nice laminate and get your 2 millimeters of additional tissue, which will create wonders in ours and everybody's life. You can regenerate tissue. When I say tissue regeneration, that means we regenerate bone, we regenerate periodontal ligament, we generate cementum, we regenerate gingival attachment. Now we do this by putting a membrane. No graft is put in this, just a membrane, which is going to prevent the tissues from the gingiva creeping in and allow the tissues from the wonderfully regenerating periodontal ligament to create bone. Now you can see that this re-entry procedure has been done to remove this membrane. It's obvious it has taken some time because this tooth has got a little worn off, and you can see actual bone has regenerated over here. So who else and where else to learn all this than when you do your post-graduation? You can learn your horizontal guided bone augmentation. You learn your vertical bone augmentation to put in the implants. And periodontology has now an implantology, which you will be learning in the next 3 years. So these are your opportunities in perio. You learn about lasers for routine and aesthetic perio. You learn to use piezoelectric kits for your hard tissue management. You learn periodontal microsurgery for the use of surgical microscopes, and you learn implants, single, multiple, everything. And I'm very grateful for the Dental Council of India for making all these mandatory to be taught in post-graduation. It is mandatory for all the departments to have these kits. It is mandatory for you to learn ample amount of cases so that you do not experiment on your patients who are not as forgiving in private practice, like I told you once before. So you will learn a procedure called as depigmentation or gingival bleach, which is done by lasers. You will learn a partially invasive treatment like a frenectomy, and this is done immediate post-operative, not a drop of blood. And you can go on to learn invasive procedures like lip repositioning, again a purely aesthetic procedure and clearly bloodless, absolutely. So though you have joined this branch to see blood, if you can do without blood, you are a marvelous genius surgeon. You're going to do piezoelectric surgery for your ridge augmentation, for your sinus lift procedures, and for your block grafts. And these are absolutely atraumatic procedures without causing any injury to the bone. You're going to learn periodontal microsurgery. Now, this is a case where the root is exposed and we are using a free gingival graft. The problem is if you put the graft on the tooth, it will not survive. So we put the graft at the base, allow it to integrate and use a periodontal microsurgery to lift it and to put in this multiple sutures 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, about 20, 25 sutures in a small area to get such wonderful results. The entire root is covered and the entire tissue is wonderfully integrated. Where can you learn it? But in your department to do periodontal microsurgery. Latest in implant surgery is a guided implant surgery where like your angioplasty, the surgeon is actually looking into the computer screen and doing an guided surgery where he's designed where to put the implant and exactly knows whether he's going in correctly or not in 3 dimensions. And you're going to learn all this and you're going to become excellent periodontists and excellent implantologists. So our opportunities are the aesthetic and functional treatments, advanced treatments like laser, piezo, implant and surgery. But what are our threats? Our major threats are the general dental practitioners who have a low awareness for motivation for perio treatment because they see patients day in and day out. As periodontists, you don't see the number of patients as general dental practitioners, and you can spot a periodontal disease in its initial stages where the GPs cannot do it. So unfortunately, the time is still there where we have to motivate and educate the GPs, and the ISP on its part has come up with guidelines for periodontal care for general dental practitioners where we're trying to tell them how to spot a periodontal disease. And we're trying to educate them about the wonderful results we can achieve. Another threat is the alternative treatment to perio treatment, where the patient or the dentist goes in for partial or sometimes even total extraction followed by implants. So unfortunately, part of our own branch, that is implantology, has become a threat to us where GPs or even perio people will want to just remove the teeth and try to conserve 50% of bone and put in implants. But fortunately for us, who better than a periodontist to manage a peri-implant complication? I attended yesterday's wonderful seminar on regenerative periodontology by Dr. Alex, and I picked up a small slide from his presentation. And I'm going to show you. First, let me show you what happens when there is a lack of awareness. So patient exists with such sort of an occlusion, such sort of a teeth. And believe me, this patient is not an old patient, 60-year-old. This is a 12-year-old boy, 12 to 14-year-old boy who has had aggressive periodontitis and is just surviving. And you have a patient who is pregnant, who has a gingival enlargement and has continued to live so much so where you can see the indentations of the opposing teeth here. So there is so much of lack of awareness. And then there is dental metallurgy, like Dr. Alex said yesterday, where you have a patient who has quite a number of teeth and quite a number of savable teeth and has gone in for so many implants. So he said that give your students only implant skills and they will find that every patient they encounter needs several implants. Or if all you know and think is implant, everything you look at a tooth will be a tooth to extract or a site with a missing implant. So if you say a missing tooth, patient, this sort of a dentist will say, oh, he's missing an implant in this. So our greatest threat is the low motivation and alternate solutions for implants. So now periodontics is basically integral to total dental treatment, where it forms the basis for long lasting and effective dental care. And it is a must for all dentists, especially those who want to have long and successful careers. And my friends, we shall definitely overcome all the weaknesses and threats that I have shown you. And one day, everyone will be aware of a wonderful branch that we have. And it will become the first choice for MDS. The true measure of success is a healthy functioning dentition over multiple number of years. So the success actually is measured in the number of years that the patient has his or her own teeth. And the focus is on overall health rather than heroic attempts to save few teeth. And this is only possible by periodontal treatment. I have no regrets about doing my masters in perio. And believe me, neither will you. And you will definitely go ahead and proudly wear the label of MDS periodontics, not only on your sleeve, but everywhere you go. You will propagate our wonderful branch, and many years or a few years down the line, it will be one of you who will be teaching and telling other people about the wonderful branch we have. I spent a lot of time trying to tell you about perio, but if you look at this small ad that I saw again on Facebook, this person has summed up very succinctly that it is an extremely lucrative branch for clinical dwellers with scope in academics and including laser, implant and newer techniques of perio endo and a lot to learn about aesthetics. So it's just a few lines to sum it up that perio indeed is one of the best branches. The only thing is people are not aware. And people definitely will be aware. And I take this opportunity to thank you and tell you that definitely अपना time आएगा और definitely आएगा, जल्दी आएगा और आप सब लोग लेके आएंगे और everything will be definitely wonderful. Thank you so much, ISP, Head Office, ISP Study Group of Rohilkhand and Chandigarh for giving me this opportunity. And special thanks to all those 500 plus delegates who have listened to me. Thank you once again. Over to you, sir, Dr. Chatterjee.
Sir, Dr. Dani, it was such an excellent presentation.
Thank you so much.
And it was a learning for me too, after 23 years of experience post-MDS, like you, a senior dentist, a periodontist, giving us the idea. It's a wonderful thing for the new periodontist. As I also told, you have also mentioned, somebody must have come without wanting to come. But they will be definitely, because that was the only, might be the seat available, perio, and might be the only somebody wanted to do surgical course. So, but the so well versed. You have given
Thank you
such
so
a
much.
now everyone is going to have a full mind. Everybody would be accustomed that all our perio PGs are all the seats in all over India is filled.
Thank you so
After
much.
this talk, it was wonderful.
Thank you.
And a small thing for all the PGs, I can see a there was lot of presentations, sir. Excellent, and I think everybody has said a wonderful presentation. So one of them has told by Shefali, this was a wonderful and very informative presentation by she's a first year. Obviously, all are first year only now. But there is one question I was just going through.
Go ahead.
Is if you can take that, is can a BDS person?
Yes.
But I find it very little odd. Can a BDS person do all the periodontal treatment? It was a question from one of the participants. I don't know whether that guy is a guy or a girl. I forgot I can't see the name. Yeah. Yes, sir.
This question has been raised many times, especially when it comes to orthodontics also. Because if you look at the council regulations, the dental council regulations, there is nothing that will stop you from doing any treatment. But if as a BDS I try to do a root coverage and I'm not able to do it properly, I don't think any other patient is going to come to me to get it done.
Exactly.
On the contrary, if as an MDS I do a wonderful root coverage, I'm going to get many more people who are going to come. So there is nothing that will stop an BDS from doing a root canal or an ortho treatment or an implant or a perio surgery. It's only how well you do it that you will have more number of opportunities to do it. That is my take. There is nothing. If you are working with a dentist or a periodontist for multiple number of years, I'm sure you can develop skills and you can do that. But you have to learn in an environment which is not conducive to learning. That is practice. If you learn in an environment which is conducive to learning, like a MDS department, I'm definitely sure that your skills will get much more mature by the time you are endeavoring to do it in your paying patients.
Yes. Thank you very much, sir.
Thank you.
There is somebody from Ching Nuncium who has told that I have been working for government service for 10 years and I've joined MDS Perio this year. And you have made me help that I have taken the right choice.
Thank you so much, sir. That is the feather in my cap. If I hear people who are practicing for 10 years and they have taken up perio and now they are certainly happy about it, there is no further appreciation than this that can be achieved.
True. Then somebody has told it. So it was a blooming experience. I don't see any more questions.
Thank you so much.
Because there's everybody has you have enlightened about the research and
Sir, I have not actually mentioned much about research because you have actually in your presentation or introduction also said that maximum research in the world.
Yes, it is done. Correct. No, what I mean to say is they have told that research in the sense they will be knowing what exactly they need to do.
Okay.
There was some. Then it is one more person, Anil Kumar, has told scope in WHO projects also can be done, sir. I think
definitely, sir. There people are free to add to the scope because what I have put in is from whatever little experience I have gained. I have done research not directly and not as a dedicated researcher, but through my students. So when you do a research for a student, that is a small research and not an ongoing project that you can take away for many years. But definitely, if you do your MDS in perio, you are going to do research because as our editor, Dr. Ashish Kumar, always says that if you look at our textbooks, the initial pages keep increasing because more and more research on the etiopathogenesis is taking place. And there are paradigm shifts that have happened over the number of years from when me or you learned MDS and what today they are going to learn. So I think research has tremendous potential for MDS perio.
And somebody has done, what is the prospect of scope of perio after it in foreign countries?
So all this is not in the scope of my
lecture.
I think somebody else will be speaking
yeah,
about
because then definitely there will be people who can give you a guideline or guidance to where you can go. Again, abroad, it all depends on whether your degree is recognized or not. But nobody can take away the skill that you have learned in the 3 years.
True, sir.
Nobody can take away the knowledge that you have learned in the 3 years and the confidence that you have gained in your own self. Nobody can take it away for you ever in your life.
True. I also agree with that because each foreign country has their own systems, and where some foreign countries allow our Indian MDS degree after 4 years you are allowed to work there. Some UAE countries, some UK, US, you have to give exam and you have to pass DDS.
Yes, sir.
All those things are there.
And this keep changing from time to time.
Yes,
so I
sir.
think
Yes,
there are
yes.
special people who take these course lectures on what after BDS, what after MDS. So those people will be more. I mean, it has nothing to do with the specialty as such. It is to do with the general post graduation.
True.
Okay,
so
thank you
I
so
think
much, sir.
it was a very, very, very affirmative and very nicely put up topic, sir, Nitin Dani, sir. So I thank our ISP for giving me an opportunity to have a say in this talk by Dr. Nitin Dani, and thank you very much. I think here we end the today's first of the lecture, and I think Dr. Shiv Manjunath or Baljit will take over for the second lecture. Thank you, sir.
Thank
you
you
very
so
much.
Sir. Thank you.
Thank you.
A very good afternoon to all of you. We are heading for the next lecture. The topic for the next lecture is Talent Win Games, but Teamwork Wins Championship. Journey ahead in periodontics. This wonderful topic, it's a very favorite topic to me also. If you all remember, the best tournaments, the best championship is won with the teamwork. And this is the best can be spoken by none other than Dr. Subhash Chandra Raj. He's an associate professor. He's working in SCB Dental College, Cuttack. He's one of the best clinician and academician. And the good, what I'm going to say is we did our post-graduation together in Government Dental College, Bangalore. He has been doing excellent work in IDA and ISP. He has been, occupying the prestigious, secretary post and the state presidents in Odisha IDA branches. And he's been extremely active in ISP. And he's going to be the organizing chairman for the next ISP National Conference. And for this particular topic, we don't have to wait too long. Listen from the master himself. Talent win games, but teamwork wins.
It's Dr. Nitin Dani's screen.
Okay. Praveen, can you allow him to have a screen share? This message, Praveen, no? I think Dr. Subhash, you can. Dani?
Now, is it visible? Manju, now is it visible? Hello.
Subhash,
yes, sir, it is visible. Dr. Subhash, it is visible. You can proceed.
Okay. Yeah. So thank you, Manju, for the nice introduction. And as you told, if I remember, we both started our journey in periodontics in the year 2000 in GDC Bangalore. Because I was from Odisha and I joined through All India and you joined through state. So being from Odisha, I was struggling to have food in the hostel because it's almost the South Indian food. So hardly, I think maybe in Wednesday, Friday and Sunday, we used to take a lunch at dinner in the mess. Otherwise, always I push you let's go outside and have food. But at the end of the month, when you look at the mess bill, the number one was Dr. Subhas Raj and number two was Manjunath. So that's what we shared the bond, and we are almost 20 years here after starting our journey in periodontics. So I'd like to thank the Rohilkhand Study Group and Chandigarh Study Group for organizing this MDS Students Orientation Program on behalf of Indian Society of Periodontology. So as Nitin Dani sir concluded with, definitely we will enjoy perio in these 3 years. But if you know Henry Ford, who is the founder of Ford Motors, he told, coming together is a beginning, staying together is a progress, and working together is success. So on behalf of Indian Society of Periodontology, I welcome all the first year postgraduate students to the Perio family of India, that is Indian Society of Periodontology. Now, you were the student as an undergraduate student, and now you are beginning your career as a postgraduate student. So there is a big difference in undergraduate student and a postgraduate student. So according to me, the student, A stands for study. So as you all are here to study, and the T stands for truthfulness. So always a student should be truthful to his teacher, to his friends. And U stands for unity. So you should be united with your co-PGs, your senior PGs, your teacher, your guide, your department, and when it comes to college also, you should be united. And the D stands for discipline. So every teacher likes the student who is disciplined. And E stands for energy, that is patience. I mean, always patience gives you the progress. And you all know success never comes overnight. So if you want to be successful, you have to choose the right path and you have to wait for the right time. And N stands for neat and clean. So it doesn't mean that neat and clean outside. You should be neat and clean inside. That is, your mind and heart should be clean. And the T stands for treasure. That is the value. You should value yourself. You should value your patient. And most importantly, I always say, a student is a student who value the moral of a teacher. So that is what a student means to me. And if I give an example, I think you all like pizza. But would you like a pizza without the topping that is the only base? I don't think anybody will like the pizza base only. So what you are expected for the academic qualification, that is MDS in periodontics, is only the base of the pizza. So this MDS degree, if you feel, it is not taken. It is given by your guide or by your examiner. So what you have to do is, you should have a topping in these 3 years. What are these toppings? These toppings are the skills. What skills you are going to get in these 3 years. So when you are preparing for the journey, I'll tell you, according to me, these are the 10 skills that you should acquire in these 3 years. The number one is detail orientation. That means now you all will start your OPD. So when you start taking the case history, the detail orientation means the minute details of the case history. And most important is, you should be a good listener, because many times I see, just you ask for the chief complaint of the patient, even the patient's complaint is not over, your instruments are already inside the mouth. So that is not, you have to spend some time with the patient. And number two is the communication skill. Now, many of you must have joined through All India. So you are from a different state and you will be doing your MDS in a different state. So you have to learn the language to build your communication skill. So if I remember my initial period of post-graduation at GDC Bangalore, I think within 2-3 months, I was able to speak Kannada. And even I sang Kannada in the annual day. So that should be your spirit to know the language, to have a proper communication skill. And the third is the steady hands. In dentistry, there are two surgical branches. One is the periodontics, and another is the oral surgery. Now, as I know, periodontists are conservative, whereas the oral surgeons are destructive. Their approach is always just cut. So steady hands means you should have a self-control and you should be calm. And fourth is interpersonal skill, that is building and maintaining relationship. That is what mostly my presentation will be today. And 5 is leadership quality. This leadership doesn't mean that you will be Narendra Modi or Amit Shah, but you should have the confidence on yourself. You should be able to inspire others, and you should be honest, and you should have integrity. That is what the leadership means. And the 6 is problem solving. That means if your average OPD is 40, at least you will have 15 chronic periodontitis and 15 aggressive periodontitis if you think. But all these patients' problem will not be same. Their chief complaint may be different. So while seeing the chronic periodontitis or aggressive periodontitis, just you don't jump into that this is my full mouth case. Just look for the patient's chief complaint and treat that fast and solve the problem of the patient fast. Then obviously that patient will be for you for the full mouth flap. Then 7 is the love of learning. Now, there is no limitation in learning. If I say about the teachers, we should not feel that we are the professor and head, so we know everything, we should not learn. So everybody should have love of learning, and you as a student should have that also. If you don't have love of learning, only you have here to get the degree, then you cannot learn anything. And the 8th is the diligence in research. Now you are a postgraduate student. You have to do your main dissertation. You have to do your library dissertation. You have to do your search studies for presenting in convention or conference. So you should be focused towards the research. But for me, research, I don't in favor of basic research. Here I mean the clinical research. The 9th is the professional behavior and integrity. So this is very important. Whether you are in the department or you pass, you are a periodontist, what is going to matter is your professional behavior and integrity. And the last important is the patience and judgment skill. So here the judgment skill means you should have the holistic assessment of the patient, number 1. And number 2, you should have critical thinking. That means you should analyze the case. And the third is the clinical reasoning. There should be the answers should be based on the clinical reasoning. Okay, so these 10 things are the skills that you should set in these 3 years. Now, let me see with one of our postgraduate students who joined in 2017 and passed in 2020. Let's go one of his OPD cases. Now, this patient came to the OPD with a right submandibular swelling. Now, this patient has visited n number of dental colleges, n number of corporate hospitals, and this patient has n number of prescriptions with him when he came to our OPD. And this patient was referred from the Department of Oral Surgery with the diagnosis of eosinophilic granuloma and biopsy report with him also, where the biopsy report doesn't say that there is evidence of eosinophilic granuloma. Now, this is how the intraoral picture looks. There is generalized diffuse gingival enlargement. there is ulceration in the floor of the mouth, and there are multiple floating posterior teeth. These are the reports he had, and almost all reports had neutropenia and lymphocytosis. And the absolute neutrophil count was 420. So usually it should be between 2000 to 6000. Similar reports, neutropenia, lymphocytosis, even immunoglobulin A was increased, which shows infection. And this is the OPG and CBCT. You can see the floating molars, lower, upper, everywhere floating molars. And even we did an ultrasound of the mandible, which shows bilateral cervical lymphadenopathy. And we contacted the Department of Hematology. According to their advice, we did bone marrow aspiration also, which shows adequate particulate cell density, suppression of erythropoiesis and megakaryopoiesis, then maturation arrest at metamyelocytic stage, and lymphopoiesis was accelerated. So this is the bone marrow aspiration report. Now, if we review this case, there is history of recurrent infection, low-grade fever, boils and furunculs since the age of 4 years. And the patient experienced increased mobility, gingival bleeding, and enlargement since the age of 10. But there are no other systemic disease, no other associated skin lesion, there is no history of drugs also. So there is no chance of any syndrome, there is no chance of drug-associated neutropenia. Then we advised OPG, CPCT, and also differential leukocyte count twice every week for 3 weeks, just to exclude the cyclic neutropenia and the bone marrow aspiration. So finally, our diagnosis was chronic idiopathic neutropenia because we excluded all the syndromes, we excluded drugs, we excluded the cyclic neutropenia. So the chronic idiopathic neutropenia, which is very rare, 1 to 2 cases per million. And as per the advice of the Department of Hematology, we started the treatment, that is 150 microgram of subcutaneous injection of recombinant granulocyte colony stimulating factor once daily for 8 days, and all other symptomatic treatment like antibiotic, mouthwash, etc. And we follow up the patient. We advised him to visit our OPD 3 to 4 weeks for the first year. So that is how it was in the first visit and how it looks after 2 years of treatment. And we are able to publish it in Journal of Indian Society of Periodontology in March, April 2020. So if I see the journey of a student with this one patient only, I am at least 95% satisfied that this student has got the skills that you supposed to get. Now let's see this. If you go to the Periodontology 2000 volume 80, there is a chapter oral lichen planus. And if you go to the treatment, here it is written, there is although a permanent cure is not available. That means they say that there is no permanent cure of lichen planus. And these are the drugs that are being there, topical or systemic steroids, then homeopathic, immunosuppressive, calcineurons. But there is somewhere very minutely written hydroxychloroquine sulfate. Now question is, whether do you agree that there is no permanent treatment for oral lichen planus? If you ask me, I'll say, as per my evidence base, I will not agree to this. Maybe in USA condition, but I'll not agree to this in Indian condition. Because since 2010, we are treating oral lichen planus with one drug, and we have evidence base that we have at least 90 to 95% cure of the treatment. But when I started treating this in 2010, I was not aware of documenting it. So I don't have the pre-photographs, so I was not able to. But I'm following this patient since 10 years, and in the department, we have started treating oral lichen planus from 2014. So actually, this Dr. Anurupa and Poonam, they are the senior lecturer in the department. They motivated, sir, if since 2014 we are doing this, why not start a clinical trial on this? So that motivated us to start this, that HCQS, a new treatment option for oral lichen planus, a 6-month clinical trial. And the owners of this trial was the two of our PGs, that is Dr. Debjani and Dr. Saida. So because this is under review in a journal, so I'm not able to see all these things, but at least I'll show 2 cases. So this is one case. As you all know, oral lichen planus is mostly bilateral, and the most common site is the buccal mucosa, followed by tongue, and then gingiva and all. So let's see this. This is the right side, and this is the left side. Again, this is the right, and this is the left. And histologically, there are many types of oral lichen planus, but mostly the features are reticulation, erythema, and ulceration. Now see this. This is the picture at the baseline, and this is the picture after 6 months. You cannot deny that there is no improvement. Now see the left side. It is almost healthy after 6 months. Same to these patients also. So when we have evidence-based approach for this, I think there is a permanent cure for oral lichen planus. Let's see another case of a student, Dr. Asit and Dr. Lakshmikant. This patient again referred from Department of Oral Surgery with diagnosis of provisional diagnosis of lichen planus, desquamatic gingivitis, plasma cell gingivitis, and this patient has erythematous rough surface lesion in the upper, left and right 6-7 region, and there are also some heart growth in the lower lingual aspect, in the anterior region as well as at the posterior region. So this is the intraoral picture, how it looks. Now this patient had some gynec problem also. So she visited the Department of Gynecology, which all this report. She had iron deficiency anemia. She had some disturbance in menstrual cycle. So they advised prolactin level is very high, 77.93, which shows there is hormonal imbalance. This is the OPG. And we did an incisional biopsy. And now you see. So in incisional biopsy, the oral pathology department, they find out the histiocytes. So they went for immunohistochemistry, which shows CD1A strong positive and Langerin also strong positive. So they diagnosed this as the Langerhans cell histocytosis. See, Langerhans cell histocytosis is rare cases, that is 2 to 3 cases per million. And if you previously it was known as histiocytosis X. There are 3 varieties of Langerhans cell histocytosis. That is acute disseminated variety that you call is that Letterer-Sieu disease, and the chronic disseminated form that you call it as Hand-Scholar disease, and the most localized form is the eosinophilic granuloma. So to exclude the systemic involvement, they advised us the ultrasound of abdomen, X-ray chest, X-ray skull, OPG, and liver function test. So we did all this, This liver function tests were normal. Then the chest X-ray, there is no radio opacity. That means there is no systemic involvement. And skull also same, there is no radio opacity. So we followed with the steroid treatment. We followed it till the January, February, but because of the COVID, we are not able to follow this patient. But these are the cases. If you see it properly, then you can get the diagnosis for these rare cases. So that is what I said about the student. Then what is a teacher? The T stands for talented, and E stands for educated, and A stands for attitude, C stands for character, A stands for harmony, E stands for efficient, and R stands for reliable. So as I know, all teachers are talented, educated, and efficient. But if a teacher is of good attitude, character, and is reliable, and maintains the harmony or balance or peace in the workplace, then they make the best team. So when a teacher sees this type of student and when a student sees this type of teacher, then they think there is a possibility of progress and it provides positive energy. So I think you all know him. He is world's famous basketball player, Michael Jordan. So this is what he said: talent wins games, but teamwork wins championships. Now this is what we discussed in the department. And this journey in periodontics is not only the department of periodontics. So you have to do lot of things beyond the department of periodontics. So that is what I told the number 4 point, that is the interpersonal skill and building and maintaining relationship with the other departments. So that is what I say, periodontal office as a hub for interdisciplinary approach. So you have to build and maintain the relationship with the physician, the endodontist, the orthodontist, the oral pathologist, prosthodontist, general dentist, any other branch of the dentistry. Now you all, once you enter into the department, you will have your case record definitely. So this is what our case record is. And if you go to the treatment aspect, the first one is emergency treatment. After that is phase 1. So phase 1 includes scaling and root planning. You have to do oral hygiene practice modification, and you have to think of systemic antibiotics, whether it is needed or not. You have to think of local drug delivery, whether it is required in this patient or not. You have to think of host modulation therapy, whether it is required or not, and also diet counseling. And most importantly, at this stage or at the first visit of the patient, you have to find out whether this patient requires interdisciplinary approach or not. So that is the most important point if you want to go and if you want to have a better journey in periodontics to the other departments. So these all will depend on the interpersonal skills, how you build and maintain relationship with other departments, with other postgraduates, with other faculties. Let's start with the branch that you all say it is a non-clinical branch. I mean, the two non-clinical branches we have is the oral pathology and the public health dentistry. So that's why I always acknowledge those people who helps us in this interdisciplinary approach. So he is our head of the department of oral pathology, Dr. S.N. Das. So that was the selfie taken by him when we were at the inaugural function of the World Cup hockey last year. So let's see this case. This was referred from Department of Oral Medicine with a hard sessile swelling in the lower anterior region, that is between the canine and premolar. This is how it looks. You can see there is bicortical expansion. In IOPA view, it clearly shows there is multilocular radiolucency. This is the occlusal view. This is the OPG. And this is the CBCT. And as per the clinical picture and the radiographic picture, which shows multilocular radiolucency with honeycomb or subbubble appearance, definitely we'll think of amyloblastoma. So we thought of amyloblastoma, and the differential diagnosis were central ossifying fibroma and central giant cell granuloma. So we did the incisional biopsy. Then we sent it for histopathologic study to the Department of Oral Pathology. Now see, they gave us the diagnosis of desmoplastic amyloblastoma. As you know, there are very common histological varieties of amyloblastoma. If you think of the varieties of amyloblastoma, clinically there are three varieties: unicystic, multicystic, and extraosseous. And radiographically, unilocular or multilocular. But very uncommon variety of amyloblastoma is the desmoplastic amyloblastoma, which occurs mostly 4 to 10% of all amyloblastoma. So this diagnosis can only be given by the histopathologist or the oral pathologist. So that's why the interdisciplinary approach, even to the non-clinical, is very important. Let's see another case. Now there is a fibrous swelling in the canine and premolar region. And in CBCT, you can assess the interdental bone loss. Then we plan to do the excisional biopsy with the provisional diagnosis of peripheral ossifying fibroma, peripheral giant cell granuloma, peripheral odontogenic fibroma. But see, pathologist, it is peripheral amyloblastoma, which is very unique, almost 1 to 5% cases of amyloblastoma. Because as I told, in amyloblastoma, there are three clinical varieties: unilocular, unicystic, multicystic, and extraosseous, that is the peripheral amyloblastoma. So this can only be given by the oral pathology department. So we are able to, this is how it looks before and after, and we were able to publish it in the journal. Next we'll go to the oral surgery department. I don't know, maybe I'm lacking this interpersonal skill development with the oral surgery department. I'll show two cases that one, when we work with this young fellow who has joined our college 4 or 5 months back, but otherwise the initial case that is done by great surgeons, we'll just compare. Now this patient came to our department very stressed with the chief complaint of bleeding from lingual aspect of 3/6. Now, when we took the history, even this patient had visited many places in Odisha, even the All India Institute of Medical Sciences, Bhubaneswar, with these findings: severe bleeding, edematous gum, bleeding point between 3/6, 3/7, and IPA X-ray shows alveolar bone loss, furcation involvement. But see the advice: not to chew hard food and hematology consultation. There is no referral to the Department of Periodontics when the IOP X-ray shows alveolar bone loss and furcation involvement. But anyhow, this patient reached our department and she had a lot of investigation report which are of not significance. And the OPG and IOPA just shows that alveolar bone loss and furcation involvement. Now we started probing that area. So the probing depth was around 8 mm. And you cannot believe there are huge amount of bleeding, which took us around 10 to 15 minutes to stop the bleeding. And we stopped examining the patient. Just we managed to stop the bleeding after 10 to 15 minutes. Then we advised some other hematological investigation, and we asked the patient to again come tomorrow. And now you see, when the patient comes tomorrow, you just look at this. Now you can clearly see there is visible pulsation at the lingual papilla. So when there is a visible pulsation there, definitely it's a vascular lesion. So either it is a hemangioma or it can be AV malformation. Now then we contacted the Department of Oral Surgery. I spoke to the concerned oral surgeon that this is of academic interest, and our PGs took this case to them also. But almost 15-20 days over, we are not getting any information from the Department of Oral Surgery. Then I call back to the concerning oral surgeon. Then he says the surgery has been done. Then I told, okay, you send me the photographs. Then he sent me these photographs. So the partial resection of the mandible is being done with this CT scan, where that CT scan doesn't show where is the AB malformation or where is the hemorrhagic lesion. So if you want to diagnose a hemorrhagic lesion, I mean a AV malformation, at least you have to do MRI or you have to do surgery. But it is not being done. It is not being diagnosed. Just assessing that it is AV malformation, the partial resection of the mandible is being done and it is being sent for the histopathology, which confirms that this is AV malformation of mandible. But anyhow, we are able to process, but not satisfied with this because the diagnosis is not right and the treatment modality is also not right. Because for AV malformation, the treatment modality is your arteriovenous embolization. You can do embolization or even you can use sclerosing therapy for also. Why to do partial resection? That puts the question mark. But see this case, this we are doing with this young oral surgeon. So this patient known to me, he is the driver of my brother. He had a ulcerative, non-healing ulcerative lesion in the lateral border of the tongue. So we did incisional biopsy and which confirmed it is a well-differentiated squamous cell carcinoma. So I contacted this oral surgeon. He advised that we'll do the MRI of neck to find out the metastasis or the lymph node involvement. But the MRI showed there is no significant cervical lymphadenopathy. So if there is a squamous cell carcinoma of tongue, always the treatment method is along with the excision of the lesion, you should go for neck dissection. But in this case, because there was no significant cervical lymphadenopathy and the patient was known to us, we thought let's do the excision fast and we'll observe this patient, and if we feel, we'll do the neck dissection. So we did that, we excised the lesion, but you see, after 1 month, the patient calls that I have a swelling in this area. So then I told, you come back. So he comes back and we did the FNSC of the lesion. Then it clearly shows there is metastatic squamous cell carcinoma. So because the squamous cell carcinoma of tongue is very aggressive. So we did the neck dissection, the oral surgeon did. So these are the lymph nodes 1A, 1B, 2A, 2B, 3A, and 4A. Then we sent it for the histopathologic study. You see there is a well-differentiated squamous cell carcinoma. 1A, 1B are free, 2A, 2B are positive, and 3, 4, 5 are also positive. So this diagnose it as skip metastasis with stage 4. So because the carcinoma of tongue, the most commonest size for skip metastasis. So we contacted the cancer department, and as per their advice, we did the CT of thorax. There are few calcified nodules in the upper lobe of the lungs, but the size was 3 to 4 mm. So as the size was 3 to 4 mm, usually if it is metastasis, mostly what they say it should be 10 mm. So maybe it was not metastasis to the lungs. So as per the advice of the Department of Cancer or the Cancer Institute, it is planned for radiotherapy and chemotherapy. So if you compare these two cases, at least because of this interpersonal skill, we are able to follow this patient, we are able to diagnose this patient, and the treatment planning is proper. But that was not happened in the earlier case. Now then we will come to the orthoperio. So orthoperio, always I tell it is a synergy. What the synergy says is if 2-3 people act together, the effect is more than the individual. So along with me, these are two of my orthodontists, very good friends of mine, with whom we all do our orthoperio interdisciplinary approaches. So this is the orthoperio symposium, what we did for the 54th Indian Orthodontic Conference last year at Bhubaneswar. Now, always there is a bidirectional. Periodontal treatment helps orthodontics and orthodontic treatment helps periodontal outcome. Now, this is one of the best case till today we have done with orthoperio interdisciplinary approach. Now you look at this 1-1, 1-2, and 2-1. If you see at this X-ray, definitely you will say it is to be extracted. It is hopeless. Now there are palatal recession and there is extrusion. This is how the lateral cephalogram shows. See the flaring. Now, with discussion, the ortho people told we'll take the risk. We'll intrude this 2 incisors. So they used tag for intrusion. Now you see, after intrusion, how it looks. If you compare the flaring, how beautiful it looks. Now, see the IOPA X-ray of that region. Now this complete horizontal defect that was almost at the 1/3 of the apex has been converted to the angular defect. Though you can find a bit of root resorption because that is always there when you intrude the tooth. But when a periodontist see this case compared to this, it is tempting that you will do the regenerative procedure in this case. As because there is root resorption, we did endodontic treatment for this also, followed by the perio treatment. And now see, 2 years after orthoperio synergistic approach, you see the lesion. So that is what, if you combine perio and ortho, anything can happen. But the orthodontic treatment, the risk factor of orthodontic treatment is the gingival recession. and they may change the gingival biotype, and they may change the transverse dimension also. Now, the gingival orthodontic treatment is now considered as the risk factor for gingival recession. That is what even their journal, American Journal of Orthodontic and Dentofacial Orthopedics says. Prevalence of gingival recession steadily increases after orthodontic treatment. And after orthodontic treatment with fixed appliance, the incidence increases 7% at the end of treatment to 20% at 2 years of treatment and 38% 5 years after treatment. And even this also says gingival recession is not uncommon in young adults and is related to past orthodontic treatment. So as per the orthodontic literature also, orthodontic treatment is the risk factor for gingival recession. Now let's see this case. Now this case is a generalized aggressive periodontitis, treated somewhere else, came to our department with the chief complaint of this, the black triangle disease. And if you look at the IOP X-ray, you can see there is almost half of the bone is remaining. And if you measure the distance from the contact point to the level of the crest of the bone, it is more than 7-8 mm. Now, if you think of the Tanner's law, so the distance from the contact point to the tip of the papilla should be 5 mm or less to completely feel it. And if there is increase of 1 mm, then there is the chance of 50% reduction of the papilla. So keeping this in mind, I don't think any periodontist can think that I can treat this black hole triangle disease. So with the discussion of ortho, we started treating this. So this is what the classification of loss of papilla by Norland and Tarnow. So this will come in class 1 and these two will come in class 2. So this is the lateral cephalogram. Now, because our ortho people, they do a lot of linguals, so they did lingual for this patient. This is during treatment, all the lingual orthodontics. Now you see. So this is how it was, and this is how it looks after ortho treatment. The contact point is created. There is regeneration of antedontal papilla. And if you compare the periodontal biotype, it is also improved. Periodontal biotype as well as the periodontal bioform is being improved. But see, compare the canine. The recession, here the recession, there is increase in gingival recession. So which justifies that orthodontic treatment is the risk factor for gingival recession. So then the perio people comes for the treatment of gingival recession. Now let's see this case. I think it's around 2014 or 15. Just we were sitting and discussing. Ortho people told that canine retraction is very difficult. We are finding difficult in treating canine retraction. Then I told, let's try this canine retraction with wilcodontics or corticotomies. So by going through the literature, we thought we'll go to the minimal invasive procedure, that is the piezo-scission. So we gave dissertation to one of our PG and one of our ortho PG. So we started this piezo-scission assisted orthodontics. So that is what the piezo-scission says. You have to give micro incisions, that is 5 mm from the tip of the papilla, and this incision should be 8 to 10 mm towards the vestibule, and the depth should be 3 mm. The corticotomy cut should be 3 mm depth, and it is with the piezoelectric knife. And then we collected the autogenous bone from the ramus of the mandible, and we placed, here we lifted the by tunneling, and we placed the autogenous bone graft. Why we prefer to place autogenous bone graft is that because corticotomy works on the principle of regional acceleratory phenomena. When there is regional acceleratory phenomena, there is a chance of dehiscence of the root. So to prevent that, we used bone graft here. Now you see, this is the final space closure, and this has been occurred in 3 months. When ortho people say it takes around 6 to 8 months for the canine retraction space closure, it took only 3 months. So this we were able to publish in International Journal of Periodontics and Restorative Dentistry with the title of Evaluation and Comparison of Periodontal Status and Rate of Canine Retraction with and without piezo-scission facilitated orthodontics, a randomized controlled trial. Now, there are many questions asked when orthoperio interdisciplinary approach comes. Now, when to perform frenectomy, before or after midline diastema closure? Now, as per I am convinced, the frenectomy should be done in all cases just before you are placing the retainer and the completion of the ortho treatment, except when there is a papilla penetrating type of attachment which prevents the migration of the tooth. Otherwise, the frenectomy should be done at the end of the treatment before retainer placement. Now, next is whether malocclusion is a risk factor for periodontal problems. Now, the systematic review and meta-analysis says not at all. Malocclusion is a risk factor for periodontitis. Now, another big question. In case of angular bony defects, when you prefer orthodontic treatment, before or after regenerative therapy? Now, when there is an angular bony defect, and if you do regeneration therapy before ortho, then when they start ortho, this bone graft is going to be displaced. So always it is preferred that you should do regenerative treatment after ortho treatment, because anyhow, ortho treatment is going to change the architecture of the bone. So even the angular bone defect may improve with ortho treatment. But exception is if the orthodontist says that in that molar, I want an anchorage, but the bone condition is not favorable to give anchorage to put pressure. So only in these cases, we can prefer to have regeneration therapy before ortho treatment. And if you do the regeneration therapy before ortho treatment, you have to wait at least 6 to 8 months to start the orthodontic treatment. Now then let's come to the endoperio problem. Now this poor patient, referred from the Department of Public Health Dentistry, came to our department with the chief complaint of this proclined anteriors. There is spacing in upper and lower anterior. There is grade 2 mobility in 4-6 and grade 1 mobility in 3-6. If you see the OPG, this area is the aesthetic concern. There is endoperio problem in 4-6. There is furcation involvement and angular bone loss in 3-6. And this area, as we discussed with ortho people, they told it is very difficult to save in this case because of the spacing. We did the endo and perio treatment. This is for the 4-6 because around 10 millimeter of probing depth. We did endo fast and followed by perio. Let's see. This is how it was in the first visit. This is during endodontic treatment. This is just you see after 2 weeks of obturation. If you compare this periapical area and this periapical area, you can appreciate there is definite endodontic regeneration in the periapical area. Then this is the picture after periodontal, osseous bone graft surgery. You can appreciate the improvement. Now same in 3-6 region, let's see, there were furcation involvement and angular bone loss. That is the X-ray at the day of periodontal surgery. That is after 2 weeks of surgery, and this is after 3 months of surgery. You can definitely appreciate the amount of regeneration that is being occurred. Now, this was in the first visit, and this is after 3 months of interdisciplinary periodontics. As it was discussed, for this period, you will give a removable denture and follow after the orthodontic treatment will be over, we'll plan for the implants. So the orthodontic treatment is started. Now then comes the last part of the interdisciplinary approach is the prosto-perio approach. I think Nitin Dani sir has covered the crown lengthening part. Just I'll go 2 cases of the advanced part. Now this patient came to the department of prosto with a chief complaint of missing 1 and if you look at this area, there are a deficient ridge. I think cortical bone was lost. So that is what the CBCT shows. There was a retained root because the patient had a road traffic accident. So we planned for immediate implant placement. So atraumatically, we extracted the root, this thing, and we placed ostium implant along with the guided bone regeneration. So we used the BIOS bone graft as well as the PRF, and this is how it looks with X-ray after placement. Now this prosto people, they gave an excellent crown. So this is how it looks before and after. Now this is another case. There are multiple missing teeth in lower and upper. This is the OPZ. Now, if you look at the OPZ, there are hardly 3 to 4 mm in this area below the sinus. Let's see the CBCT. There is only 3.8 mm bone here in 7 region. Here 4.9 and here 9.2. So at least in these cases, you have to do direct sinus lift, and here you can go for indirect sinus lift or even without sinus lift if you a bit angulate it. And if you think of the lower, these area, there are atrophic ridge. Width was very insufficient. So in these cases, you have to do ridge augmentation. So there are many methods of ridge augmentation, but here we preferred the ridge splitting method because there are you can do ridge splitting, you can do GBR, you can do onlay bone grafting, but we preferred the ridge splitting because the onlay bone graft, you have another donor site morbidity and it goes undergoes resorption also. And if you think of GBR, there is expose of the membrane and there is infection also. But ridge splitting, there is around 90 to 100% predictability is there as per the systematic review and meta-analysis says. Because to place an implant, at least the width should be 6 mm, whereas here it was around 3 to 4 mm. So we did ridge splitting and placed 2 implants. Along with ridge splitting, we placed BIOS and PRF. So that is how the two implant looks. And this is the OPG after the sinus lift, because this sinus lift was done in 2018 during the integrate that we did in Kalinga Institute of Dental Science, where we did the live surgery, and it was done by Dr. Amit Benjamin. So that's why I didn't have the clinical pictures. So that is almost after 1.5 years picture with the 3 implants at place. So the prosto people are looking after the prosthesis. They have completed only the upper arch. So that is what they have completed for the upper arch, and maybe within a week they will be completing the lower arch. So that is how it looks when you build your interpersonal skill and you maintain the relationship with other departments. So these are all my colleagues who help all this interdisciplinary approach, and these are my postgraduates, those who are actually the player for this interdisciplinary approach. Let be the communicating with the patient. When we take the patient to the medical side or to the cancer institute, so they mostly play the vital role in this interdisciplinary approach. And these are my first year postgraduate students for whom this MDS orientation program is there. It's an excellent program as Journey Ahead in Periodontics. So this video is for all the first year postgraduate students, those who are watching this Journey Ahead in Periodontics.
यारों की यारी ऐसी बीमारी बड़ी नशीली.
I think I am in time. We can roll this for 3-4 minutes. I think he is Dr. Chang. He is a dentist. So that's why this video is there.
यारों की यारी ऐसी बीमारी बड़ी नशीली. गलती करे बिन बात के पीछे हटे ना इस राह पे. उल्टी चले बिन ताल के टेढ़े ही रहते ये रास्ते. हम जो मिले तो मिलते रहे, जो मिले सबको चलते रहे, जो चले पल पल पढ़ते रहे, जो बढ़े दुनियादारी लगती सजा. मस्ती ने छोड़ो छाटो नशा, नशा यूं ही हम तुम यहाँ.
So I think you all can enjoy this journey ahead in periodontics if you build and maintain relationship with all your friends, with all your interdepartmental friends. So the journey of periodontics will definitely be a wonderful experience. So be patient and trust your journey. And this is very important. Give yourself a great self-respect to know who you are and try to develop skills. So if you cannot critically analyze yourself that what I am lacking and what I am having, then you cannot develop the skills that is required. So thank you all for the patient hearing. Now it's Manju, over to you.
Thank you very much, Subhash. It was simply awesome. As usual, it's a feast to listen to you. I don't know how that 1 hour went off so fast. Wonderful presentation, crisp, clean, clear. I hope the PGs would have enjoyed. Wish when I was a PG, first year PG, we had somebody should have shown something like this. That would be very nice. Doesn't matter. And we are almost going to end. Just we are another 2-3 minutes. One question from Monica Oinam had given a couple of questions. Maybe it will be useful for many of the students.
Manju, I'm not able to stop.
Hello, can you hear me?
Yeah. I want to stop.
No, it's screen sharing stop हो चुका है सुभाष sir. हो चुका है.
Okay. So, what is the treatment of lichen planus? This is a question from Monica. Monica, because one of your case you said treatment plan for lichen planus. Can you please just briefly tell? Some student wants to know about it.
Yes. So that is what I told. We are doing the clinical trial. The drug is HCQS, hydroxychloroquine sulfate. That drug has been taken a lot of discussion in COVID also. So we are doing this since 1.5 years. That is hydroxychloroquine sulfate. So the dosage is 200 milligram BID for 6 months. So we have almost 90% cases we have succeeded in Indian scenario with treating oral lichen planus. At least I'm not telling about the lichen planus with systemic involvement. Only the oral lichen planus with HCQS. I think we have started seeing the improvement in burning sensation in 15 days to 1 month. And after 3 months, at least 70% of the ulceration are being reduced. So HCQS 200 mg BID for 6 months. And initially, you can give some like asymptomatic anesthetic gels and all just for this. But as a monotherapy, HCQS 200 mg BID for 6 months.
Right. Thank you. One more question, Dr. Subhash. Yes. Will there any side effects for corticotomy? This is a question from Monica.
Yeah, that's why corticotomy, there are many methods. Initially, it started with chisel, then burr, then the most non-invasive procedure is the pigeon where you don't have to reflect the flap. So mostly, if you don't use graft, there is a chance of dehiscence and fenestration. So that's why always we prefer to place graft in the corticotomy areas to prevent this dehiscence or the fenestration.
Right. Thank you very much, Dr. Subhash. On behalf of ISP Study Group Rohilkhand, ISP Study Group Chandigarh, indeed an excellent presentation. We would love to hear again and again. Thanks a lot for your precious time.
Thank you, Manju. It's I think it is the first time that we both as co-PG, you are moderator and I am speaker. I enjoyed this presentation, Manju. Thank you so much.
Thank you. And for all the students, tomorrow we are going to have a wonderful session again. Dr. Neeraj Deshpande is going to talk about how to keep your clinical records and other things. Excellent topic, most important for the student, and most important is research methodology. Imagine, all of you are going to do your dissertation and other things. These 2 topics are excellent. All of you log in. And for today, that's all we're going to have. Thank you very much for all of you, for your patience listening. And, you all been there for last 3 hours. It's been more than, we had 600, 700 participants who are listening to it live. So thanks a lot for all the participants. We'll see you tomorrow. Till then, goodbye. Thank you.
Okay, that's okay. So
okay.
And then there's a huge response. I've been told that we are close to probably over 900 registrations
Hi. As we all know, the periodontal disease is one of the integral part in dentistry, and the survey shows that 95% of the population are affected with periodontal disease. Here, we as a periodontist are taking an effort to get into the masses of the population to create an awareness among the general public and to create an impact as well as on the treatment line and to create an impact on the urban as well as the rural population in the coming years. So, we are creating an attempt as the President-elect of Indian Society of Periodontology to have a proper screening, charting and a treatment line for the patients and to have a benefit for them as such. Thank you.
Friends, periodontal disease leads to loss of teeth, and this loss of teeth has to be rectified by way of placing artificial teeth. And who else better than a periodontist would be able to restore the teeth, and this by way of dental implants. Dental implants has been aggressively being practiced these days into dental clinics, and periodontist is one of the best specialists in terms of practicing implant dentistry because he knows the details nuances and also the structures which are involved into placement of dental implants. So whenever you are experiencing dental loss or tooth loss, better go to a dental surgeon and go in for dental implant therapy. Dear friends, on behalf of the Indian Society of Periodontology, I wish to inform you that according to the data of WHO, we have 80% of our population which is affected with some or the other sort of periodontal diseases. Periodontal diseases are gum diseases and which increase in severity and lead to periodontitis, which ultimately leads to tooth loss. So, if we consider the huge population, which is if we consider our country as the second most populous country of the world, then definitely it's a huge healthcare burden over us. And if we consider the clinical data, it reflects that very less number of patients are being treated for periodontal conditions into our clinical practices. And this is basically because of the fact that we devote less time into diagnosing these conditions. Since these conditions are asymptomatic conditions, there is a great possibility of them being missed upon in the initial examination. So, I would request all of you to devote adequate time into diagnosing these conditions at the initial screening visits so that we would be able to provide a healthy periodontium and a healthy masticatory apparatuses to our patients. Thank you.
Aesthetic and smile designing is incomplete without the proper care of the pink. The judicious balance of white and pink is a prerequisite for aesthetic periodontal outcome. The various aesthetic periodontal surgeries, various aesthetic periodontal treatments like periodontal plastic surgery and even the newer advances in periodontal microsurgery are very handy in comprehensive aesthetic periodontal care for the patients.
India happens to be the diabetic capital of the world. India also has the largest population of hypertensive. Alongside India also have the highest prevalence of periodontal disease. Of late, the literature is flooded with the correlation of periodontal health and the systemic health. There have been enough evidence everywhere around the world with conferences, with workshops, with consensus meetings happening together, wherein it has been almost conclusively said that a poor oral health, a poor periodontal health can actually worsen the systemic health as well. So within the Indian perspective, Indian Society of Periodontology takes the lead, takes the charge and makes sure that all of our brother dentists are aware enough for not only diagnosing the patient from the periodontal point of view, but also giving him a good oral health so that he can live well, he can have a good systemic health also.
I'm a periodontist. A periodontist is someone who is a gum specialist. As we all know, teeth are held in the mouth because of the strong gums. And if the gums are not strong, the teeth will tend to fall off. In India, a lot of people suffer from gum diseases. Almost 80% of the adult population has some form of gum disease or the other. One of the points regarding gum disease is that it is entirely preventable. So if you visit a dentist regularly and get all the regular checkups and treatment done, you can have a teeth that will last for a lifetime. You need not wear any false teeth or dentures, and you can chew happily ever after and have a well balanced diet. The key to it is that you must have good oral hygiene practices, clean your teeth regularly, and visit a dentist and do all the treatment that is recommended by a dentist.
Now, we have our branch is periodontology, and basically it deals with the structure which is called as periodontium, which in common terms, which means the structures which support the teeth. Now, a structure which supports the teeth means that if tooth has to remain in oral cavity, the structure have to be in a healthy state. Now, we always, as you know, concentrate on treatments like orthodontics, that is treatment of malocclusion, root canal treatments. We have FPDs, RPDs, replacement of all these, missing teeth, which gets concentrated too much. But if we go to the background of this and we realize that, can we have an orthodontic treatment without a healthy periodontium? After all, movement of teeth is just based on bone and periodontal ligament, which is a part of periodontium. Have you asked any endodontist, would they do a root canal treatment in a mobile tooth? They will not, because after they see an X-ray and they see the extent of caries, the next thing which they see is the amount of support which is present. Take a tooth to them which is mobile, and the thing they will ask is whether the prognosis is good or not, whether we should do a root canal or not. So that means if you have to have a successful root canal treatment, the baseline is a healthy periodontium. You give RPDs, you give FPDs. Can you give a FPD on a tooth where the adjacent teeth are mobile? No. Can you give a RPD when you have the adjacent teeth mobile? No. So that means even in your prosthodontic treatment, the baseline for a healthy prosthodontic replacement is you have to have a healthy periodontium of the adjacent teeth. The fact that the basic principle of FPD, the Antes law, is not given in any prosthodontic terms, it is given in periodontal terms. It says the periodontal area of the supporting structure should be whatever it is. So that means the baseline of dentistry is the healthy periodontium. So whole dentistry treatment revolves around if you have a healthy periodontium. You cannot do any treatment in any department if the periodontium is unhealthy. So that means if periodontium has to be healthy, the branch periodontology has to be surviving. And dentistry just cannot survive without periodontology.
Good morning, everyone. This is Dr. Vishakha Grover. I am a periodontist by profession. Periodontist is a dentist who specializes in the care of gums around your teeth. In our country, gum diseases occupy the major proportion of oral health problems. Almost 90 to 95% in every 100 people are suffering from gum diseases. The worst part of these problems is that these are very silent or do not causing any signs at the early stage. Only in advanced stages, the patient may suffer from some pain, bleeding, or some unsightly appearance of the teeth. Recent research has highlighted that consistent inflammation in oral cavity may lead to other body problems also, for example, cardiovascular diseases or diabetes, etc. So this new dimension has been added to gum diseases, that they may act as general body health risks as well. So maintaining good oral hygiene with twice daily regular brushing is the only way to avoid these problems. But as a periodontist, I would like to stress upon the importance of regular visits to the dentist for checkup. Because whatever best practices we are maintaining, these visits will give a chance to the dentist to check on to how well you are maintaining your hygiene, and if there are any lapses, they can be made up. Even any new diseases, caries or gum disease, any new issues coming into the oral cavity may be detected at an earliest point of time and can be managed thereafter. So, maintaining good oral hygiene coupled up with the regular dental visits, in my view, is probably the best and the most sure way of preventing gum diseases and maintaining good oral health. I don't know when did you last visited your dentist, but today I will really ask on that book for your next appointment. Thank you.
Hi. As we all know, the periodontal disease is one of the integral part in dentistry, and the survey shows that 95% of the population are affected with periodontal disease. Here, we as a periodontist are taking an effort to get into the masses of the population to create an awareness among the general public and to create an impact as well as on the treatment line and to create an impact on the urban as well as the rural population in the coming years. So, we are creating an attempt as the President-elect of Indian Society of Periodontology to have a proper screening, charting and a treatment line for the patients and to have a benefit for them as such. Thank you.
Friends, periodontal disease leads to loss of teeth, and this loss of teeth has to be rectified by way of placing artificial teeth. And who else better than a periodontist would be able to restore the teeth, and this by way of dental implants. Dental implants has been aggressively being practiced these days into dental clinics, and periodontist is one of the best specialists in terms of practicing implant dentistry because he knows the details nuances and also the structures which are involved into placement of dental implants. So whenever you are experiencing dental loss or tooth loss, better go to a dental surgeon and go in for dental implant therapy.
Dear friends, on behalf of the Indian Society of Periodontology, I wish to inform you that according to the data of WHO, we have 80% of our population which is affected with some or the other sort of periodontal diseases. Periodontal diseases are gum diseases and which increase in severity and lead to periodontitis, which ultimately leads to tooth loss. So, if we consider the huge population, if we consider our country as the second most populous country of the world, then definitely it's a huge healthcare burden over us. And if we consider the clinical data, it reflects that very less number of patients are being treated for periodontal conditions into our clinical practices. And this is basically because of the fact that we devote less time into diagnosing these conditions. Since these conditions are asymptomatic conditions, there is a great possibility of them being missed upon in the initial examination. So I would request all of you to devote adequate time into diagnosing these conditions at the initial screening visits so that we would be able to provide a healthy periodontium and a healthy masticatory apparatuses to our patients. Thank you.
Aesthetic and smile designing is incomplete without the proper care of the pink. The judicious balance of white and pink is a prerequisite for aesthetic periodontal outcome. The various aesthetic periodontal surgeries, various aesthetic periodontal treatments like periodontal plastic surgery and even the newer advances in periodontal microsurgery are very handy in comprehensive aesthetic periodontal care for the patients.
India happens to be the diabetic capital of the world. India also has the largest population of hypertensive. Alongside India also have the highest prevalence of periodontal disease. Of late, the literature is flooded with the correlation of periodontal health and the systemic health. There have been enough evidence everywhere around the world with conferences, with workshops, with consensus meetings happening together, wherein it has been almost conclusively said that a poor oral health, a poor periodontal health can actually worsen the systemic health as well. So within the Indian perspective, Indian Society of Periodontology takes the lead, takes the charge and makes sure that all of our brother dentists are aware enough for not only diagnosing the patient from the periodontal point of view, but also giving him a good oral health so that he can live well, he can have a good systemic health also.
I'm a periodontist. A periodontist is someone who is a gum specialist. As we all know, teeth are held in the mouth because of the strong gums. And if the gums are not strong, the teeth will tend to fall off. In India, a lot of people suffer from gum diseases. Almost 80% of the adult population has some form of gum disease or the other. One of the points regarding gum disease is that it is entirely preventable. So if you visit a dentist regularly and get all the regular checkups and treatment done, you can have a teeth that will last for a lifetime. You need not wear any false teeth or dentures, and you can chew happily ever after and have a well balanced diet. The key to it is that you must have good oral hygiene practices, clean your teeth regularly, and visit a dentist and do all the treatment that is recommended by a dentist.
Now, we have our branch is periodontology, and basically it deals with the structure which is called as periodontium, which in common terms, which means the structures which support the teeth. Now, a structure which supports the teeth means that if tooth has to remain in oral cavity, the structure have to be in a healthy state. Now, we always, as you know, concentrate on treatments like orthodontics, that is treatment of malocclusion, root canal treatments. We have FPDs, RPDs, replacement of all these, missing teeth, which gets concentrated too much. But if we go to the background of this and we realize that, can we have an orthodontic treatment without a healthy periodontium? After all, movement of teeth is just based on bone and periodontal ligament, which is a part of periodontium. Have you asked any endodontist, would they do a root canal treatment in a mobile tooth? They will not, because after they see an X-ray and they see the extent of caries, the next thing which they see is the amount of support which is present. Take a tooth to them which is mobile, and the thing they will ask is whether the prognosis is good or not, whether we should do a root canal or not. So that means if you have to have a successful root canal treatment, the baseline is a healthy periodontium. You give RPDs, you give FPDs. Can you give a FPD on a tooth where the adjacent teeth are mobile? No. Can you give a RPD when you have the adjacent teeth mobile? No. So that means even in your prosthodontic treatment, the baseline for a healthy prosthodontic replacement is you have to have a healthy periodontium of the adjacent teeth. The fact that the basic principle of FPD, the Antes law, is not given in any prosthodontic terms, it is given in periodontal terms. It says the periodontal area of the supporting structure should be whatever it is. So that means the baseline of dentistry is the healthy periodontium. So whole dentistry treatment revolves around if you have a healthy periodontium. You cannot do any treatment in any department if the periodontium is unhealthy. So that means if periodontium has to be healthy, the branch periodontology has to be surviving, and dentistry just cannot survive without periodontology.
Good morning, everyone. This is Dr. Vishakha Grover. I am a periodontist by profession. Periodontist is a dentist who specializes in the care of gums around your teeth. In our country, gum diseases occupy the major proportion of oral health problems. Almost 90 to 95% in every 100 people are suffering from gum diseases. The worst part of these problems is that these are very silent or do not causing any signs at the early stage. Only in advanced stages, the patient may suffer from some pain, bleeding, or some unsightly appearance of the teeth. Recent research has highlighted that consistent inflammation in oral cavity may lead to other body problems also, for example, cardiovascular diseases or diabetes, etc. So this new dimension has been added to gum diseases, that they may act as general body health risks as well. So maintaining good oral hygiene with twice daily regular brushing is the only way to avoid these problems. But as a periodontist, I would like to stress upon you the importance of regular visits to the dentist for checkup. Because whatever best practices we are maintaining, these visits will give a chance to the dentist to check on to how well you are maintaining your hygiene, and if there are any lapses, they can be made up. Even any new diseases, caries or gum disease, any new issues coming into the oral cavity may be detected at an earliest point of time and can be managed thereafter. So, maintaining good oral hygiene coupled up with the regular dental visits, in my view, is probably the best and the most short way of preventing gum diseases and maintaining good oral health. I don't know when did you last visited your dentist, but today I will really ask on that book for your next appointment. Thank you.
Hi. As we all know, the periodontal disease is one of the integral part in dentistry, and the survey shows that 95% of the population are affected with periodontal disease. Here, we as a periodontist are taking an effort to get into the masses of the population to create an awareness among the general public and to create an impact as well as on the treatment line and to create an impact on the urban as well as the rural population in the coming years. So, we are creating an attempt as the President-elect of Indian Society of Periodontology to have a proper screening, charting and a treatment line for the patients and to have a benefit for them as such. Thank you.
Friends, periodontal disease leads to loss of teeth, and this loss of teeth has to be rectified by way of placing artificial teeth. And who else better than a periodontist would be able to restore the teeth, and this by way of dental implants. Dental implants has been aggressively being practiced these days into dental clinics, and periodontist is one of the best specialists in terms of practicing implant dentistry because he knows the details nuances and also the structures which are involved into placement of dental implants. So whenever you are experiencing dental loss or tooth loss, better go to a dental surgeon and go in for dental implant therapy.
Dear friends, on behalf of the Indian Society of Periodontology, I wish to inform you that according to the data of WHO, we have 80% of our population which is affected with some or the other sort of periodontal diseases. Periodontal diseases are gum diseases and which increase in severity and lead to periodontitis, which ultimately leads to tooth loss. So, if we consider the huge population, if we consider our country as the second most populous country of the world, then definitely it's a huge healthcare burden over us. And if we consider the clinical data, it reflects that very less number of patients are being treated for periodontal conditions into our clinical practices. And this is basically because of the fact that we devote less